ठीक है ना ये?
ये अगर खराब होगा तो
हाँ ये ठीक है।
प्लान खराब होगा।
प्लान खराब है, ये से हो रहा है।
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary health has all to do with community health, has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint gap mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID vaccine.
Hello.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030 can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the global action plan for healthy lives and well-being for all, to support countries to achieve an equitable and resilient recovery, and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remain unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used properly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement.
Mic testing.
Capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation, UHC, provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participation spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent
Hello.
communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. Influential stakeholders such as academia, medical doctors, and government actors derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
Check.
Santa bastante depurali la cittadini, ma solo tanto cittadini. Lì sta avanzare a cadere di te, non si va tanta ci vai.
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Heart Bazaars as a platform for the primary healthcare services closer to people who need it the most.
गांव से आए सयान सजन मन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, पूरे स्वास्थ्य संबंधी समस्याओं का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें।
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है, जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं, उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिलती है।
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Heart Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CH थे।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहां तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में यहाँ हमारी वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as Ashas, or community level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते हो तो बाजार में जाने से क्लिनिक खुला है, वहाँ जाके चेकअप कराइए, सब कुछ बोलते हैं।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
मैं तो परेशान बहुत, ये जितना मन सुस्ता, ये पैर में सुस्ता था, ये पूरा शरीर सब मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोल के, अभी सबसे वो दवाई मन लेता, अभी थोड़ा ठीक था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं और टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Bazaar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health. Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
Lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation, or UHC, provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind. Tribal communities residing in the core of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead.
Check. Morning to everyone, ladies and gentlemen, namaskar. Good greetings of the day and good greetings of the event. A delight and honor to be greeting you all on behalf of the Ministry of Health and Family Welfare, Government of India, and on behalf WHO Southeast Asia Regional Office. Thanking each one of you for having joined us. A special thank you to our online distinguished speakers, the participants and delegates joining us from different geographies, time zones. So big thank you to them for taking our time and being a part of the discussions which we are just about to begin. Thank you and welcome to the Global Conference on Digital Health. Would like to request you all to kindly take your seats. Also to have your mobile phones on the silent mode or in the meeting mode. Would just like to quickly, because we intend to start on time, the first session as we start the inaugural session, that's going to be at 9 o'clock. We still have some 5 to 10 minutes. So just thought of just briefing you of the entire 2 days, how we are scheduled and planned for these 2 days. One, of course, I would like to once again request people who are inside, hope you have registered yourself. In case you have not, you're requested to please have yourself registered. Also register yourself for the National Public Health Observatory and Health Emergency Operations Center visit. That's by the Ministry of Health and Family Welfare, Government of India. You have to register yourself also for this visit. So please ensure that you have registered yourself for, of course, the conference and of the visit. Also, if our online speakers and delegates are with us, would like to mention, we encourage a lot of participation from the audience. So, of course, from our in-person delegates and participants present with us, any questions we have, except for the inaugural session, there's going to be a window towards the Q&A. We encourage taking questions from you, as well as from the online speakers and the online delegates and participants. They are requested to kindly post their questions in the chat box, and our representatives will accordingly take those questions and pass it on to the moderators. So that's a request to our online delegates, speakers, participants. For the rest of the people who are present in person, we are going to be passing on the mic and taking questions from you here. And today evening, ladies and gentlemen, we have also a cultural event, a cultural evening, giving you a little taste of India through its dances, through its various performing arts. Hope you're going to be enjoying that. As we start in a while from now, these 2 days is going to be almost going back to back with the sessions, with a few breaks of tea breaks and the lunch break. We have the inaugural session, and then, of course, the last session tomorrow, that's going to be the closing session, summing up, connecting the dots. Apart from that, we have a ministerial session tomorrow morning, starting again at the same time. And then we have our 5 technical sessions. As mentioned in the technical sessions, we are going to be taking questions from all of you. There's a small window of 10 to 15 minutes, which we have for taking questions from your end. So good, productive sessions and discussions with all of you, requesting you all to kindly be taking your seats and having your mobile phones on the silent mode or on the meeting mode, please. Thank you. Ladies and gentlemen, just to apprise you, though all of you stand in safe hands, but as they say, taking precautions is always better than care. So we have also outside medical kiosk in case of any emergency. We have it outside just to apprise you all towards that. And we're really thankful also to the honorable ministers and senior representatives from the G20 countries joining us. As you know that India is leading the presidency of G20 this year, and we are having meetings across sectors. As we take it in the health sector, delighted and honored to have the presence of the honorable ministers. Though we have a separate ministerial session, which is going to be happening tomorrow. Even in today's session, the session just after the inaugural, again, we have some of the honorable ministers from the G20 countries who are going to be part of that session. Ladies and gentlemen, may I once again request people in the hall to kindly take your seats. Please make yourself comfortable. We are going to be starting in a while from now. If you can take your seats. Also, a humble request to have your mobile phones on the silent mode or on the meeting mode, please. Once again, just ensuring that you've already registered yourself. In case you've not, you're requested during the break time, have yourself registered. Also for the field visit, which is planned by the Ministry of Health and Family Welfare to the National Public Health Observatory and the Health Emergency Operations Center, you're requested to kindly have yourself registered in case you're wanting for this, interested in the field visit. And then we have the various kiosks, the various partners who are exhibiting here, a lot of knowledge sharing towards the work which they are doing, towards the best practices which they have been adopting, the digital health initiatives and technologies are at display, the processes, the strategy which they are adopting, that is there in the kiosk which you see here in the hall. And we also have few booths which are outside in the pre-function area. Ladies and gentlemen, once again, a very humble request to the people who are standing. Kindly take your seats, for we already have our distinguished speakers, the leaders of the inaugural session joining us. They already in the premises. They're just going to be joining us in the hall. And as they're here, we are going to be good to be starting with the inaugural session. Just requesting you all once again to be seated, please.
all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development, all ready to go, will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID vaccine, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation.
Ladies and gentlemen, we solicit your support in starting our session on time. If you can be seated, please.
To disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
Once again, may I request you, ladies and gentlemen, to kindly take your seats. We are ready to start with our inaugural session. Just awaiting your presence at your respective seats, please. Can I request people who are standing on the sides in the aisles, if you can please be seated. Ladies and gentlemen, our distinguished speakers of the inaugural session are already here. We're just requesting you all to take your seats so that we can start. Thank you so very much for your time and attention. Excellencies, ladies and gentlemen, good greetings of the day and good greetings of the event. On behalf of the organizers, the Ministry of Health and Family Welfare Government of India, and on behalf of WHO Southeast Asia Regional Office, I welcome all our online and in-person present esteemed speakers, delegates, participants. Welcome to all of you to the Global Conference on Digital Health. And ladies and gentlemen, this two-day meeting is a preeminent gathering of the global health leaders, of the policymakers, development partners, the digital health innovators and influencers, academicians, researchers, philanthropists, financial institutions, NGOs, and the other institutions, organizations, stakeholders joining us in this two-day meet to have an open dialogue and seek a consensus on the shared key initiative. Create a shared agenda driven by the global digital initiatives, technologies, and take the universal health coverage to the last citizen. So as we work on this very objective and we open the doors to this open dialogue with the inaugural session, we have the leadership of the two strategic partners from the Ministry of Health and Family Welfare and from WHO who are leading us today. In fact, they have been working towards these joint efforts towards giving an impetus to global collaborations and actions in the implementation of digital technologies, innovations, and initiatives, which can accelerate our progress to universal health coverage. So as we thank them for joining us, I would like to now take this opportunity of inviting them to please take center stage. Ladies and gentlemen, leading us is our Honorable Minister, Dr. Mansukh Mandaviya ji, the Honorable Union Minister of Health and Family Welfare. He's also the Minister of Chemicals and Fertilizers. Unfortunately, he's not been able to join us in person, but he has sent across his good wishes. And we also have a video message from him, which we are going to be playing in the course of this session. Please now join me in inviting on the dais Dr. Poonam Khetrapal Singh, Regional Director, WHO Southeast Asia Region. Mr. Rajesh Bhushan, respected Secretary, Health and Family Welfare. Mr. Manoj Jhalani, Director, Department of Universal Health Coverage, Health Systems, WHO Southeast Asia Region. Mr. Love Agarwal, Additional Secretary, Ministry of Health and Family Welfare, Government of India. And Professor Alain Labrec, the Director, Digital Health and Innovation, WHO Headquarters. We also welcome DPM Dr. Prem, WHO from the WHO Regional Office, Southeast Asia. Thank you very much for joining. So at the very onset, I would like to request and invite Mr. Love Agarwal, the Additional Secretary in charge of International Cooperation, International Health, Telemedicine, E-Governance, Metadata and Data Standards, Electronic Health Records, Public Health and Public Health Institutions, Integrated Disease Surveillance Programs, Emergency Medical Relief, also the COVID Digital Platform, and many of you during the COVID times would have seen him on TV. He was the spokesperson and he's responsible for the COVID-19 management. He's also the focal point for the G20 health track. Thank you for joining us and leading us, and I request him now for his welcome remarks.
Honorable Dr. Mansukh Mandaviya, Union Minister of Health and Family Welfare, Government of India. Honorable Mr. Joe Bijang, Honorable Minister of Health from Marshall Island. Dr. Poonam Khetrapal Singh, Regional Director, Southeast Asia Region. Shri Rajesh Bhushan, Secretary Health, Government of India. Mr. Alain, Director, Digital Health and Innovation, WHO Headquarters. Shri Manoj Jhalani, Health System, Sero Region, Director, Health Systems. Members of the esteemed organizations, delegations from all the countries, all WHO regions, distinguished participants, invitees, ladies and gentlemen. I would like to welcome you all to the Global Conference on Digital Health, Taking Universal Health Coverage to the Last Citizen, a co-branded event under India's G20 presidency, organized by WHO Southeast Asia region in collaboration with Ministry of Health and Family Welfare, Government of India. On behalf of Government of India, I express my gratitude to all of you for having accepted our invitation and taking time to join this conference. COVID-19 pandemic has undoubtedly served as a pivotal catalyst for greater adoption and implementation of digital solutions. Every country in the world has witnessed firsthand the potential for digital technologies as a game changer in health service delivery. Colleagues, India has introduced World Health Assembly resolution on digital health at its 71st session in Geneva, which was successfully adopted by member countries and spurred global action on the agenda of digital health. Post creation of a Department of Digital Health and Innovation at WHO headquarters, a global strategy on digital health 2020-25 in line with the 2030 Agenda for Sustainable Development Goal has also been developed. While governments around the world are already making significant investment to leverage technology successfully to improve health outcomes, there's still a long way to go in order to achieve sustainable and scalable outcomes. India, accordingly, under its G20 presidency, has prioritized digital health as a specific priority in its health working group, namely digital health innovation and solutions to aid universal health coverage and improve healthcare service delivery. It aims to align, support, and converge efforts, investments, and promote the concept of digital public health goods to aid universal health coverage and ensure democratization of digital health solutions, innovations with specific focus on low and middle income countries. Aligned with India's G20 agenda on digital health, the objective of this global conference is to bring together global leaders, health development partners, policymakers, digital health innovators, academia, and other stakeholders at a common platform to accelerate our progress towards universal health coverage, duly leveraging technology, and to further deep dive and deliberate on accelerating the implementation of connected digital health initiatives and intervention as a cornerstone for building resilient health systems. Creating a framework of converging ongoing digital initiatives across the world and work towards bridging the existing digital divide amongst nations through promotion of curated digital solutions available as common goods. Further, also to promote standard-based, scalable solutions, including the use of cutting-edge technologies in health. I am sure that this global conference on digital health will be yet another milestone and an opportunity for all of us to draw lessons, learn best practices from one another, to move together, to grow together, and shine together for a brighter future. With these words, on behalf of Government of India, I would like to once again welcome you all for this conference. Thank you. Thank you very much.
Thank you, sir, for further setting the tone and the context of this meet with your welcome address. And now would like to invite Professor Alain Labrique, Belgio-Indian born in Bangladesh. So he's well acquainted with the populace and the challenges which are here. He is an innovator, entrepreneur, policy advisor, digital health thought leader, presently Director, Digital Health and Innovation, WHO headquarters. I request him for his opening remarks. Would also like to mention that he's also been the professor at the Johns Hopkins University.
Thank you so much. It's always embarrassing when your introduction is almost longer than your remarks. So, distinguished guests, Honorable Minister, Secretary, respected WHO RD, and directors, and honorable members of Government of India, colleagues from around the globe. It is my distinct privilege to be here sharing the stage with such amazing people and to have the honor of 2 days of what I know will be interesting discussions that lead to real changes in the world. You represent some of the top thinkers and architects of digital health. But more importantly, every single one of you in this room has rolled up their sleeves and actually converted plans into action. So we should not call this so much as a conference as an action planning session. How can we together develop and execute a strategy for lasting and impactful digital transformation of the health sector? We are currently faced with an important opportunity as our member states think about the lessons learned from the pandemic. There's a growing recognition that we need to do things differently. Going back to business as usual is not going to create the pandemic resilience that we need when we need to have it. We're not going to close the gap in progress towards the health SDGs that emerged as a result of so much of global health resources being diverted towards responding to the pandemic. We're also not going to meet the needs of aging populations and the tsunami of non-communicable diseases while continuing to address the threat of maternal, child, and reproductive health issues unless we harness the power of digital to its full potential. Today's conversation is about a shift, one that will be familiar to many of you, as we've all been calling for this shift for over a decade now. Finally, policymakers and funders alike are hearing our call and are also supportive of it. That shift is away from siloed, disconnected, vertical, stopgap digital solutions towards an ecosystem where government can be in the driver's seat, planning for a person-centered health system, powered by digital solutions which help both the person, the provider, and the policymaker. Investments go farther and are more sustainable and can yield better experiences and results if we take the time to develop clear national goals and strategies. If countries have access to architectural roadmaps that enable those goals, if systems are developed using global standards and are also interoperable, not only do we unlock continuity of care within a health vertical, but also enable people to access their right. And I repeat this, it's their right, which is right now reserved to a privileged few around the globe, but it's their right to continuity of care across their health journeys. The types of plans and investments we will discuss over the coming 2 days not only puts governments in control of the vision and direction of these digital strategies, but people in control of their own health and wellness. In recent years, we have worked together to develop communities of practice, networks of implementers, policymakers, and even of donors. We've developed principles for digital development, principles for donor alignment. We've developed a vocabulary around digital health. We've conducted rigorous research that has led to formal WHO guidelines. And we've built maturity models to understand where countries are in their transformation journey. We've even begun addressing important issues around equity and inclusion, recognizing that the digital divide is real. And there is a risk of leaving people behind as we forge ahead in a connected world. We have a global digital health strategy, and nearly half of the countries of the world have a costed digital health roadmap. This is all wonderful progress, and we should celebrate these successes. Just seeing what our host country, India, has achieved in the last decade alone is cause for celebration. But we have some ways to go. We are gathered in the next 2 days to develop that action plan, to define the road ahead, to develop new and better ways to work together, understanding the roles, strengths, and mandates that each of us have, the resources that we need to enable this rising tide that will lift all boats, making sure that countries who could benefit from digital health can do so. Over the next 2 days, we have some key conversations to have. So to the extent that you can, I'm going to ask you to disconnect from whatever is happening outside of this room. and connect to the critical discussions that are happening here. None of us is here by chance. And I know Amani has been working very hard to get each of us in this room together. So please let us benefit from each other's presence. We have a number of signposts that we will pass as we travel this road together over the next 48 hours, beginning with some key words of inspiration from our special guests from the Government of India and WHO colleagues. But we will then unpack some exciting, tangible lessons from digital health work that strengthens PHC and UHC before rapidly coming back to the foundations. Before we talk about architecture and building things, we need to have the ingredients for success, what we're calling strategic enablers. We'll hear from several ministries and one of the largest implementation networks of digital health, AHIN. We then move to talking about the technology enablers, key building blocks that can help ensure digital health success by investments in the build to standards that enable interoperability. But I want us to please keep things firmly grounded in real world examples, learning both from the accomplishments, but also the frustrations and the challenges that we have all faced in trying to achieve digital transformation. We ask that we all see this forum as an opportunity to speak frankly and learn from the wisdom that comes from things that don't work as planned, in addition to things that do work as planned. Tomorrow, we move towards digital health interventions themselves, having talked clearly about the enablers today, and lastly, some possible mechanisms that can enable us to work more effectively as a community, unpacking how we catalyze investments and develop a corpus of building blocks or digital health global goods by expanding how we think about these tools beyond pieces of software to also include policy and legal frameworks and training and standards and architectural blueprints that need not be reinvented in every country, but could be adapted before being adopted. Digital health is a powerful tool in our box of strategies to improve, strengthen, and save lives. How can we achieve synergy by working collectively on our shared vision of a better future? We need a collaborative and coordinated effort from all stakeholders, including governments, civil society, the private sector, and academia. This conversation provides a unique platform to craft such a collaborative and knowledge-sharing ecosystem. And we are confident that our discussions over the next few days will lead to concrete actions that will improve the health and well-being of millions of people around the world. Thank you, shukriya, and warm welcome.
Shukriya, Professor Alain, and thank you for inspiring everyone for the very importance which each and every person present in this hall and also joining us online has towards a more impactful digital transformation of the health sector. Thank you for sharing your views on the shared responsibility and the need towards this digital transformation of the health sector. And now would like to request Mr. Rajesh Bhushan, our respected Secretary, Ministry of Health and Family Welfare, to further please set the tone and the context with the very objective of this conference. Would like to mention, ladies and gentlemen, I'm going to be very short in that. He has a very distinguished public service of more than 36 years. He earlier has also worked in the rural ministry towards rural development, and we look forward to his views and strategies and approach which the ministry is adopting towards the digital transformation of the health sector. Request, respected Secretary, sir.
Honorable Union Minister for Health and Family Welfare, Dr. Mansukh Mandavia, who would be joining us virtually. Honorable Dr. Poonam Khetarpal Singh, Regional Director, WHO Southeast Asian Region. Professor Elaine, Director, Digital Health and Innovation, WHO Headquarters. Mr. Manoj Jhalani, Director, Department of UHC, Health Systems, WHO CRO. My colleague in the ministry, Mr. Love Agarwal, Additional Secretary. Ladies and gentlemen, it is indeed a pleasure to be here on the occasion of this global conference on digital health, taking the UHC to the last citizen. While digital health interventions have been there in standalone, isolated fashions during the last 1 decade in the sector of healthcare, taking healthcare to the last mile, it was the pandemic which made us realize that digital health solutions add value and must be institutionalized. They can no longer exist as independent, standalone, one-time interventions. So it needed a pandemic, that to a global pandemic, to bring home this point that one needed integrated digital health solutions, which would bring all these standalone interventions which have happened earlier in the past, which would happen as we traverse this road ahead. They must be working in sync and in harmony. So this is what the pandemic has taught us when we look back to the last 2.5 years of our tackling the various challenges posed by the pandemic. So let me start first by the Indian experience, and that itself is a fairly sort of longish journey. So I would try to compress it. And then let me also talk of certain generic thematic issues that we need to address and grapple with. The Indian journey during the pandemic, there were 4 major public health digital goods which were created. The first one was Arogya Setu. Now, Arogya Setu is a digital solution which also has an accompanying mobile app. It was developed as a surveillance tool because once you have a widespread pandemic, you have large-scale lockdowns, there is disruption of human movement as well as various supply chains. How do you keep track of the infection or the infected people or their close contacts? And how do you then devise containment strategies? So these multiple challenges were addressed by this Arogya Setu application. And as the infections declined, then Arogya Setu was repurposed to help people in other ways to take health-related decisions. So that is the great value of any digital intervention or application. As the scenario changes, you can very rapidly with agility, and agility is important when you are tackling technology change or a changing pandemic. So with agility, you can repurpose. So this was the first public health digital good that India produced. And this concept itself is important. When we say digital public health good, it means that that digital good is for everyone. Although someone in India may have created it, it's available for the global community. It is open source, and we do not very jealously protect the intellectual property right related to that digital public health good. So it must be available globally. Coming back to the second major development that happened during the pandemic, that is the development of e-Sanjeevani. E-Sanjeevani is a digital telemedicine platform that enables patient to doctor consultation, doctor to doctor consultation, and patient to doctor assisted consultation, where you have a health worker sitting alongside the patient and describing her symptoms to the specialist doctor who is at a remote end. And ladies and gentlemen, today eSanjeevani is world's largest telemedicine service with more than 100 million teleconsultations which have already been done. And these teleconsultations start, there is a hierarchy. They start from the cutting edge grassroots level, which is a health and wellness center. And then they go all the way up to a medical college hospital. The third major digital public health good that was created is something called the iGot digital platform. This was meant initially for training and orientation of health workers and doctors during the pandemic. We realized that at sub-district level, in India, we have this hierarchy of primary health center, community health center, subdivisional health center, and district hospital. We realized that at the sub-district level, there was no critical care specialist. There was no intensivist. Who would intubate the patient? Who would take a decision whether the patient is to be put on oxygen or not? If the decision is to put the patient on oxygen, what should be the oxygen flow? Should it be 5 liters per minute, 10 liters per minute, 30 liters per minute? Is it high flow nasal cannula that is required? So all these issues were addressed by developing digital training modules, which were uploaded onto this iGot platform, and our general duty medical officers who are, UG degree holders, undergraduate doctors who were there at sub-district level facilities, they utilized this digital platform and got trained and were evaluated also on the same platform. So this was the third development in the shape of a digital public health good. And the last and the most well-known is the COVID digital platform, which tracked each individual COVID-19 vaccination event in the country. And currently, it has tracked more than 2.2 billion COVID vaccinations across the country. Each vaccination generates a QR coded digital certificate, which can be downloaded on your mobile and can be shown wherever it is required to be shown. So COVID digital platform not only tracked each and every vaccination, it permitted hospitals and every vaccination center to pre-publish a calendar of vaccinations. They could say that I have 3 COVID-19 vaccines with me, and this is my schedule. Day 1, I would have X number of doses, day 2 of A number of vaccine, Y number of doses of B vaccine, Z number of doses of C vaccine. And people could look at that calendar, decide which vaccination center to go to, pre-book an appointment, and get vaccinated. Those of us who were not so technology savvy could saunter into a vaccination center and get registered digitally then and there. So it was it is still citizen friendly, and it kept on repurposing itself as the pandemic evolved. So these were the digital public health goods that India created and offered globally for anyone who would require them to be used after repurposing. Having very briefly shared with you the India example, there are multiple other stories of IHIP, which I hope today and tomorrow someone would discuss with you. It's an integrated disease surveillance platform, which presently on real-time basis monitors the emergence and re-emergence of 33 diseases across the country, data being fed from 3 different sources, from labs, from grassroots workers, auxiliary nurse midwives, from medical officers, so on and so forth. But coming back to the point that I mentioned at the beginning of my speech, that we now need to look at certain generic challenges that all of us must jointly address if this journey is to proceed ahead at a fast pace. The first such challenge is that each country must have its own digital health strategy. That digital health strategy document must be a dynamic document, must evolve and change with the changing times, changing challenges, changing technology. There is a template that WHO has provided by creating a global public health digital strategy. So once each country has a health digital strategy, each country must benefit by being part of networks which are collaborative in nature of different skill sets within the digital health space. Not all skill sets exist within the government. There are skill sets outside. When the government created iGot in India, it was not as if people sitting inside the government created it exclusively. There were people who were outside government. They also collaborated. That is how the digital platform got created. So globally, we need to create these networks of collaborating partnerships which would help national capacities to take their digital health policy document forward in terms of implementation. So now I have laid before you 2 thematic areas: having a digital strategy or a document or a policy which is national in nature, and having a network which would bring synergies and add value to national efforts. The third important thing is that whatever policy or strategy that we create nationally and globally must ensure that these digital interventions must talk to each other. At times, when we create something, we take immense satisfaction in creating it. In Hindi, or rather in Sanskrit, there is this phrase, Swantah Sukhai. I am happy because I have created something. Without asking the fundamental question, are others happy because of what I have created? So this has happened in digital space also. I have created something, Love has created something, Madam Poonam Khetarpal Singh has created something, but whatever we have created are not talking to each other. They are not integrated. They are not helping people at large. So that is where the concept of interoperability comes in. Whenever we create these digital solutions, they must talk the same language. Otherwise, that's how internet works. So why can't the health internet evolve in that fashion? So this was the third point I wanted to bring before you. And this is the lowest hanging fruit. This can be done immediately, provided the global community decides to do it. The fourth generic challenge that we face is creating the skills necessary, creating training programs, creating capacity building institutions within the government, outside the government. And lastly, governments must show their intent by putting sufficient financial resources to back these commitments. And this holds true not only for governments, but for organizations outside government. If they want this radical change to sustain, they will have to put their money where their mouth is. So these were certain things that I wanted to bring before you for further discussions today and tomorrow. I once again thank all of you for having provided me this opportunity for sharing my thoughts with you. Thank you. Namaste.
Thank you very much, respected Secretary Sir, for guiding us and also sharing the very impressive, massive and very impactful digital footprints which India casted, especially during the COVID time. And India, in the very spirit of Vasudhaiva Kutumbakam, made it available, and it was actually for global good and welfare for all. Also further guiding us and certain generic challenges which we need to address so as to bring in more speed, scale and pace to our efforts. Thank you, sir. And now would like to request Dr. Poonam Khetrapal Singh, the Regional Director, WHO Southeast Asia Region. She, ladies and gentlemen, needs no introduction. Very impressive, massive footprints in the public sector. Earlier, she's also worked with the World Bank. She's was with the WHO headquarters for almost 20 years before she took over as the Regional Director, WHO Southeast Asia Region, and this is her second term. We look forward to her guidance, and I request and invite her for her inaugural address.
His Excellency, Dr. Mansukh Mandavia ji, Honorable Union Minister of Health and Family Welfare, whose message you will be hearing shortly. His Excellency, Minister of Health from Marshall Islands, Mr. Rajesh Bhushan, Secretary, Ministry of Health and Family Welfare, Government of India, Mr. Agarwal, Additional Secretary, and other staff from the Ministry of Health and Family Welfare, representatives from member states, from different regions, distinguished partners, and many of you are online. In fact, we find more online than within this room, and WHO colleagues, both from within the region and outside the region. A very good morning to you, and welcome to this global conference on digital health. Subsequent to the discoveries of diagnostics, of antibiotics, and of vaccines in the 20th century, digital health is the latest addition to these list of breakthroughs. Digital health can significantly improve the quality, access, affordability, and sustainability of patient-centered health services and effectiveness of disease management, as was highlighted by the Secretary Health and as the COVID-19 experience showed to us. It highlighted the importance of the application of digital technologies in health and the potential of health systems to prevent disease and enhance service delivery at the national and the subnational levels. Digital health, therefore, is critical today, and its potential is immense. You've heard a lot about it, but let me highlight a few things. It can democratize healthcare, which I think is extremely important. It enables one's digital health identity to be used as a digital health passport for a range of healthcare services. It can use the benefits of innovation, including artificial intelligence, novel diagnostics, measurement of clinical outcomes, and adherence to evidence-based interventions, such as the rational use of antimicrobials. It can enhance the efficiency and effectiveness of health services through the use of patient-centric electronic health records. It can support data-driven clinical decision-making and inform policy interventions. Most of all, digital health is about finding ways to fast-track what our region has been working intensely towards since 2014, which is universal health coverage. The scope of e-health is enormous. According to the World Bank, about 40% population of South Asia is using the internet. The World Economic Forum reports that around 2/3 of the population of Asia are using mobile phones. Both the public and private sectors are active in developing virtual health service delivery platforms, and there is more acceptance in the use of digital technologies today than ever before. For many years now, the WHO Southeast Asia region has recognized and embraced e-health potential. All but one of the 11 countries of the region have digital health strategies, plans, and architecture blueprints at various stages of development, revisions, and implementation. Over the course of recent years, countries of the region started to gain vast experience with practices on telemedicine interventions. You have heard about India's initiatives, and let me not repeat them. I would only mention one, which is eSanjeevani, which has, as shared by the Secretary Health, registered more than 100 million teleconsultations. Countries are also realizing the boundless power of learning networks, highlighted by Professor Alim. In Nepal, Raft Network is working in collaboration with the BP Koirala Institute of Health Sciences to support distance learning and to have remote interaction teleconsultation and provide services by connecting healthcare workers at the peripheral level to those who are experts at the tertiary level. In pursuance of the 4 strategic objectives laid down by our strategy on digital health, WHO has created a few important products and platforms. And let me share a few. 1, the Digital Health Atlas. 2, WHO Clearinghouse, which goes further by providing an inventory of digital solutions that have been validated by teams of experts. Digital Health Infrastructure Investment Guide, which is a comprehensive handout that provides a step-by-step approach to building digital health ecosystems. We have moved on to an interesting cusp of the evolution of digital health. We are witnessing a transition from health systems to ecosystems, from digital technologies to exponential technologies, which are increasingly being used in healthcare. While the canvas is large, I would like to mention 4 priorities that we need to pursue. First, establish a global institutional mechanism for digital health, and this is extremely important for LMICs. Second, focus on the key elements of a coordinated approach to address the challenges of UHC through responsible deployment of digital technologies and emerging technologies, building on our global digital health strategy. Third, develop a standard-based and open reference architecture of digital health ecosystem with strong safeguards for privacy and for confidentiality. This enables several countries to leapfrog to the state-of-the-art digital environment that provides health services in a person-centric manner. Fourth, build on institutional framework that can oversee the development of the global digital health mechanism. It should be a platform that can bring together all the partners to align and synergize their efforts on digital health. Insufficient cybersecurity, interoperability, evidence and evaluation, clinical and consumer engagement, and complex policy environment continue to be barriers to, and that restricts progress. Further, the region is encountering a twin challenge of accelerating progress towards UHC and establishing citizen-driven digital health ecosystem in all countries. Together, we can find ways to surmount challenges and realize the promise that digital health holds today. The twin challenge has been the trigger to design the global conference, which aptly seeks to focus on digital health initiatives through the lens of UHC. The aim is to shift focus from strategy to achieving a global consensus on a plan of action, which you would be working on, and which produces impactful results on the ground in member states. I am hopeful that this important meeting will provide you the platform to hold meaningful discussions and to accelerate the implementation of digital health initiatives, including establishment of enablers at population level, how to enhance investment, how to explore the potential of delivering and sharing digital health solutions in an ethical, secure, reliable, equitable, and sustainable way. Leveraging India's presidency of G20 and the prolific actions and commitments of previous presidencies of WHO the WHO Southeast Asia Regional Office and the Government of India are joining efforts to give an impetus to global collaboration and actions in the implementation of digital health technologies and innovations. Digital health is key to attaining sustainable development goals and improving the health and well-being of citizens all over. The WHO Southeast Asia remains committed to leveraging digital health as a key component of the drive towards universal health coverage, which it has pursued as a flagship priority since 2014. With this, I wish you all productive deliberations. Thank you so much.
Thank you, ma'am, for your guiding and insightful views on the very imperatives and need, the potential of digital health, WHO's strategy and approach to digital health, and further guiding us with your very valuable and constructive recommendations as we move from health systems to health ecosystems, digital technologies to exponential digital technologies as a drive towards universal health coverage. Thank you, ma'am. And now, ladies and gentlemen, we have the pre-recorded video message from our Honorable Minister of Health and Family Welfare, Shri Mansukh Mandavia ji. If you can please play the message.
Namaste. I would like to welcome all the excellencies, dignitaries, and delegates from WHO member states, G20 countries, and international organizations participating in this co-branded event with India G20 presidency on Global Conference on Digital Health, taking universal health coverage to the last citizen. Organized by WHO Southeast Asian region in collaboration with Ministry of Health and Family Welfare, Government of India. Allied with India's G20 agenda on digital health, the objective of this event is to bring together global leaders, health development partners, policymakers, digital health innovators, academia, and other stakeholders at one platform to accelerate our progress towards universal health coverage. India's commitment to universal health coverage encompassing digital intervention is evident from national programs like reproductive child health care, NICSHI, TB control program, integrated disease surveillance system, hospital information system, and many more, which have been assisted with technology at various levels. Digital health is a great enabler in delivery of healthcare services and has the potential to support the overall universal health coverage targets. India has adopted a two-pronged approach focused on promoting digital health solutions through policy frameworks, while also creating a digital health ecosystem. The national health policy set a strong foundation for various path-breaking digital health interventions, which focus on not just availability, accessibility, and affordability, but also equity of health services. Under the able supervision of Honorable Prime Minister, Ayushman Bharat Initiative was launched, which provides an overarching framework to revolutionize primary, secondary, tertiary healthcare services, duly leveraging digital solutions through its 4 associated pillars. Under Ayushman Bharat Health and Wellness Center, access to quality primary healthcare services is being strengthened through establishment of 150,000 health and wellness center to provide preventive, promotive, curative, rehabilitative, and palliative care. Leveraging digital health at these centers, telemedicine services are being provided. Second pillar of Prime Minister Jan Arogya Yojana provides health insurance to 500 million citizens for identified secondary and tertiary health services, free of cost, in a cashless and paperless manner, making it the biggest government-funded health insurance scheme of the world. The scheme not only ensures access to a wide range of services, but focus on ease of access by leveraging digital solutions. Through Ayushman Bharat Health Infrastructure Mission, an outlay of 641.8 billion rupees has been sanctioned with a focus on strengthening surveillance through expansion of digital disease monitoring platform, creating a network of integrated public health labs, National Institution for One Health, and research network across the country. Fourth pillar of Ayushman Bharat Digital Mission seamlessly interviews these initiatives to create continuity of care and is working towards establishment of a digital health ecosystem. The foundation of ABDM was laid with the launch of National Digital Health Blueprint in 2018, with the prime principles of capture data one and use many times, and move from silos to system. NDHB provided an architecture framework for effective implementation of digital health interventions. Implementing the principles of NDHB, we launched the National Digital Health Mission, now known as the Ayushman Bharat Digital Mission, to create accessible, efficient, and inclusive digital health ecosystem in India. India adopted digital health as a critical intervention from the onset of the pandemic, given the volatile natures of the virus. As part of our data-driven and digital-first approach, we deployed cutting-edge intervention, leveraging quick, contactless, and safe technologies to strengthen our pandemic response. We developed multiple portals to support our pandemic response and ensured that all relevant data from state and district level is consolidated in a common framework through COVID-19 portal. Further, we tracked every test in the country and through ICMR's RT-PCR portal, we have data of more than 918 million tests conducted on a real-time basis. The government also launched a nationwide rollout of e-Sanjeevani, the first of its kind and the world's largest telemedicine services, ensuring free of cost online health services to citizens, and so far more than 100 million teleconsultations have been conducted. Under the visionary leadership of our Honorable Prime Minister, the vaccine management platform, COVID, was developed in record time with key features such as end-to-end beneficiary management, self-registration for vaccination, allocation of vaccination sessions, and QR code-based vaccination certificates. So far, more than 2.2 billion doses have been administered, having digital imprints over entire country. Further, India has opened its digital learnings to the world and aligned with ethos of Vasudhaiva Kutumbakam, we have provided COVID, e-Sanjeevani, and Arogya Setu applications as a digital public good. This exemplifies our commitment to global health and our role in driving equitable access to critical health solutions. Now, under the G20 presidency, India aims to be the voice of Global South and is already bringing together multiple stakeholders with action-oriented and impactful measures. Given the potential of digital solutions in revolutionizing the healthcare delivery systems, we are furthering the agenda of digital health during our G20 presidency. We are focusing on launching the global initiative on digital health as an institutional framework which aims to converge the global efforts for digital health and scaling up digital solutions with use of cutting-edge technologies. Through this initiative, we are building consensus on promotion of digital public goods as a key enabler in achieving universal health coverage targets through customization and democratization of technologies. This will also address challenges in universalization of digital health and enable equitable access to healthcare services across the world, particularly for low and middle income countries. India leading the G20 agenda has opened avenues to revive, rebuild, and strengthen global health partnership under the tenets of One Earth, One Family, and one future. The approach adopted by India in its G20 presidency under the leadership of Honorable Prime Minister. I urge all the participant countries present here to join hands with India in leveraging the power of innovation to create an equal world for a healthier tomorrow. Thank you.
We thank our Honorable Minister for guiding us and further sharing with us the strategy, the approach, the commitment of India towards digital health, making quality healthcare more accessible, affordable, and more equitable and available for everyone. Thank you. I now request Mr. Manoj Jhalani, the Director Department of Universal Health Coverage, Health Systems, WHO CRO, to kindly conclude the session, also his vote of thanks. Ladies and gentlemen, once again, he brings in extensive experience. He was earlier Joint Secretary, then Additional Secretary, and then Special Secretary in the Ministry of Health and Family Welfare. We seek his views as I request him for his concluding remarks.
Many thanks. No concluding remarks, just a vote of thanks. So His Excellency Dr. Mansukh Mandaviya ji, Union Minister of Health and Family Welfare, Government of India. His Excellency Mr. Joe Bijang, Health Minister from Marshall Islands. Excellencies, Regional Director of WHO Southeast Asia Region, Dr. Poonam Khetrapal Singh, Health Secretary, Government of India, Rajesh Bhushan, DPM, Dr. Pem, Additional Secretary Love Agrawal, Dr. Ellen, distinguished delegates from member states and partner organizations. It's indeed my honor to propose the vote of thanks. I'd like to thank Honorable Union Minister of Health and Family Welfare, Government of India, Dr. Mansukh Mandaviya ji, for his inspiring address and highlighting the importance of digital health for taking UHC to the last citizen and working and appealing for everyone globally to work together for it. I want to express my gratitude to the Regional Director, WHO Southeast Asia Region, Dr. Poonam Khetrapal Singh, for her leadership and support for this conference, recognizing the importance of digital health for taking the UHC forward in the region as part of the regional flagship program. I'd like to also thank our co-host, Ministry of Health and Family Welfare, Government of India, and in particular, Secretary Health, Rajesh Bhushan, and his very able colleague, Additional Secretary, Mr. Love Agrawal. Both provided very insightful and inspiring remarks, and for all the support they provided for co-hosting this event and inviting the G20 countries for this conference. I wish to thank my colleague from the headquarters, Professor Ellen Lebrick, and also Dr. Garrett and their team for providing wholehearted support and guidance for organizing this conference. And last but not the least, I also grateful to all the delegates from WHO member states, from all the WHO regions, including from the G20 countries, for joining us in person or virtually. And last, I'd like to express my very sincere appreciation to the WHO Southeast Asia Region Secretariat and the Ministry of Health Welfare teams who have been working tirelessly over the past few weeks, getting everyone together, trying to adjust and make sure that we have all the member states, key member states from all regions, and also all the key partners here together on this important journey. We recognize that digital technologies are a great enabler. They have a transformative potential to accelerate our progress towards achieving health for all in addressing real challenges. We look forward to very intense two-day deliberations on moving from what we have been saying as a potential to transform to actual impact on the ground. And I'm sure all of you will be joining in undertaking this important journey of moving from potential to real impact on the ground. Thank you once again to each and every one of you for joining us here. online and offline. Thank you.
Thank you very much, sir. With that, ladies and gentlemen, we conclude the inaugural session, thanking each one of you also for joining us, and now requesting you all to please join outside for a group photograph. It's going to be there at the steps. Post that, we have tea and coffee break that's going to be there in the Allure Hall. And herein, we are going to be starting our next session at 10:45. So requesting you all to be in time for that session also. We already have made arrangements for the group photograph outside, requesting you all to please, all the delegates, participants, please join us outside. So the next session, 10:45, Digital Health, an imperative for the universal health coverage. Herein, we are also going to be joined by the global leaders, the honorable ministers of some of the countries from embassy. We look forward to having great sessions with all of you. Please also have your tea and coffee in the Allure Hall. We'll have signages outside, representatives who will also guide you to the tea area. Thank you.
Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint CAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding THC for UHC.
We have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government's actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
Santa bastante depurali la tumititani mas kogu santa kudang ni saban saro kader kite anti wastan santa santa tiwaisan.
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water.
Check.
The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव से आए सयान सदन मन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तस्राव की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें।
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो अब मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं, उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिलती है।
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Haat Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CHC रहेगी वही बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहां तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में यहाँ हमारी वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as Ashas, or community-level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते हो तो बाजार में जाने से क्लिनिक खुला है, वहाँ जाके चेकअप कराइए, सब बोलते हैं।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
परेशान बहुत ये जितना मन सुस्ता ये पैर में सुस्ता था, ये पूरा शरीर सब मोटा मोटा था। मेरे को यहाँ पता चला शुगर बीपी बोल के। अभी तब से वो दवाई मन लेता, अभी तो रखी था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Bazaar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint gap mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Wellbeing for All, to support countries to achieve an equitable and resilient recovery and to drive progress toward this UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
संत अवस्थान देव पुरानी इलाज तुम्ही पिता निवास भोग संत सुदान मी सबन सारो का दुर्गीते उनके वक्तान संता सब संता शिवाय संत
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव से आए सयान सजनमन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार रक्तचाप की जांच और उपचार मधुमेह की जांच और उपचार शिशु का टीकाकरण गर्भवती माताओं का टीकाकरण का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें.
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है, जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो अब मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच।
So ladies and gentlemen, people who've joined us, may I request you to kindly take your seats. If a word can be put across to the people who are there in the Allure Hall, we are good to start with our session. If I can request someone from the hotel or maybe our representatives to just ask them to move in the hall. Okay, I think I'll take that podium only initially. So as our online delegates and participants also join us, we're going to be starting this session. At the end of the session, if time permits us, we are also going to be taking some questions from the audience present here, also online. So the online delegates are requested to kindly post in their questions in the chat box. Our representatives accordingly, as in the interest of time, we are going to be taking whatever number of questions we are able to take during the time. Just requesting people who are in the hall to kindly take your seats. Speakers, and then you have the panel discussion. They're coming in. Thing that we will be against our speakers coming here. So that comes to your 75 minutes for your speakers. I understand it. But then we have to keep some time. Yeah. So it will be keep it 6 to 8 minutes. We say 6 to 8 so that they. Yeah. And then we keep some time. I'll just anyway spell that out. Once again, a request to the people joining us, if you can kindly be seated at the earliest possible. We intend to start with our session. We are running slightly late. Solicit your support in starting the session on time. Now, in this session, we have 2 keynote speakers. So the keynote speakers, requesting them to kindly have their presentation within the 15 minutes time which has been allocated to them. Then we have our panel discussion. In that, we have our partner organizations and also the honorable ministers and senior representatives from the embassy. We would like to request them if they can have, during the panel discussion, their remarks or their comments for 6 to 8 minutes so that we are able to, and then keeping 10 minutes also a window for the Q&A. So the online delegates, you're requested to kindly post in your questions in the chat box. We'll take the questions accordingly. The moderator, depending on the time, how much we have, we are going to be taking the questions at the end of the discussions which we have here. Just requesting the people who are standing very closer to the entry gate, if you can be seated, if you can have your attention, people who are standing in the center also. So looking into the imperatives for universal health coverage, discussing the why, the what, and the how. In the inaugural session, we have certain pointers which have already been shared by our distinguished speakers of the inaugural session, guiding us, especially respected Secretary, sir, speaking about 3 challenges: interoperability of the digital solutions, robust training and skilling ecosystem to be developed, putting in more of these financial resources so that we can actually take UHC to the last citizen. So we are going to be focusing in this session more on prioritizing digital health and to allocate these adequate resources, financial, organizational, and human resources, how to further also ensure that the digital health initiatives are institutionalized and they are handled professionally in a time-bound mission mode manner. So if I have the attention of all present here, I would like to invite our keynote speakers to take center stage. Once again, inviting Mr. Love Agarwal, the Additional Secretary, Ministry of Health and Family Welfare. Our second keynote speaker, Dr. Kidong Park, Director, Data Strategy and Innovation, WHO Wipro. May I request him to please join here on the dais. Our Honorable Ministers of Health and Digital Health officials from various countries, Dr. Dasho Pemba Wangchuk, Honorable Secretary to the Minister of Health, Bhutan, Dr. Marcel Floor, Counselor for Health, Welfare and Sport, Embassy of the Netherlands at New Delhi, Mr. James Chia, Director, Health Informatics and Technology, Technology Policy and Governance, Ministry of Health, Singapore. From the partner organizations, Dr. Santosh Matthew, Country Lead, Public Policy and Finance from Bill and Melinda Gates Foundation, India. Dr. Francesca Colombo, OECD, and he's going to be joining us virtually. Dr. Ajay Tandon from World Bank Group. And our moderator of the session, Dr. Ahmed Mandel, Coordinator, Research and Innovation Science, Information and Dissemination at the WHO Regional Office for the Eastern Mediterranean. He, ladies and gentlemen, he was Secretary, International Epidemiological Association, Dean, College of Health Sciences at the University of Sharjah, Professor of Community Medicine at King Saud University, and presently, as mentioned, he's the Coordinator, Research Innovation at the WHO Regional Office for the Eastern Mediterranean. I invite our moderator and I hand over to him for the proceedings of the session.
Thanks very much for the introduction. This is our first technical session for this conference. It's a pleasure and honor to be here, and I thank the Regional Office for Southeast Asia for inviting all of us to this global conference, and hopefully that we can achieve in this session 2 topics we're covering and 2 questions we're trying to answer. The 2 topics are the criticality of digital technologies for universal health coverage, especially telemedicine and primary care-centered solutions, as well as the role of leadership in prioritizing digital health and universal health care. So these are the 2 topics we're trying to cover during this session. We're also trying to answer 2 questions, ladies and gentlemen. The attention of leadership is needed for the prioritization of digital health and allocation of necessary resources, all kinds of resources. And secondly, how can we ensure that digital health initiatives and applications are institutionalized within healthcare systems, time-bound, and put into action? We have listened to excellent speeches this morning about the importance of digital health and universal health coverage, and how these applications could make the healthcare equitable and less and less investments in healthcare as time goes by. In this session, we have 2 keynote speakers, 3 ministerial delegate interventions, and 3 partner organization interventions. For the keynote speakers, the first speaker is Mr. Lav Agarwal, whom we listened to him during the opening ceremony. He's the Additional Secretary of the Ministry of Health and Family Welfare of the Government of India. I would like to invite Mr. Agarwal to give the first keynote speech. Please welcome Mr. Agarwal.
Thank you, Dr. Ahmed. Dear colleagues, I would just like to run through a small presentation, primarily highlighting the topic for discussion today: digital health, an imperative for universal health coverage, and what from India's G20 perspective we think we should be focusing on. Universal health coverage primarily aims to ensure that all people, regardless of their socioeconomic status, have access to essential health services and without suffering effectively financial hardships. This means that everyone should be able to access a range of health services, including preventive, promotive, treatment, rehabilitative, and palliative care, without incurring catastrophic health expenses that can push them back into poverty. Digital health, to that extent, we believe can be an enabler and in effect has become an imperative for achieving universal health coverage because it has a potential to transform the way health services are delivered, improve access to care, and reduce cost. Digital health, to that extent, can also ensure availability, accessibility, and affordability of healthcare service delivery. If I were to highlight key aspects of digital health enabling universal health coverage, it can help in terms of bridging the urban-rural digital divide. It can reduce out-of-pocket expenditure. It can lead to continuum of care across the spectrum of health services, and it can also aid policy through data-driven policy decisions. By bringing quality health services at their doorsteps through multiple initiatives, a case in point is telemedicine. Dear colleagues, if I were to highlight India's digital health vision, India has envisioned to create a national digital health ecosystem across the country, focusing on creating electronic health record, longitudinal electronic health record for 1.35 billion people of this country with a pan-Indian exchange which can allow data exchange in a secured manner. We are also focused on ensuring citizen-centric health services delivery, duly ensuring continuum of care across primary, secondary, and tertiary level of health services, creation of longitudinal health record across health facilities, setting up a pan-nation telemedicine network, optimal use of IT for pan-nation surveillance and monitoring of programs, efficient use of IT tools for capacity building and training, and including integration of national and state program in a common framework so that seamless data interflow can help happen across the system. To fulfill this vision, India has also set up certain strategic focus areas for effective implementation of digital health intervention, which would include creating an enabling environment, focusing on a governance framework, digital health and policies and strategies to support this initiative, as well as focusing on capacity building and implementation support at the field level. Government of India is committed to universal health coverage for all citizens to make healthcare affordable, accessible, and equitable. And digital health technology, as I mentioned, has a potential in terms of supporting these initiatives. India has made exceptional progress in implementation of digital health interventions to aid universal health coverage and has demonstrated full use of digital technology in major health programs under the 6 strategic pillars as shown in this slide, be it planning and monitoring of multiple ongoing initiatives, hospital management systems, public health solutions, supply chain management, emergency response management, and a citizen interface through multiple citizen interportals is what has been planned. The initiatives like hospital information system, online registration system allowing patients to get appointment of doctors from health facilities across the country, Nikshay TB program, monitoring TB compliance, TB disease management, mother and child tracking program, wherein more than 120 million women are monitored for their pre-postnatal planning as well as the immunization of the children so born. Mera Aspatal is software wherein we can manage the patient feedback to health information management system, which gets collated data from across the health facilities in the country in terms of policy planning, and something which Secretary Health alluded to in the morning, an integrated health information platform where 36 diseases are monitored, name-based, line listing based, and GIS enabled so as to understand the trajectory or the spread of infectious diseases across the country, including monitoring NCD across the country through multiple IT applications. These all initiatives have benefited country and patients across the country with timely service delivery and making government healthcare more accessible to people. I would also like to highlight, while these were the ongoing initiatives within the country, we also realized that the type of problem which had happened in the physical space, that is people don't talk to each other. Similar problem was also happening within the data space, where the egos of the software, something again the Secretary Health alluded to in the morning, egos of the software was forcing software not to talk to each other. And that is where we realized that we are not able to make the best what technology has to offer us. So with a vision to create this ecosystem where the egos of the softwares can be broken, we launched a National Digital Health Blueprint in the year 2019, which was focused on creating an architectural framework which can seamlessly interweave all ongoing initiatives in this country. It laid the foundation of a mission mode approach, Ayushman Bharat Digital Mission. The Ayushman Bharat Digital Mission initiative of Government of India is primarily focused on creating the backbone necessary to support an integrated health data infrastructure and bridge the existing gap among different stakeholders, both public as well as the private partners, through digital highways and through multiple registries like Health ID Registry, health provider registry, health facility registry, and a sandbox environment to promote innovation and in turn creating an environment where both public and private sector can contribute to the digital health intervention within the country. As on date, I'm happy to highlight that we have been able to create 332 million health IDs, ABHA IDs is what we call them, as well as 144,000 health providers have been registered through the providers registry, and more than 200,000 health facilities are already having unique health IDs given to them, and more than 600 plus IT applications which are being made by government as well as the private sector are running through this sandbox environment where they get integrated with these multiple registries which have been made across the country so as to actually create a seamless flow of data across the system. We talked about data interoperability as a very important imperative to make advantage of technology, and this is what this initiative will be focusing on. I would like to highlight, and which we also discussed in the morning, how technology got strength during the challenges posed by COVID-19 and the acceptability increase. We had a Arogya Setu application to keep users informed and updated about the spread of infection in their surroundings, support them in contact tracing, as well as also to disseminate information about latest development on COVID management. Arogya Setu is presently the most downloaded application in the world with more than 218 million downloads. Dear friends, I would also like to highlight about COVID-19 portal. Much of it is not known in the public domain because this is an in-house portal, but this is the portal through which India has managed the COVID-19 management across the health facilities in the country. So all the 750 districts of this country are sending a daily data on multiple aspects of COVID-19 management, be it the number of tests, number of cases which are positive, their clinical status, based on which a clear understanding is done in terms of what action need to be done in what territory of this country. So these are again such applications. Let me also make a mention of how Indian Council of Medical Research RT-PCR application and portal, wherein 404 million samples were collected through the app from the field. So we have digital imprint of all 404 samples which have been collected through this app. We also parallelly have this analytics portal where 918 million tests, the digital imprint of who took it, where he took it, and what is the status of those tests is available, based on which critical action at the field level was planned. Let me also make a mention, I would be talking about in the next slide, the eSanjeevani telemedicine application. And I would like to highlight how digital intervention, a single digital intervention can be a game changer for health service availability at the field level. We discussed about iGot, a training platform where more than 919 million COVID warriors were oriented, including the health service provider across the remotest part of the country in terms of what needs to be done when it comes to managing COVID-19. I would also be discussing about COVID. You are all aware that 2.2 billion doses of vaccines which have been administered in this country are monitored through this particular application. COVID, dear friends, as I mentioned, 2.2 billion doses, 1 billion first dose administered covering 96% of the eligible population of this country, 951 million second dose administered covering 88% of the eligible population of this country. And the highlight is a technological intervention which ensured that based on Aadhaar authentication, you can actually book up your slot, you know which center you are going. You also know the cold chain which has been followed in terms of that particular vaccine which is going to be administered to you, allocation of the centers, as well as QR code based vaccination certificate, adverse event following immunization monitoring across the spectrum. This is one technology tool which India produced and made available to country in a period as less than 2.5 months, and which monitored application. And why I have shown in the last point, 25 million doses administered in a single day, highest doses administration in a single day in the world. And it is this technology tool which did not slow down ever from the day one when it was started, and ensured that we are able to monitor what is to be done in terms of management of COVID-19. Dear friends, India made this tool available as a digital public good to the whole world. I am constrained to highlight there are times when we realize when we go to ACT Accelerator meeting and people talk that There are countries in the world where the vaccine administration is as low as 23% when India has been able to do much higher. On one side, it is vaccine availability. On second side, it is the administrative aspect of vaccine delivery. And it is this particular tool which supported. Assuming if these tools are available as digital public good to whole world, then can we not ensure better service delivery to our citizens across the world? And that is where we brought the concept of digital public good. Knowledge should not remain confined to places where it is created, but it should be widely disseminated to people across the world. The focus should be on use of technology, not only creation of technology. Let me again highlight telemedicine journey. This has two components where doctor-to-doctor consultation can take place, as well as through a mobile app, a patient can directly talk to the doctor too. This is a service which you are providing free of cost to every citizen of this country, widely made available during COVID-19. 27,000 doctors for 141,000 telemedicine facilities in the health and wellness centers are contributing to this service on a daily basis. I'm happy to submit to you that we are doing as high as 400,000 telecalls per day. And as well as that, we have done 105 million teleconsultations we have finished so far, made available to citizens of this country. A very important critical point, which I would like to specifically submit here. An NGO has done an analysis in Jharkhand state of this country, and they noted that per telemedicine call is leading to saving of 21.59 kilometers of travel to the patient per telemedicine call. Similarly, $11.41 is being saved in terms of both direct and indirect cost because this telemedicine call is available. Dear colleagues, as I was submitting to you, single intervention has ensured cumulative cost saving of around $1.1 billion to the citizens of this country, and also the fact that it has ensured access to specialized care. It has also ensured reduced out-of-pocket expenditure. Take into account 21.59 into 100 million kilometers of travel has been saved, that much of carbon credit has been saved, that much of harassment has been saved in terms of moving out and leaving your daily wages, which otherwise if you are a poor person, you're going to lose. And the early identification is a primary key in terms of saving lives and in terms of avoiding complication. Dear colleagues, what I'm trying to submit here is that these are the interventions which have very critical field implementation. We want, from India's perspective, they should be made available as a norm across the world. Knowledge of one country, knowledge of one organization should be made available as digital common pool to the world, and based on which we can serve the country and the world well. Another interesting issue I would like to highlight, that we have now started working towards how data first approach can be built into policy. And with that as a thought process, now we have come with the National Public Health Observatory, where all the IT applications of the country are being integrated. 40 plus health IT applications have been identified. 600 plus key performance indicators have been identified, which will indicate the health of each and every health program conducted by Government of India. And this also provides transparency to the aspect that video feed from all the medical colleges and all AIIMS is also available at the national level. So with this, we are basically focusing on creating disease surveillance management, health human resource management, healthcare financing management, as well as the public health program delivery aspect are being monitored. What you see here on the side is a glimpse of those dashboards which have been prepared for honorable ministers, for the policy planners, as well as for the state and the districts across the country, based on which you can actually really do effective implementation of multiple programs ongoing and ensure value for money approach. Dear colleagues, there is a need to learn from what is happening across the world. There are learnings which are there with India, and we believe there is a need to converge all these ongoing global efforts on digital health to create a global digital health ecosystem, which means that there is a need to establish an architectural framework to promote data first approach. Similarly, we need to move from silos to an integrated approach for digital health implementation. We need to create an enabling environment to ensure that the digital divide can be minimized. Technology is moving at a very fast pace. Are we moving with that speed? And if we do not move with that speed, so much is at stake. So it is very critical that we need to converge our efforts. We should not remain in silos, and we should create a framework where the digital divide can be minimized before it gets too entrenched that in future we realize we cannot ever bridge it. Similarly, we need to also focus on shifting, not only making solution, as I mentioned earlier, we should see that the fruits of technology are actually seen by the common man. It is in this direction we have prioritized digital health agenda, as I mentioned earlier in the inaugural session. We want to work with WHO to support WHO to achieve the objectives of global digital health strategy. We want to create national action plan by every country on the digital health implementation so as to support universal health coverage. We want all the organizations in the world to come together, since we're all working with the common goal of making health service delivery better. So we should converge, we should not remain in silos, we should converge our initiatives. All institutions, all initiatives, please come together so as to make a collective impact. And we all know that there is always a strength in unity. We also need to ensure that we curate and make digital public goods available to the world at large. We need to focus on aspects related with interoperability, data security, and privacy. By focusing on curation, we need to focus on the capacity building aspect of the digital health. And this is not a tough job, but we need to strategize it well. And we are saying that when India is proposing a global initiative on digital health in alignment with WHO, that all these initiatives, by converging your ongoing initiatives, when you're already investing money, by converging them, can we create a fund of $200 million to support this initiative? In terms of way forward, what we would like to request that collective efforts are needed. We also would like to highlight what Honorable Prime Minister of India has very specifically mentioned, that India's G20 presidency is also going to be the voice of Global South. And we are then in that context focused on minimizing the digital divide by promoting digital solutions and innovation to aid universal health coverage. We are talking about democratization of technology, something which Regional Director Zero also mentioned and other colleagues had mentioned in the morning. We are looking for digital tools as common public goods. We're also talking about organizing countries, organizing organizations in terms of this approach and contribute to the global initiative on digital health and support it with both cash as well as the software which they have as digital public goods. In the end, I would like to only urge, there is a need for all of us to come together and be part of a global revolution on digital health. One Earth, One Health. And there is definitely, this should remain our guiding principle, and which is again based on India's philosophy of Vasudhaiva Kutumbakam, which translates to that the whole world is one family. We need to understand that technology is moving very fast. And if we do not really catch our efforts, if we do not really work together, probably there will be so much which will be at stake and so much we could have done better. There is a need to convert, there is a need to work together, and One Earth, One Health should remain our guiding principle. With these words, I would like to thank my moderator for giving me, I think, little bit extra time. But yes, I think, this is an area which is so passionate to us collectively. We need to collectively do that together. Thank you very much.
Thanks very much, Mr. Agarwal, for an excellent presentation and a start of this session. Mr. Agarwal spoke about how universal health coverage would help bridge the digital divide, reduce out-of-pocket expenditure, ensure continuity of care, and enabling data-driven policy decisions. He actually spoke about India's digital health vision and mission, and very impressive achievements from which many member states across the world could learn. He focused on areas of digital health as an enabling environment, policies and strategies. He spoke about Ayushman Bharat digital mission and digital health enabling during the COVID-19 pandemic through different areas of work, including surveillance, logistics, lab testing, hospital preparedness, risk communication, capacity building, but most impressively, vaccine distribution. He spoke about the excellent digitally monitored system, which is probably the biggest in the world. He also shed light on the telemedicine journey as the world's largest government-driven telemedicine program with more than 100 million consultations. So far, more than 400,000 per day. He shed the light on how digital health is used for universal health coverage through planning, hospital information systems, public health solutions, supply chain management, energy response management, and citizen portals. And finally, he also spoke about the National Public Health Observatory through its work through the population profile, surveillance, healthcare infrastructure, public health programs, and ended by how the G20 could support WHO's global strategy on digital health, its action plans, digital public health goods, the importance of interoperability and capacity building, and how investments are needed in order to support digital health across the world. Thanks very much, Mr. Agarwal, for an excellent presentation. It now gives me great honor to actually introduce the second keynote speaker, Dr. Keenog Park. Dr. Park is the Director of Data Strategy and Innovation in the Western Pacific Regional Office of WHO. He has extensive experience in global health, health policy and management strategic planning, and international career in public health, which spans from high-level representative roles to technical work on communicable disease control in the Republic of Korea, where he actually was the most important person on MERS response. He held many management positions as Director of Communicable Diseases, Non-Communicable Diseases, and also as the Director of the Medical Insurance Physician. Ladies and gentlemen, please welcome Dr. Keenog Park.
Okay, thank you, Mr. Chair. Good morning, ministers, distinguished delegate, colleagues, and friends. As introduced by by Chair, my name is Dr. Keenog Park. I'm the Director of the Data Strategy and Innovation at the WHO Regional Office for the Western Pacific based in Manila, Philippines. I'll tell you about the WHO's strategy on digital health, which aims to help countries' journey in progressing universal health coverage. WHO's mission is to provide universal health coverage, to protect people from health emergency and make population healthier. In 2019, by adopting the 13th General Program of Work, GPW13, WHO set an ambitious goal to achieve 3 billion targets by 2023. It means 1 billion more people benefiting from universal health coverage, 1 billion more people better protected from health emergencies, 1 billion more people enjoying better health and well-being. Since then, the world has shown steady progress in these 3 billion targets. However, we have to admit the situation that we are off track to reach 3 billion targets, in particular, 4 billion target of UHC. The COVID-19 pandemic presented huge challenges to health system in providing essential health services to vulnerable population. This backsliding means that business as usual is no longer an option. We must learn from this pandemic and accelerate our progress towards UHC, towards ensuring that more people benefit from UHC, are protected from health emergency, and enjoy better health and well-being. Last year, the World Health Assembly approved the extension of the GPW13 from 2023 to 2025. The objective of the extending the GPW13 is to strengthen country capacity and to accelerate progress towards achievement of the 3 billion target and health-related SDGs. To meet this objective, WHO Secretariat presented to the Executive Board in early this year 5 priorities and strategic direction for the extended GPW13 and proposed program budget for 2024 and 2025. these provide health, support a radical reorientation of the health system towards primary health care as the foundation of UHC, protect health, urgently strengthen the systems and tools for health emergency preparedness and response at all levels, promote health, support countries to make urgent paradigm shifts towards promoting health and well-being and preventing disease by addressing its root causes. Power health, harness the power of the science, research, innovation, data, and digital technologies as critical enablers of the other priorities, and perform for health. Urgently strengthen the WHO as the leading and then directing authority on global health. At the center of the global health architecture and building around empowered country office. Today and tomorrow, we will discuss how to accelerate our journey towards UHC by harnessing the power of the digital health technology. I'll tell you more about WHO's strategy on digital health to support this UHC journey. There are many kinds of the digital health solutions as shown in this slide. Telemedicine, mobile apps, clinical information system, big data, genomics, artificial intelligence, etc. Most of these digital technologies, if not all, have great potential to help countries' journey in progressing UHC and overcome health system challenges. However, I must tell you that digital technology, including digital health technology, may increase inequality by disproportionately benefiting less disadvantaged people. We must address this unwanted impact of the digital technology, unwanted impact of the application of the digital health technologies. WHO's strategy on digital health can help countries in this regard. We have the Global Digital Health Strategy, Global Strategy on Digital Health 2020 to 2025, which was endorsed at the World Health Assembly in 2020. The Global Strategy on Digital Health set the vision to improve health for everyone, everywhere, by accelerating the development and adoption of the person-centric digital health solutions, and developing infrastructure and application that enable countries to use health data to promote health and well-being and achieve health-related SDGs and triple billion target of the GPW13. Let me take one step further into the global strategy on digital health. It sets 4 strategic objectives to achieve. Objective 1, promote global collaboration and advance the tech transfer of the knowledge on digital health. Objective 2, advance the implementation of the national digital health strategies. Objective 3, strengthen governance for digital health at global, regional, and country level. And objective 4, advocate people-centered health systems that are enabled by digital health. By achieving these 4 strategic objectives of the global strategy on digital health, we expect the following impact at global, regional, and country levels. Increasingly appropriate and then sustainable digital ecosystem, cost-effective and efficient health systems and services, accelerated digitalization on health and the well-being sector, and healthier population. In the course of the implementation of the digital health strategies, both the WHO's strategy and the national strategy, we recommend
the following framework of actions to consider. First, commit. Maintain commitment and contributions to the implementation of the digital health strategy while respecting national priorities, capabilities, and resources. Second, catalyze. Generate a cooperative environment that is conducive to creation, introduction, and the scaling up of the appropriate digital health technologies. Third, measure. Create and then adopt processes and metrics for monitoring and then evaluating the effectiveness of the digital health strategy. And fourth, enhance IT rates. Undertake a new cycle of actions based on what has been experienced, measured, and learned. We need more investments to harness power of the digital health technology and make these digital health technologies become an enabler to address health system challenges. There are many different digital health solutions, many different digital health technologies which can benefit different sectors of the society. Technologies such as electronic health record and wearables can benefit individuals, families, and communities. Technology such as clinical decision support system can benefit health service providers. Technologies such as telehealth, telemedicine can benefit organizations in health sector. Technologies such as web-based reporting and the big data analytics can support countries' health system. Considering these many competing digital health solutions, the role of the government is prioritizing investments, which is very critical in moving forward digital health ecosystem. All the investment health sector, including digital health technology, should help countries' journey towards by improving quality of health services. Access to those quality health services in affordable costs. The public investment on digital health technology should also address essential foundations of digital health. These are essential ICT infrastructure, such as power supply, mobile network, internet bandwidth, etc. Essential tools, such as common registries, unique IDs, EMR, EHR. Readiness of the information sharing by setting standards, protecting security and privacy of the digital data, and readiness of health system, such as digital health literacy, policy, legislation, workforce, financing, governance, and engaging stakeholders. I'm reaching almost at the end of my presentation. Let me conclude my presentation by reconfirming a few key principles of WHO on digital health investments. WHO recommends countries to consider. Digital health investment should be coordinated to support continuity of care. Digital health investment should address a health need, should be appropriate for local context, should not duplicate existing digital tools of system, and should account for long-term costs. I'll stop here. Thank you.
Thanks very much, Dr. Kino Park. We learned a lot from your presentation, especially from a WHO perspective. Dr. Park started by talking about WHO's mission with the 3 billion targets on universal healthcare, health emergencies protection, and healthier populations. He mentioned that while we were doing more or less well on health emergency protection and healthier populations, we still have a long way to go as far as universal health coverage is concerned. He also spoke about the extension of the global program of work from 23 to 25 and the importance of powering health through data, digital, and delivery for impact. He spoke about the model, which some people agree upon, some people don't, that digital health includes e-health, includes m-health, includes telehealth, while we have at the other side of the slide, big data, genomics, and AI. He then shed the light in details about the global strategy on digital health 2020-2025 with its 4 strategic objectives, and mentioned that the people-centered health systems are really important for both the healthy as well as the sick people. And then he spoke about the framework of action to commit, catalyze, measure, enhance, and iterate, the importance of quality, access, and cost. He spoke about essential foundations of ICT tools and readiness of information sharing. And then he ended by digital investments in digital health in supporting continuity of care and hence universal health coverage. I just have to mention also that in addition to the global strategy in digital health, many regions have had their own regional strategies and action plans, including AFRO, EMRO, EURO, and WEPRO. Thank you very much, Dr. Park. We learned a lot from your presentation. Thanks very much. The second section of this session includes ministerial delegates invited interventions. And we have 3 interventions for this session. 1 from Bhutan, and 1 from the Netherlands, and 1 from Singapore. It gives me great pleasure to welcome Dr. Dashu Pemba Wangchuk, the Honorable Secretary, Ministry of Health of Bhutan, to start the first ministerial delegate invited interventions. Dr. Dashu, the floor is yours. Please welcome Dr. Dashu. Thank you very much.
Excellencies, keynote speakers, distinguished delegates, ladies and gentlemen. May I thank the keynote speakers for their valuable insights on the importance of digital health for universal health coverage, with special focus on reaching the difficult to reach population. The presentations were very engaging. Globally, all sectors, especially the business community, are making optimum use of IT technology, and this has increased the quality and reach of services. I am of the view that there is huge opportunity for the health sector to also throw in and intensify adoption of appropriate technology to improve quality and reach of health services to the last citizen, thereby enabling us to achieve our noble goal of universal health coverage. For resource-constrained countries like Bhutan, with difficult geographical terrain, scattered settlement, limited healthcare providers, and inadequate finances, a good answer to our problem is the digitalization of the entire health system. Excellencies, ladies and gentlemen, I'm convinced that our initiatives in health digitalization in Bhutan are already bringing a huge benefit and transformation in service delivery and health management. Further, the COVID-19 has given us the lesson and confidence on the need for going digital in health. The Royal Government of Bhutan has always accorded highest priority for e-gov initiatives. Under the recent whole government transformation, the IT department received the top priority and is now upgraded to an autonomous agency and put at par with other government ministries with a separate secretary appointed. The whole government is shifting to digitalization, and a lot of exciting, important e-gov initiatives, such as the National Digital Identity Project, digital schools, integrated citizen services are underway. In the health sector, Bhutan is implementing the national flagship project known as Electronic Patient Information System, EPIS, this year. This system is going to be a consolidated, interoperable system with all health information system, electronic medical record, laboratory information system, radiology information system, picture archiving and communication system, human resource information system, medical supplies inventory system, etc., with 29 modules from reception module to pharmacy module, catering to both OPD and IPD services. It is also in one system with source household data integrated from civil registration and vital statistical system. It will also have a centralized health data hub for household, medical, health, and biobank with data collected from both hospitals and primary healthcare centers. Similarly, Bhutan has introduced the use of mobile cardiotocography, ICTG, to improve mother and child healthcare. ICTGs will support in reaching every pregnant woman with quality antenatal care and gynecological and obstetric services with special focus on remote parts of the country. ICTG is expected to benefit more than 50% of expectant mother every year. Excellencies, ladies and gentlemen, digitalization of health services is not as simple and as easy. It is resource intensive to start with, and many of our countries are constrained in that respect. In this regard, we would urge WHO and all development partners to prioritize digitalization of health services in their assistance to health systems in developing countries. The investment will be worth in terms of health outcome. Many of our countries are also constrained with expertise and experience in initiating various digitalization of the health system. Lack of health IT experts pose a serious threat to intensification and sustainability of digitalization in the health sector. In this regard, WHO and other development partners may wish to provide technical support and enable the countries to adopt digitalization. There are also complex issues of data security and confidentiality being faced by developing countries. Therefore, these countries would require assistance and collaboration for developing legal instruments for data protection and data utilization. It may also be worthwhile to share health digital systems adopted in different countries and create a regional resource pool so that we can learn from each other. Excellencies, ladies and gentlemen, in conclusion, I would like to thank WHO CRO and the Ministry of Health and Family Welfare, Government of India, for organizing this forum. I wish everyone a very happy International Day of Happiness. Tashtile, and thank you.
Thank you very much, Honorable Secretary, Dr. Dasho Pemba, for excellent remarks on the digital health importance for universal health coverage in Bhutan, especially given the nature and geography of the country. He actually spoke also about the lessons learned from the COVID response as far as digital health applications are concerned. He also shed the light on the whole of government approach towards digitalization, which was experienced in Bhutan, and spoke about the program of quality antenatal care, which should cover 50% of expected mothers in the country. And he finally said that digital health needs investment, and it needs also leadership and needs prioritization from different governments, and called for technical support from different partners, especially WHO and other partners, to help in building mechanisms and modalities for data security and protection. Thanks very much, Dr. Dasho. It gives me now the pleasure to welcome the second ministerial delegate intervention from Dr. Marcel Floor, who is the Counselor for Health, Welfare and Sport at the Embassy of Netherlands here in New Delhi. Mr. Marcel, the floor is yours. Please welcome Mr. Marcel.
Excellencies, distinguished guests, thank you for inviting me on this very, very special and most relevant conference. It's been it's a privilege to speak and to share some learnings and some findings that we have in the area of digital health, which is so close to my heart. This is the Netherlands. I see some heads nodding. This is the Netherlands that we like, that we share, that we cherish. And spring is coming. But if we zoom in, we see a different kind of the Netherlands. This is healthcare in the Netherlands. Looks good as well, you might say. Smells good. Yes, indeed. But there is a fantastic diversity in color, in smell, in needs, in strength. To a certain extent, it illustrates the high level of personalized options for health and care. And I deliberately say health and care, not healthcare, because we extend our thinking on digital health to care as well, to youth care, to care, long-term care for the elderly, to prevention. So this diversity is able to a certain extent and up to a certain level is able to address the individual patient's needs as much as possible. Now, the Netherlands has a private health and care provision system, which is unique in Europe. Government sets the framework and the principles on financial accessibility, on accessibility, and on quality, very important. Now, for us, digital health is essential for patient safety, for lowering administrative burdens for nurses and doctors, and for generating data that might open complete new views on health and on diseases, on prevention and on treatment. We share in the Netherlands the same ambition of digital health and care. However, we have different contexts, as you see on the right, different flowers. Now we see this in the Netherlands at a small piece of this planet, but at the same time we see it on a global level as well. I think we're in this together in digital health. We share and we should cherish, in our opinion, the fantastic diversity. And therefore, when it comes to implementation of digital health, we're of the opinion that one size fits nobody. We should accept and embrace the diversity, the uniqueness to a certain extent. And if all healthcare systems are unique, more or less tailor-made solutions for national strategies and implementations plans are needed. And for those, it is essential to learn. Oops. Yeah, there it goes. Now, learning is require an active, open mind, not to be preset or prejudged. There's no need to reinvent the wheel. Let's look at what's happening now. GPT-4, that's storming the world, does set the standard. It takes the best of what's available on the internet. And to a certain extent, that is my personal story as well. I have a background in Dutch digital health implementation, but being based here in India, I learned from the Indian leapfrog in digital health. And does it mean that Indian digital solutions can be transferred to the Netherlands? Not per se, but we do learn from the Indian approach. Learning for us also means sharing successes and failures. And we made a lot of mistakes. We constantly do learn. And for that, we need the right kinds of setting of environment that stimulates learning. There is a wealth of knowledge and expertise available in public and in the private domain. Some even speak about an oversupply. And I learned a few weeks ago from the WHO Innovation Hub that we need to rebalance globally. Demand articulation is a critical issue. But a word of warning, as far as I'm concerned, are we able to objectively analyze what's needed? And are we able to define the requirements, the processes, and the resources? Or are we, to a certain extent, blinded by supply of technological point solutions, of low-hanging fruit, of short-term financially attractive arrangements? For us, WHO can act and serve like a broker of this expertise. Not WHO should have all the expertise on board itself as an institution, as an organ, as an organizational, as an organization. WHO can and should provide and link to the knowledge that is available, should help to mobilize these additional resources that are needed, as the previous speaker pointed out so eloquently. Mobilize can help in finding the answers to the specific issues of situations in the different countries that we represent. So there for us is a key to a more focused and targeted capacity building that we're all looking for. Once again, the Netherlands. In blue, that's water. Over 50% of the Netherlands is under sea level. So working together in keeping out the water has been for centuries our main objective. It's in our DNA, work together in an ecosystem, because if not, half of the country will be reduced. We would not be able to survive. Now, for us, working in a health ecosystem is very much to do with, it has to be patient, citizen-centered. And yes, we're all citizens, and yes, we're all patients, but it is important to constantly keep patients engaged in the decision-making and the design that we're working on. I said it already, public and private, we need to work together. It's very much about inclusion. It's about give and take. And we have great success in bringing the whole system in one room. I've seen some examples here in India as well. Might not be the obvious choice, but it works, believe me. And then about leadership. As government, we have a great convening power, also in a privately organized healthcare system. And yes, we have carrots and sticks, and we use them both, and we should use them both. And nothing new to you. This whole trajectory is a dynamic. We need to adjust to new situations, new insights. There's no linear route. We need to organize iterations. Now, ladies and gentlemen, if I zoom in on the Dutch digital health and care transition that we're in, what is important to share with you, not so much the small letters that can be later on, but that my minister made an agreement with private sector, the privately organized healthcare system. You might say, how does that reflect the leadership? Because as a minister, you can impose, you can instruct, you have the instruments. We chose because we believe in an ecosystem for an agreement. So we brought on board the medical doctors, the nurses, the patients, the IT providers, you name it, any organization, stakeholder that we need for this digital health implementation. We sat together and we made an agreement. If you do that, we do that. If you leave this out, then we leave that one out. So it is very concretely put together our ambition to work in an ecosystem, in hard targets that we need to put as well, milestones that you need to collectively work on. Now, if we worked in an ecosystem and would like to push stakeholders and systems and individuals to work together in this ecosystem, we believe it is essential. Communication, information flows, data can be exchanged, and data therefore must be interoperable. And that's more, as far as we're concerned, more than ensuring that one's own business is in order. Interoperability, by definition, has at least two sides. Sending data without those data being understood or contextualized will not help the patients. It will not help the nurse. It will not help the doctor. We believe there is a strong need, an agenda to accelerate interoperability and to accelerate the acceptance of standards, because there are sustaining implementations. I think at the same time, we're making good progress in global communities to standardize terminologies, specifications, semantics, and protocols. I'd like to highlight the International Patient Summary, in which we see implementation really is catching up around the globe, and many more use cases will follow. And the role for government, once again, leadership, is to ensure those standards actually are implemented up to the last mile, up to the last citizen. Once again, government has instruments, carrots and sticks, and we need to use them. And the Netherlands is actively pushing for acceleration of interoperability, also on a global scale. Now, the implementation, no surprise to you, is not going to be a walk in the park. Our lessons as well. As I said, we made a lot of mistakes as well. It's more like a steeplechase. It's all about agility, perseverance, stamina. But it's well worth it because there's so much to win. Thank you.
Thanks very much, Mr. Marcel Floor, the Counselor for Health, Welfare and Sport at the Embassy of Netherlands here in India. Mr. Marcel started by beautiful slides on the Dutch tulips, which I really like very much. But he emphasized that tulips have different colors, smells, and so is healthcare. He emphasized the importance of talking about health and care rather than just healthcare. And hence, he spoke about the Dutch digital health and care transition so that within 2 or 3 years, everybody in Netherlands will have digital access to their health and care data. An excellent initiative, which we'll be all looking forward to. He emphasized the importance of the different members of the healthcare team in digital health support of universal health coverage and the challenges in learning in different parts of the world, as well as the requirements and resources needed for digital health for universal health coverage. He emphasized the importance of information sharing and calls on WHO to help in mobilization of resources and investments. Thanks very much, Mr. Floor. The third invited ministerial delegate intervention actually comes from another Asian nation, from Singapore. I'd like to invite Mr. James Shea, Director of Health Informatics and Technology, Policy and Governance at the Ministry of Health of Singapore, to be the third speaker. Please welcome Mr. James Shea.
Very good afternoon to esteemed leaders and guests. I would first like to thank the organizers for giving me this opportunity to share the digital health approach as well as experience that Singapore has gone through. The idea for this sharing is essentially to give everyone another data point, another one of the many data points for reference as each country go on with your own plans. And I guess the aspiration is for us to converge eventually onto some form of a template where we can then better share our experiences in a more sustainable manner. Right. Maybe let me start off by sharing with everyone Singapore's healthcare landscape. Essentially, we are supported by public and private healthcare in a proportion that might not be quite the same across the various countries. 80% of our public acute hospitals are directly managed by the government or government-related associations or institutions. While the converse is true for the primary care and ILTC, the intermediate and long-term care facilities, right? Close to 70–80% of them are being run by the private. Now, as we talk about moving into universal health coverage, it is important that the collaboration between the private and the public healthcare providers needs to be tight, seamless, and in fact, in our point of view, they need to be increasingly connected digitally, right? This is quite difficult to achieve, right? Good news is that since last year, we have given ourselves a shot in the arm, right? Our ministry in Singapore has actually launched a national program called the Healthier SG Initiative. Essentially, it is a population health initiative. And with that, it has actually boosted more support across the various stakeholder groups, encouraging them to work together more collaboratively. Now, in order to enable the connections between the various providers, which I highlighted earlier on being an important ingredient, the digital maturity across the different care segment groups are actually quite different, even in Singapore, right? Good news is that in Singapore, we didn't have to start from scratch. Over the past decade or so, we have invested quite significantly in some of the platform capabilities that are largely used by the bigger players in the country, right? And we are increasingly leveraging that as the base to extend it out for other players, including the private players, to onboard. And from there, we hope that this will actually catalyze some of this collaboration and digital connectedness across the public and the private realm. Now, some of these digital capabilities, you might be wondering what are those, all right? So this could be some of the consumer engagement capabilities like portals. We have actually a national platform for citizens to log on to check their health status, their medical records, right? And in fact, we also have a capability to actually allow them to collaborate with industry players so that they can build in nudges as well as how they can better embark on some of the preventative care initiatives, right? Being a public and private partnership. Also, we have our core data backbone. Some of you might be quite familiar that in Singapore, we actually have what we call a National Electronic Health Records System that houses the longitudinal medical health record of all citizens, right? Now, this is also a decade, more than a decade year old effort. Primarily, the data has been fed in by the public hospitals and on a voluntary basis by the private organizations, right? What we are going to do going forward is to get support from Parliament to actually mandate the mandatory contribution of medical records by the private players as well. Now, this is actually going to be quite a game changer for us because by then, the full set of longitudinal records, both from private and public use, can be actually made available to all providers of care, right? At any point of time when our residents go to a doctor or a care provider. Underpinning all these capabilities actually is a plan, right? In Singapore, we are fairly well known for trying to plan as much as we can, right? Okay. And we all know that a plan is useless if it is done up once and it's left there to guide for the next 5-10 years. It doesn't quite work that way. So the plan has always been calibrated. So we do have a similar plan called the Digital Health Master Plan that looks at how we can pull all these various capabilities together. We also take into consideration the learnings from recent events like the last 3 years of pandemic. We have taken away quite a lot of learnings, right, to see how we can actually improve not just how we turn around software solutions, but also understanding that the dynamics of the stakeholders have also changed as a result, right? Consumers, residents, citizens are actually now more responsive and being willing to take a look at some of these national initiatives being rolled out, right? As a result of some of these experiences they went through over the last 3 years of pandemic. Okay. On the provider side alike, you might find this amusing, right? But in telehealth, for telehealth, in Singapore, a lot of doctors actually do not like to have them implemented. Reason is simple. In Singapore, which is so small, no matter where you are just half an hour away from medical help, right? So usually there is not a lot of use case for telemedicine to be in place. Guess what? Pandemic has changed that picture, right? So right now we do have a new kind of wave of motivations, and we're trying to ride on that to be able to get the various stakeholder groups to then roll out the Healthy SG program so that they can maximize and the opportunity that has been presented to us over these last 3 years. The plan actually will also mean that it is a group of sub-strategies. Okay, to give you an example, our hospitals care settings, we are quite developed, and we have been pouring in a lot of investments over the past few years, past 10 years, in fact. We are right now looking at how we can divert some of these resources to help the primary care sectors level up, right? This is something that the government has the power to do so. And I think this is where I would like to emphasize, I think leadership, having been mentioned by many leaders before me who said that it is an important ingredient to this effort, this is one of the manifestations. Right. Maybe let me come to try to wrap this up quite quickly. We have done quite a fair bit of planning. We have done a fair bit of implementation. And I think we are beginning to see some of the fruits of all these efforts coming through, right? But this is still very much early days. And we don't think that we have the magic formula. So we are very much in a place whereby we also hope to learn from everyone. There are also quite a number of challenges that we feel is out there that is challenging us, and not just us, but probably all of you as well, which is as we move into this realm of population health, universal healthcare, how do we measure performance? How do we know that we have succeeded? We are actually moving a lot of resources from existing commitments into new realm, right? So some of the things that we are looking into is how do we plan for some of the performance outcomes, metrics that we want to then take measured steps to see whether the intended outcomes have been achieved. And from there, we'll again do what we do best, which is to calibrate the plan, right? So I thought maybe just some quick notes for sharing with everyone on Singapore's journey so far, early days, and we hope to look forward to greater sharing as well as advice from everyone as we move along. Thank you very much.
Thanks very much. Thanks very much, Mr. James Shia. He actually reflected on the experience of Singapore in digitalization of health as an imperative for universal healthcare. He started by talking about the healthcare landscape in Singapore. He shed the light on the importance of interoperability and digital maturity. He spoke about the digital platform, which is accessible to all registered populations in Singapore. He also shed the light on an excellent system for electronic health records, including medical records for all citizens in Singapore. He spoke about the importance of the planning, that it is not rigid, and it always has to do with replanning, learning from our mistakes, and actually building new mechanisms for delivery. He thought and he shared with us that the proximity was really important before the pandemic in Singapore, where everybody is few minutes or very close to healthcare. But with the pandemic, telehealth and telemedicine became important. And finally said that the country in Singapore, and probably many countries all over the world, have a problem with performance measurement and assessment for delivery of digital health models for universal health coverage. And if we manage to do this proper assessment, then we can actually use our resources rationally, especially in low and middle income countries. Thanks very much, Mr. Shia. And I would like to pause here and ask for a stretch video, which is probably for 3 minutes. So maybe we can have this. Thank you.
Hello, we are.
I request you all if you can be standing at your positions.
Asia
Small exercise by the WHO regional office. Yeah.
Please stand up and follow our moves on this song about Southeast Asia regional flagships. But do you know how many flagships there are?
Flagships, I'm wishing for of you. Still as the read in the winter night, shadows and flashes.
One, raining the Jesus, so
Flagship two, we are leading and fleeting. Flagship four, stronger UHC.
95, moving my 6, flagship 6.
I shall emergency.
Flagship 7.
Flagship 8, and we are ending to be. Flagships, one vision for you. Stand still as the wind in a winter night. Southeast Asia has a flagships. Flagship two, we are leading and fleeting. Flagship four, strong.
Six, flagship 6.
I try emergency.
Flagship 7.
Flagship 8, and we are TV.
Thank you. So a lot of fun with learning with fun. Yeah.
Thanks very much for the Southeast Asian Regional Office of WHO for refreshing all of us. I guess representing the 8 flagship programs in such a way is such a wonderful idea and quite attractive. Everybody was involved, and I think we now know about the 8 flagship programs. Thank you very much. We'd like now to continue with the 3rd section of this session, where we listen to partner organization invited interventions from the Bill and Melinda Gates Foundation, from the OECD, and finally the World Bank. I'd like just to ask Dr. Santoush if he doesn't mind that Thanks very much, Dr. Santoush. Dr. Francesca Colombo, she has to catch a train, and she wanted to ask the Dr. Santoush if he doesn't mind that she goes first. Dr. Francesca Colombo is the head of the OECD Health Division Employment at the Labor and Social Affairs Directorate of the Organization for Economic Cooperation and Development, better known as the OECD. We will virtually listen to Dr. Francesca through a recorded presentation. Dr. Colombo, please welcome Dr. Francesca Colombo.
Thank you very much. And I'm live, I'm not recorded, I'm live here in Paris. Thank you so much also for allowing the flexibility to go first. I have two main messages from my presentation. The first one really has been encapsulated in all what we have heard in the previous presentation, and it has to do really with the importance of having an integrated digital health ecosystem. But the second one has to do with the importance of what we say sometimes in terms of skipping a generation of health reforms, particularly, trying to go beyond what we have seen in some of the high-income to make systems which are much more agile and much more delivering to the needs of populations. Sometimes in OECD countries, we have systems which tend to be a little bit too fragmented, which tend to be more based on rigid structure. And my point is really that countries which are low and middle income can actually leapfrog and try to create a much more integrated system. Very quickly, but it came out from the presentations previously that there are very, very important advantages of implementing a digital health ecosystem for improving outcomes and performance. And those can be summarized in 6 main areas. In terms of clinical practice optimization and improvements, which you have heard a lot, from more analytical precisions to improving clinical decision-making. Surveillance, whether it's related to public health interventions, but also think about monitoring the quality and safety of technologies. Predictive public health, to have much more precise identifications of risk populations. Issues related to having a more system approach and ability to manage the system, reducing waste and improving performance. Empowering people to self-care, so having a much more people-centered approach, and clearly the issues of supporting research and development. And we have seen a number of progress, if we look across the OECD countries, but also more globally, which have been actually accelerated by the pandemic. So massive boost in the use of data and digital health, but also rapid changes also in the attitudes, both of workers as well, healthcare workers, as well as individuals themselves. Unfortunately, though, we still have a long way to go, and there are many, many barriers that remain. They relate to digital divides, and we have heard about them. They relate to the difficulty to implement good governance, a digital governance, and a more coherent strategy. And I have 3 next slides in which I want to point to some 3 areas in which there has been progress, but much more remains to be made, learning from the experience of OECD countries. The first one has to do with telemedicine. Through COVID-19, we've seen a huge accelerations in OECD countries in the use of telemedicine. Think that before COVID-19, only 4% of total health services in OECD countries were delivered through telemedicine. And this was skyrocketed during COVID-19 to the extent that in some countries, up to 70% of individuals had consulted through telemedicine. So really huge acceleration of 40% across the countries themselves. However, there are still important barriers which tend to be institutional rather than technical to accelerating the use of telemedicine. And I want to stress this one because our experience has been that it's not issues related to connectiveness or to digital technologies, but it has to do more with barriers linked to payment systems, to legal framework, and to regulation. So those institutional barriers can be much more important in enabling or in putting a break to the use of telemedicine. Second example has to do with the ability to use data across different silos. for the benefits of patients, providers, and populations. And it has to do with the ability of countries to link different data sets in order to have a more integrated approach, an integrated look at what happens for patients across the entire pathway of care. And if we can focus here only on the lighter blue bars, this shows different countries, and it shows the percentage of the available data sets in those countries, which is actually regularly linked. And you see that in a number of countries, that percentage is really quite low. So even in some of the most advanced countries, the ability to link data sets at the individual level to improve quality, outcomes, patient-centeredness, and so forth is limited. And this points to the importance of privacy respectful data governance and areas in which more progress needs to be made. And the third example, which I want to do, has to do with healthcare workforce. We have seen in OECD countries how skill mismatches represents a significant break to the use and accelerations of digital tools. So only between 30 and 70% of health professionals report having knowledge and skills, having the knowledge and skill shortages, which relate to use of digital tool and data analytics, but also look at the lack of involvement. So many of the healthcare workers see some of those tools as a black box. So the importance really of bringing also workers on board through improving their skills and their involvement into the development of digital tools themselves. So what is needed really to move on is an approach which is much more to do with a digital health strategy, which is comprehensive, and highlighted here are some of the important pillars of that: an integrated health information system, comprehensive health data governance, so this privacy respectful use of data, standardized and coherence and available health electronic medical records, but digital tools more broadly, and an empowered and trusted governance. We think that having those pillars for a digital health strategies are much more important than focusing on specific individual digital solutions. Now, we have done some costing of the returns on investments from investing in that more comprehensive digital transformations. And we have seen that for the OECD countries, for each dollar or euros which is invested in the digital transformations, up to $3 can be expected in direct economic benefits. And those have to do both with efficiency dividend for health system, as well with the health dividend for health systems. So it just gives you an idea of how that more integrated ecosystem approach can deliver very good returns of investments. And that concludes really with the key messages which I have. Clearly, digital transformation is fundamental for universal health coverage and all those benefits which I alluded to at the beginning. And the digital transformation is not really about digitalizing existing processes. It has to do with having a coherent strategy, a coherent approach, a coherent governance, as well as capacity for both the health professionals and for all the stakeholders into the systems. There are opportunities for countries in low and middle income countries to leapfrog and to skip generations of reforms. So learning from some of the mistakes in terms of rigidities and fragmentations that we have seen in OECD countries. And clearly those smart investments have very healthy economic returns. And with that, I stop and just some link to some of our work. Thank you very much.
Thanks very much, Dr. Francesca Colombo. She's the head of the OECD Health Division Employment, Labor and Social Affairs Directorate at the OECD. Thanks very much, Dr. Francesca Colombo. She actually spoke about towards integrated digital health ecosystems and universal health coverage by the year 2030. She shared the right of the importance of digital health investments for clinical care, surveillance, predictive public health systems, empowering people to self-care, as well as research and innovation. She said that the countries of the OECD have learned from the experience of digital health applications during the pandemic, especially telemedicine, but the barriers were mainly institutional rather than technical. She also spoke about the importance of universal healthcare in integration across services and secondary data users. But she also spoke to us about whether the health workforce is ready for digital transformation and digital applications, and that the study they did found out that only 30 to 70% of the workforce knew about the digital applications and were ready for their implementation, and there was lack of involvement of many of them. She shed the light on the importance of having a strategy with clear objectives when it comes to digital transformation through integrated health information systems, trusted governance, especially for data, and the importance of electronic health records. And finally, she spoke about the cost effectiveness of digital health in healthcare delivery and universal health coverage. Thanks very much, Dr. Francesca Colombo from OECD. And now I have the pleasure to introduce Dr. Santhosh Mathew, the country lead of public policy and finance with the Bill and Melinda Gates Foundation. Please welcome Dr. Mathew.
Thank you. I just want to applaud both the Ministry of Health and Family Welfare and WHO for convening this, but also call out especially Additional Secretary Love Agarwal and Manoj Jalani, not only for this convening, but all the work that has gone into making India such a digital ready place for interventions. I also want to recognize J. Satyanarayana, who's here, who actually played a fundamental role in actually helping India take this forward. I want to start by a little bit of myth busting. The myth busting that I want to do is with reference to the belief that many people have that you need 100% internet coverage, you need 100% ownership of smartphones, and you need literacy to be able to leverage digital health for universal health coverage. I'm going to try and produce an imagination for you, which will hopefully get you to be more sympathetic to my viewpoint. Imagine a 70-year-old woman who lives in a village in the district of Bastar in the Indian state of Chhattisgarh, where there is no internet. Imagine that she is illiterate. Imagine that she does not own a phone, forget a smartphone, does not even own a phone. But she has access to an operation center, which has got a toll-free phone number. She's experiencing headaches for the last 15 days. She borrows a feature phone from somebody in the village. Happy to lend it because it's toll-free. In fact, if you want to incentivize it further, you can even have a national program by which you will put talk time into the phone, from which phone calls emerge that lead to substantial solutioning of somebody's individual healthcare. It's possible to do that, but let's drop that for the moment. And then she says, Beta sir dard ho raha hai. Son, I'm having headaches for the last 15 days. This woman or gentleman who's receiving the call is not a trained clinician, but she has access to a triaging system, which is an adaptive question engine, which in normal parlance would be called a symptom checker, which actually asks very carefully curated questions. The 8th question will depend on the answers to the first 7, and the 9th to the answers to the first 8. What this produces is not clinical decision support. What it does is that it populates an electronic health record. And what it then enables is effective choice for the care or wellness seeker, which is a determination and advice that you will actually need immediate care, possibly a stroke, but needs to be ruled out. The ambulance is triggered. The stroke team is alerted. The electronic health record, which probably had nothing in it prior, was being populated as a result of this triaging is transferred to the stroke team, but actually the MRI operator was not available at that time. That's the system is able to determine. A motorcycle is dispatched and somebody from a distant facility is actually transported to where this woman will then be transported. By the way, I'm saying this is imagination, but in Rwanda, this is what they do through an intervention which is powered by an entity called Babel Rwanda. In India, in Kolar district, one part of this has been working for more than 4 years. It's called the Digital Nerve Center. And what they do is that this call is open to every resident, 10 lakh residents of Kolar. They're able to offer teleconsult, and they're also able to offer credible appointments in government facilities. Ladies and gentlemen, this is something that is eminently possible today. But what is more powerful about this is that if we go down this pathway of imagining how the patient or a wellness seeker can actually leverage this, then we can actually make this much more politically salient and realistic. But there are 3 things that are missing for this to happen. Number one, we do not as yet have an effective triaging engine that governments can use, which is a digital public good. The private sector does have. I am aware of a number of companies that offer very substantially adequate quality of triaging. I'm not talking of CDSs or a clinical decision support system, but which has the ability to populate the case history of the patient. You go to most patient, OPDs today, what you find is doctor writing 3 tests and 4 medicines. But the clinical history, which is part of your second year MBBS training, that's almost universally absent. And you cannot, and you don't need to have, voice to text. You don't need medical transcription. You don't need a data entry operator if you actually have this sort of a triaging system, which is centered on an operations center. But the most impactful use case of the operation center is that suddenly this person becomes trackable in the entirety of your health system. I don't know how many of you have used something called the Flight Radar 24. Flight Radar 24, thank you, sir. Flight Radar 24 gives you the picture of every moving aircraft in the world. You click on it, it will show you the picture of the aircraft. It will tell you what time it was supposed to take off, what time it actually took off, where it's currently located, and so on and so forth, metadata. Why can't we think in terms of leveraging, and I mean, all of you are going to get a chance to see that, which is the National Health Observatory, which is there in the Ministry of Health and Family Welfare. Why can we think of, spawning local district versions of that, which are the equivalent of the Flight Radar 24, where every woman, man, child, and infant is tracked through a traffic-like system. If they reach out to you, it's blue. If you deliver with quality and time, it's green. If you fail, it is red. If you're getting close to failure, it is amber. And then at the end of the week, can we actually get the district health team to analyze all the reds for the week and do a root cause analysis of why the system failed each of these people who turned up as red in the district equivalent of the observatory? I believe that this sort of a system can deliver immunization services, family planning services, NCD screening, not deliver, trigger, monitor, ensure that service delivery failures do not happen, antenatal checkups, appointment with doctors for ambulance and diagnostics. But for that, as I said, the triaging system, which is a digital public good, is missing. Number 2, many countries are unable to offer appointments. Can you book an appointment nationally? And this is not a digital question. It's actually a policy question. Today also for example, tremendous progress has been made in eSanjeevani, and they're about to launch, as I understand, an appointment system where soon in 2.0, when it's operationalized, you will be able to actually book a doctor. Today, scan and share, you have to go to the hospital to be able to get onto the queue. You can actually get onto the queue from your home. You can get yourself triaged from your home. Your clinical health record can be populated from your home. So when the doctor and the patient meets, the doctor or the clinician has the complete case history of the day. And if you have a longitudinal health record, all the rest that you need to make appropriate clinical decisions. But at the end of the day, you need to be able to produce this in a politically salient offering. And there I would urge us to think in terms of 4: doctors, ambulance, drugs, and diagnostics. A doctor appointment in 20 minutes, an ambulance in 40 minutes. If drugs are prescribed and if the facility cannot deliver it to you, delivered through a courier system in 48 hours or 24 hours, and firm diagnostic appointments. Can we make it possible for the political leadership of our countries to make this as a political promise that people can touch and feel, can hold them accountable, can reward them? Promise, deliver, reward. If we can make this happen, that's when I believe that the true promise of digital and the true necessity of universal healthcare will actually happen, because then the 6 things that we need will get unlocked: finance, human resources, supplies, data, facilities, and the attention that is required to generate demand. Thank you.
Thanks very much, Dr. Santosh Matthew from Bill and Melinda Gates Foundation for a very lively presentation, I have to mention, and the importance of telehealth and telemedicine in modern times, especially for remote, suburban and rural settings, as he has described. He also mentioned that there are challenges for the system he was describing, including a public effective triage system, an appointment booking system, and he was calling for a system which enables doctors, ambulances, drugs, and diagnostic appointments to be integrated and interoperable in order to meet the challenges for digital health, including finance, human resources, supplies, data, facilities, and attention, and hence the importance of leadership and investments in this regard. Thanks very much, Dr. Matthew. Yes, please, Mr. Agarwal.
Thanks a lot. I think let me thank Santosh Matthew, sir, for raising this point. Just to tell all the delegates present here, triaging tool is already operational in eSanjeevani from 13th of March onward, and 700,000 calls have been done in this country where this triaging tool is operational. Not only that, we have even converted eSanjeevani into multiple Indian languages. And the other thing is that the triaging tool we are using is AI enabled. So through this, we are also going to create a mechanism where a AI enabled clinical decision support system will also be created for multiple diseases in the country. So thank you. But I think, ideas like these are very important because these ideas give us food for thought of how we can make things better. Thank you.
Thanks very much, Mr. Agarwal, for your intervention, which was really called for at the right moment. The last but not least speaker is actually from the World Bank. I'd like to welcome Dr. Ajay Tandon, who's the lead economist with the World Bank in Washington, D.C., who previously worked with the Evidence-Informed Policy Department of the World Health Organization. Dr. Tandon, the floor is yours.
Thanks very much. I recognize I'm standing between lunch and the end of the session, so I'll make this very short. I think most of what I was going to say has already been said, but wanted to start by saying thank you for inviting us to participate in this digital health conference. And I think the first point I want to make is it's important to look at not just the title of digital health, but digital health for what? And this is really about universal health coverage. Digital health is not the end, it's a means to an end. And the end here being, how can we use digital health in order to accelerate progress towards universal health coverage? And we at the World Bank recognize the importance of digital health as a very key and important aspect of health system strengthening. We believe that there never has been a moment in time like this one to harness the potential of digital tools and technology and data to accelerate the transformation of health systems around the world in order to make progress towards universal health coverage. Just as a reminder, I think as Mr. Agarwal pointed out, universal health coverage is the goal that everybody should have access to the range of preventive, promotive, curative, palliative, rehabilitative services of sufficient quality to be effective, but also that people don't suffer financial hardship in the process of seeking care. And I think it was amongst all the speakers so far since the morning, I think it's only Mr. Agarwal that mentioned the point that one key aspect of universal health coverage is that the way in which a health system is financed matters, and that we need to ensure that not only is there service delivery that's enabled with digital health, but also that it enables a reduction in payments at the time and place of seeking care, a reduction in out-of-pocket spending. No country in the world has made progress based on a health system that's financed out of pocket spending. We need to move towards more and more public financing, or more accurately towards compulsory prepayment and pooling mechanisms in order to make progress, especially in light of the NCD agenda, where we now have conditions that are very slow to onset, often go without symptoms, and that you may have to take medication for hypertension or diabetes for 30, 40, 50 years of your life. So the need for tracking, as also Dr. Matthew pointed out, potentially a revolution in the making. And also the need to ensure that all of this is done in a very cost-effective manner. COVID-19 was not just a health shock. COVID-19 was also a massive economic shock, the likes of which the world had not seen in the past 100 years. And just as we have long COVID in some people, there is also the longer term lingering effect, economic effect from the economic shock of COVID that's happening. A lot of countries, actually almost all countries in the world, saw their economies contract in 2021. However, government spending didn't go down, rightfully so. So there was a lot of deficit financed increase in public spending, including for health, for social protection. The problem is that a lot of that increase in debt that occurred is now having to be paid back. And so a lot of countries, including in the Asia Pacific region, are struggling with a mixture of macro, fiscal, and debt related struggles. So even more important for us in the health sector, to demonstrate that we are being effective and being cost effective, we have to compete for scarce resources. The education sector is asking for money. There are other sectors that require legitimate investments as well. And so we need to be recognize that we are also having to demonstrate not only how well we do in our own sector, but also how we contribute to making investments in other sectors more effective. A couple of other points, I think in recognizing the importance of digital technologies, I think it's also important, as others have already pointed out, that we also reflect on what has not worked in the past concerning digital health. And there are some key challenges that remain that have already been mentioned: the issue of immense fragmentation, of lack of data governance, focus on technology as opposed to healthcare. Really, what is the technology being used for? That continue to need addressing, and also need more evidence in terms of what works and also how it works, and how it's working to enable a much more human-centered design, so that you're actually focusing on really the outcomes that we are focused on. So that's why we at the World Bank, we believe that what is needed is digital in health rather than just digital health. That's an approach that's needing a move away from seeing digital health as a separate vertical intervention, but really looking at digital in maternal health, digital in supply chain, and digital in health financing and all the other components of a health system, and spanning the continuum of care, also looking at prevention and promotion in addition to curative care, and really to also to work with countries as to define what their health needs are, and also to help leverage digital health technologies for last mile coverage in order to, as somebody pointed out, to leapfrog and to reduce inequalities that remain in healthcare. So I'd like to just stop here and say thanks again, and we look forward to participating in these two days of this digital health conference. Thanks very much.
Thanks very much, Dr. Tandon, for your important presentation from the World Bank. You emphasized the importance of digital health, universal healthcare across the different levels, whether primary, secondary, or tertiary, and different types of services. And he also emphasized the importance of how money is spent. And obviously, he mentioned that the COVID-19 pandemic was not only a health crisis, but also an economic crisis, and that we should learn from our mistakes and build accordingly. And finally, he mentioned the importance of investments of digital in health rather than digital health, the importance of investments in maternal health, supply chain, and finance. I would like actually to thank all the speakers, but invite maybe one or two questions from the audience. Please mention your name, your affiliation, and to which speaker you'd like to address your question. Any questions, please, for the speakers? Yeah, Mr. Agarwal, please.
Thanks once again. I just wanted to also request, when I was mentioning few of the ongoing IT initiatives in the country, I would request all the distinguished delegates. We could not bring all the ongoing IT initiative for display, but there are 15 counters here in this hall and just outside, where few of the ongoing IT initiatives of the country are exhibited. Just for example, the NCD portal, where the 5 non-communicable diseases name-based are monitored across the country, to how blood banks are monitored, to how the field workers take care of working with the pregnant women. And outside, we have one counter indicating how the National Resource Center for Electronic Health Record Standards is creating a movement in terms of those standards get implemented in the IT application. And another counter indicating few of the ongoing artificial intelligence related initiatives in health sector. So I would really request that these displays are available for all the distinguished delegates to just go through them. And also very important to all the CRO countries which are present here and other regions, we would be willing to work on the whole concept of working together, convergence, that any of the initiative which you think we can learn from you, we would like to know and engage that in India. And similarly, any of the initiative we are doing, they are available as digital public goods to be made freely available to the world. We'll be willing to work with those countries and those regions. We can, as has been mentioned, that no one size does not fit all. If these software need to be customized, we are willing to work with those countries also. We can customize them for those countries or those regions, so that wider usage of technology can take place, which is what India's G20 presidency has kept the aim in front of itself. Thank you.
Thanks very much, Mr. Agarwal, the Additional Secretary, Ministry of Health and Family Welfare of the Government of India. Appreciate it indeed. During this session, we listened to 8 speakers. We first started with 2 keynote speakers, Mr. Lav Agarwal, the Additional Secretary of the Government of India, Ministry of Health and Family Welfare, Dr. Kinok Park, Director of Data, Strategy and Innovation in the Western Pacific Regional Office of WHO. And then we listened to the countries with ministerial delegates and invited interventions from Bhutan, Netherlands, and Singapore, Dr. Dashu, Dr. Marcel, and Mr. James. Then the final section was from the partners in digital health globally, the Bill and Melinda Gates Foundation, the OECD, and the World Bank. We learned a lot from the speakers, and I think it's time that we move into integration of digital health into our health systems, especially on primary care, to digitalize with strategic action plans, looking towards increasing coverage, financial protection, health for all, and hopefully this health for all is by all stakeholders. And the importance of leadership has been repeatedly mentioned by all speakers, and the importance of investments on organizational, human resources, financial, and technological resources. And ladies and gentlemen, we hope that digital health would help universal health coverage for equity, equality, and no financial hardship for anyone across the world. Thank you very much.
Thank you, Dr. Mendel. Thank you to all our speakers, and thank you everyone in the audience also. With that, we close this session, and we now invite you to please join us for lunch. It's going to be a 45 minutes break for lunch. 1:30, we are going to be reassembling here for the next session. That's on digital health at population scale, strategic enablers. During this lunch break, if you get time, you're requested also to kindly pay a visit to the various kiosks, as was mentioned by Mr. Lava Agarwal. We have the various IT initiatives which have been taken. You can have a look at that even outside. And 1:30, we start with the session. Also, in case you're interested in the field visit to the National Observatory, you're requested to kindly have yourself registered outside. Thank you. Enjoy your lunch. The lunch, ladies and gentlemen, is in the same place, same hall, the Allure Hall where you had your tea.
आने के लिए बोल दिया शायद It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision of that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remain unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs when no one is left behind.
Santa Vastante Depurani la Titani Vastoga Santa Sudan. Lisa Bantara Caderte, and Kevastan Santa, Santa Tiwan.
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव से आए सयान सदनमन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, समस्याओं का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें।
The health worker can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है, जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडेड चेकअप करना रहता है उसके लिए हमारे पास उनके प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं, उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिलती है।
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Haat Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारा नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CHC रहेगी वहीं बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहाँ तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई थी इस डेट के दिन, इस बाजार के दिन में हमारी वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as Ashas, or community-level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं, अगर अस्पताल जाना नहीं चाहते हो तो बाजार में जाने से क्लिनिक खुला है, वहाँ जाके चेकअप कराइए, सब बोलते हैं।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
परेशान बहुत ये जितना मन सुस्ता, ये पैर में सुस्ता था, ये पूरा शरीर का मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोल के, अभी तब से वो दवाई मन लेता, अभी तो रखी था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वहीं बाजार में करा लेते हैं। बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Haat Bazaar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the health care they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Wellbeing for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government's actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remain unheard in government's decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation for UHC provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind.
सीधा सीधा आ जाओ।
संत वस्तान देश पुरानी इलाज kita nih mas oh bukan sudah ini saban saro kader kita ke waktan santa santa satu iPhone.
Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव-गांव से आए श्रेयांत जगमन आया दीदीमन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, का निदान भी मुख्यमंत्री हाट बाजार योजना के साथ करें।
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है जिसमें हम लोग हाट बाजार में आते हैं जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते जो अब मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिलती है।
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Heart Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CHC रहेगी वही बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहां तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में हमारी वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as Ashas, or community-level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते हो तो बाजार में जाने से क्लिनिक खुला है, वहाँ जाके चेकअप कराइए, सब
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
मैं तो परेशान बहुत, ये जितना मन सुस्ता, ये पैर में सुस्ता था, ये पूरा शरीर सब मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोल के, अभी तब से वो दवाई मन लेता, अभी तो रखी था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Bazaar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines has improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. better logistics to reach the most distant health centers, stronger regulatory systems to ensure quality and safety, apply intellectual property rules that promote access to affordable medicines, more research and innovation to meet changing population needs, track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's our vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Wellbeing for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, people's insights and lived experiences remained unheard in government decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation, for UHC, provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. More influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind. Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Heart Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Heart Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Heart Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव से आए श्रेयांक कदमन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, समस्याओं का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें।
The health workers can identify illnesses in their early stages in the communities with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है, जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडेड चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं, उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है और उनको यहाँ पर फिजिकल मिलती है।
Convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Heart Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PHC CHC रहेगी वही बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहाँ तक हम हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के ट्रेनिंग के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में हमारे वहाँ स्वास्थ्य सुविधाएं प्रदान की जाती है।
Vitamins, also known as ASHAs, or community level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं, अगर अस्पताल जाना नहीं चाहते हो तो बाजार में क्लिनिक खुला है, वहाँ जाके चेकअप कराइए।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
परेशान बहुत ये कितना मन था, ये पैर में सुस्ता था, ये पूरा शरीर का मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोलते, अभी तब से वो दवाई नहीं लेता, अभी थोड़ा ठीक है।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं और टेस्ट वगैरह वहीं बाजार में करा लेते हैं।
बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Hard Bazaar Clinic is a step towards reducing extreme inequity in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines is improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone, everywhere can access the health care they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety.
Ladies and gentlemen, good afternoon. We, in a short while, will begin the post-lunch session. You are please requested to head towards the conference hall. Those outside the conference hall, please, it'll be most very kind if you come inside and take your seats. Thank you. Good afternoon again, ladies and gentlemen. Ladies and gentlemen, may I please request you to take your seats inside the conference hall. We are about to begin the post-lunch session. Thank you for your attention, ladies and gentlemen. We are about to start the post-lunch session of this global conference on digital health, co-organized by the Ministry of Health and the World Health Organization's regional office. This is Gautam Basu, and it takes me great pleasure to walk you through the calibrated discussion sessions that we will have for the rest of the day and for tomorrow. Excellencies, distinguished participants, honorable guests and delegates, colleagues, ladies and gentlemen, on behalf of the organizers, I welcome you to the post-lunch session. I'm sure you've enjoyed your lunch. There was literal food, and now for some food for thought, metaphorically. May I have the pleasure to invite Dr. Nima Asghari, who is Director, Asia Pacific Observatory, hosted by the Regional Office, to please join us on stage to moderate the post-lunch session. I have great pleasure in inviting the keynote speakers for this afternoon. Dr. Kiran Gopal Vaska, Executive Director, Ayushman Bharat Digital Mission, National Health Authority, Government of India. Dr. Vaska, please. I have great pleasure in inviting Dr. Garrett Mahel, Unit Head, Digital Public Health Technologies, WHO Headquarters, Geneva. My pleasure in inviting Dr. Nuriyati Rusli, Deputy Director General of Health, Public Health, Ministry of Health, Government of Malaysia. From the Sultanate of Oman, Dr. Wasan Muhammad Abduraz, Director, E-Health, Ministry of Health, Sultanate of Oman. Mr. Oleg Sonin, Deputy Head, Department of International Affairs and Public Relations, Ministry of Health of the Russian Federation, will join us virtually. Welcome, Mr. Sonin. I have equally great pleasure in inviting our partner organizations and their representatives, Dr. Surakamet Mahasiri Mongol, Strategy and Planning Division, Ministry of Public Health, Thailand, on behalf of Converge. Are you there, Dr. Surakamet? Dr. Surakamet will join us virtually. Welcome. And Mr. Jai Ganesh Uday Shankaran, Executive Director of the AHIN Network. Dr. Jai Ganesh. And our next distinguished participant, Mrs. Kachina Chola, Acting Health Office Director of USAID India Office. Mrs. Chola, please. Ladies and gentlemen, with that, I hand you over to Dr. Nima to conduct the rest of the session. Thank you, Dr. Nima.
Thank you very much, Gautam. And good afternoon, everybody. And thank you for joining us either online or in person for this next session. I think we don't have enough chairs. Can we squash a bit more? Thank you, and good afternoon, everybody. Thank you for joining us in this first post-launch session. I'm hoping that we'll have a lively discussion and the effect of the launch will not be on our sleep. My name is Nima Asghari. I'm the director of the Asia Pacific Observatory on Health Systems and Policies. And for those of you who don't know, APO is a partnership of WHO, Wipro, and Zero, as well as World Bank, ADB, the Pacific Community, and 5 countries from Asia, which focuses on health system research. That's my plug out of the way. This afternoon's conversation is going to be around digital health and population at the population scale. And I think we're going to have 6 or 7 key topics which we'd like to cover. This is about national digital health strategies and the roadmaps, legislation and policies, be that about management of the data, innovation policy, use of digital health with public-private partnership, and health system reforms, which are necessary as part of that. It'll be about capacity building of the actual health sector staff in using it, as well as digital health literacy across the whole wider community. And we'll finish with the institutional framework and the multi-sector engagement, and try and see if we can bring in issues of special challenges for middle-income countries and low-middle-income countries. To begin with, I would like to ask Mr. Kiran Gopal Vaska to present his experiences, his views, his challenges, and his future vision when it comes to digital health. Mr. Vaska is the Executive Director of the Ayushman Bharat Digital Mission. And for all of you who don't know, that's that cubicle over there on the right side. It's part of the National Health Authority in India, and is responsible for designing strategy, building technological infrastructure, and implementation of National Digital Health Mission to create the National Digital Health ecosystem. So it's a pretty all-encompassing mandate. And we heard Mr. Lal Agarwal talk this morning about some of the achievements, and I think hopefully we'll hear now about the ins and outs of how those were achieved, some of them. And Dr. Vaska, before he joined the Ayushman Bharat Digital Mission, he was the Mission Director for National Health Mission in Madhya Pradesh. Floor is yours, sir.
There's a clicker, right? Okay. Thank you very much. So my mandate for the afternoon has been to speak about the strategic enablers in implementing digital health at population scale. And that is something we are trying to achieve as part of the Ayushman Bharat Digital Mission. So I will briefly try to talk about what are these enablers, mainly 3 of them to begin with, because some of them would be covered by Dr. Mahil in his note, and also share you a little bit of experience about what we are doing at the National Health Authority to cover or leverage on those enablers. So these are basically the three enablers that I would be covering. One is about having a strategy and roadmap. And I think it's a no-brainer to say whether we should have a strategy and roadmap or not. Of course, we should have one that gives a clear vision, mission, and purpose as to what we are trying to achieve. I mean, this kind of clarity at the very beginning is something that can give all the ecosystem participants a clear understanding of what their individual roles are and what is being tried to be achieved as part of this. And then one of the most important factors in achieving or implementing digital health at national scale is the regulatory framework. I mean, without a proper regulatory backing, we can only go so far. So I'll try to cover that. And finally, engaging with the ecosystem. I mean, digital health is something new. Digital health has been there in silos, in islands of excellence in some private hospitals, but then having it at a population scale, expecting the last mile, the last person in the queue to understand and appreciate and avail the benefits of digital health requires engagement at a different scale. So in terms of strategy and roadmap, the overall strategy for digital health requires, in our opinion and experience, 4 key components. One is a mission and vision. Like I said, what is the digital health initiative, what it intends to do, and objective and the desired outcome. So, I mean, is it about building a software for the country? Is it about building a framework? Is it just about trying to create a digital ID for everybody? Or what is it about? And what is the ultimate objective? I mean, patient centricity, and what are we really going to achieve? And as the overall title of this event and the objective talks about, the idea is taking universal health coverage to the last citizen, right from primary to secondary to tertiary. If we were to bring in insurance as part of it, how is digital health going to help bring in insurance, make it more affordable, and make it more easily accessible? How are we going to help doctors and physicians and experts who are located far away and may not be present in every nook and corner of a country to be able to provide their expert advice by using digital means. So the clear vision and mission is something that is the primary thing. Another is about the strategy. I mean, what would be the scope of it? Like I said, is it that the country is trying to build one huge software and store the entire data in one single database and then do some analytics on top of it and make everything free and will the country run the whole thing on its own? And what would be the scope? I mean, in terms of scope, would it be a national effort? Would it be a regional effort? Would it be divided into national, subnational entities, and then there would be some sort of amalgamation at the national level? I think the integrated and then what would be the role of private players? What would be the role of different stakeholders such as regulatory bodies who have already been regulating the health space already? And then how is the citizen expected to join this? And then having a blueprint. I think the blueprint is where the architectural part comes in. I mean, it actually something that lays down how this whole implementation of the digital health is going to be. What are the layers? What are the foundation layers of it? What are the application layers? And what are the final presentation layers which are going to interact with which the users are going to interact with? Are we going to leverage any existing public goods or digital goods that a country already has? Or rather, what are the essential prerequisites for running a digital health or implementing a digital health strategy for a country? And then finally, a roadmap. How do we want to achieve it? And how quickly we want to achieve it? There are some agencies or some entities who may be already digitized, but then how do you bring them onto our fold? Is there a timeline for it? So I think with these four things in mind, I think a strategy and a key component of the whole strategy comes into play here. So, like I said, and in order to come out with a robust digital health strategy, we feel that these are some of the key components. One is collaboration. It is given that if you want to implement something at population scale, no government can do it on its own. You need to collaborate with every player in the ecosystem. Liquidity of knowledge. Unless there is easy flow of information between one entity to the other, unless there is co-creation, it would be not possible. Then leadership and governance, it would be important to have a buy-in by the national level leadership and also to have an agency or an authority which can actually drive it and run it. Participation, like I said, engaging everybody is in the ecosystem is an important part. And then finally, how do we create interest and investment in this initiative so that the money flows in? At the end of the day, we need digital health solutions to be used, to be built, and then there's some value created out of it so that there is continued sustainability in it. So if we were to trace India's journey in the digital health strategy, the National Health Policy 2017 was the first time where it advocated deployment of digital tools in finding solutions for or enabling universal health coverage for every citizen. It aims at integrating health. It aims for creation of an integrated health system, and also mentioned for the first time the setting up of a national digital health authority to regulate, develop, and deploy digital health. I think this is the beginnings. And then came the National Health Stack, which actually tried to bring together all these thought processes in one place, where it said, what are the different entities and what are the different parts of digital health that need to be developed. And finally, the National Digital Health Blueprint. In fact, Mr. Satyanarayana, who is sitting here among the audience and who would be the next speaker, in fact, was part of, in fact, he was the one who led the team who built the National Digital Health Blueprint for the country, where this blueprint provided the architectural vision. It provided what are those building blocks, what are those registries we need to have, what are those exchanges we need to have, and then how the data would be stored, and what kind of an architecture would be used for data, and what kind of a governance is required. And finally, the NDHM strategy overview laid down clear plans, which then started the first pilot in the country. So this is the evolution of the Ayushman Bharat Digital Mission. Like I said, the health policy came in 17, July and July 2018, the National Health Stack came in. By 2019, we had the Digital Health Blueprint, the telemedicine practice guidelines. Believe me, this was one of the turning points in actually enabling digital health in the country. Until then, it was a black box. Until then, there was no clarity as to what would happen if a doctor sitting in Maharashtra gave a counsel to a patient sitting in Uttar Pradesh and something goes wrong. So then came the pilot, and then today is where we are, where we have created digital health IDs for almost every 1 out of 4 persons in the country. And we have linked more than close to 300 million records, digital health records. Next, so that finally give you to the IBDM overview and the mission and guiding principles, where the technology and policy had clear guiding principles with the buy-in of the government. And with this force, we are able to implement the digital health strategy in the country. Regulatory framework. When we talk about regulation, the first thing comes is a negativity about it. Regulation, I mean, you are trying to stop somebody or you're trying to control something. But I would say, first of all, a regulation helps to build trust and confidence, to build, to adopt and invest in an ecosystem. I mean, unless you do not know where this particular sector is going to go or how it is going to be controlled and managed, it would be difficult to ask people to come in and join us. Secondly, when we are dealing with something as important as health data of individuals, securing and ensuring that the data of the individual is secure, and the data stewardship or the responsibility of the different ecosystem players who are dealing with health data are very clearly defined. And then there should be a clear pathway as to how the development and adoption of digital health is going to be like. I mean, where do we start? And how is each ecosystem player, how are different health programs, different levels of hospitals going to be part of it? And then the regulation should also nudge collaboration and participation. I mean, unless there is some sort of a push, we've realized that this kind of bringing in players may not always be easy. And then accountability and transparency. The regulatory framework should also bring in that necessary accountability and transparency so that every player, every partner in the ecosystem is accountable for what he's doing. So if we really broadly look at how the 3 types of regulatory framework and 3 types of models of implementation, from a self-regulation to a fully control-based regulation and a completely government-run system to a completely market-run system, India adopted a middle path where we said we'll have a market-based regulation and government will build the rails, the private sector will run the trains. So this is the idea and this is the vision with which we went ahead. And even in spite of that, the regulatory situation in India is currently quite fragmented. We have myriad acts and laws and rules governing different aspects of it. But we are also finding that having a regulation that helps manage and regulate digital health is also an important part. And that is something that we are trying to work towards rather than trying to like plug into different parts. So some of the challenges that we are looking at it, and which probably all the countries might also want to have a look at it. In India, health is a state subject. That means the provinces are empowered to make policies, laws, and regulations on health. So in such a case, how do we deal with e-health or digital health? And then there's no clear law around privacy and protection. Of course, we are now just introduced the DPDP bill, and that is actually going to define how digital health is going to shape up going ahead. And then absence of definition of digital health. To be very honest, we still have no clear definition of what digital health is. Is it that EHR that I am creating? What is it? What exactly is digital health? So I think it is a dynamic nature of the technology is also making it challenging to create that clear regulatory clarity. So going ahead, we believe that a balanced privacy and protection framework, like I said, which is being covered as part of the Digital Personal Data Protection Bill, and having a model law on digital health. In fact, one of the thoughts, food for thought is, health is a state subject, electronics and IT is a central subject. Can e-health be a concurrent subject? Can states and and center create laws on this subject together. And then can there be model laws on top of it? And then having a digital health regulatory agency. The National Health Authority was made with a purpose. The National Health Authority was to have this kind of authority to be able to drive digital health in the country. But quite honestly, today what we do is incentivize and then request and nudge. We also need that regulatory backup to be able to push it further. So any country which would want to implement digital health at population scale would have to think on these lines. Then the ecosystem engagement. This is the last part and probably the most important part. Like I mentioned here, there are so many entities that are involved in this whole digital health sphere. Citizens, regulatory and accreditation bodies, pharma industry, non-profits, health providers of different shapes and sizes, insurance, health tech companies, and then governments, both federal and provincial. So the diversity of the ecosystem players makes it important that you deal with each one of them in a specific way. So, for example, you might have to do a consultation for some group. You might have to do an innovation challenge to bring in the best out of the tech companies. You might have to go for co-creation of certain things like building health exchanges or building standards for data interchange. Or you might need the support of NGOs. You might need the support of non-profits in pilot testing and creating those small islands of excellence, which can actually give us the necessary result to calibrate and understand how to expand the digital health intervention further. Implementing it, in fact, we have solutions. We have a digital health solution. How do you even start going to a small 2-doctor clinic and start asking him to start using that IT system? How do you even implement it? Then getting the ecosystem feedback. These microsites, how do you develop these microsites across the country to give you that feedback? What is working, what is not working? Creating awareness and incentivization are some of the areas we feel are ways of engaging the stakeholders. So for citizens, like I said, awareness. For healthcare providers, understanding the infrastructure gaps, building digital capabilities, designing a good incentive policy to be able to tell them what is the incentive for you to come into digital health. Then, and engaging with provincial governments. Like I said, it ultimately at the end of the day, it is that last mile hospital, the health and wellness center, which is serving a population of about 1,200 to 1,500 people. The community health center, the district hospital. These are the areas where this needs to get implemented. And then co-building solutions. Like I said, any architecture, any IT initiative would need the buy-in of the private sector because innovation comes from there. So how do we co-create and how do we bring in the experience they already have in doing it? And then provide them the levers to drive market adoption. And how do you foster innovation? And also, how do you partner with them for pilot testing? I'll just talk about what we are doing in some of the initiatives there also. Then for the pharma industry, because this is also another important partner for health insurance providers. I mean, insurance is probably one industry which is really looking up to what's going to happen in digital health, because they are really looking forward to the kind of transformation digital health is going to bring about in bringing down the claims cost. It is estimated, because in NHA, we also run the Pradhan Mantri Jan Arogya Yojana, the world's largest health assurance program. And it is estimated that a typical insurance claim costs about 500 rupees to process. And what is the fees you pay for an OPD center? An average fees you pay in India is 150. So if my processing cost is 500 rupees, what is the point of trying to think of OPD insurance if you want to expand it? So insurance companies are really looking forward to digital health solutions that can actually bring down this cost, bring about auto adjudication. So how do we actively engage them? Then regulatory and accreditation bodies. These are probably some of the trickiest entities to deal with, right from entities like the National Health Commission, National Medical Commission, and then different professional bodies, different accreditation bodies. But then bringing them into the fold is the key. And then non-profits. Like I said, they are an integral part and a very important entity in actually bringing about collaboration, getting to the field and doing something that you sitting at a federal level may not probably be able to achieve. And then also bringing about a consultative process. I mean, the kind of experience and the kind of feedback the nonprofit bring in becomes very important. So this kind of overall engagement actually becomes very important so that each stakeholder feels a part of it. So in ABDM engagement, we created registries. We have the health data management policy, the retention policy. We have various components such as the unified health interface, the health claims exchange. And in each one of them, we followed a consultation process where we constituted a working group that creates the architecture or the papers. And then the strategy paper with listing out the goals, the architecture, the building blocks, the proposed approach, and the questionnaire is released for a consultation. And then multiple rounds are taken so that we get the feedback, and no policy decision or no policy made by the National Health Authority has been created without public consultation, including the National Digital Health Blueprint. So that was the kind of collaborative effort that has happened. And that is why we see the numbers that we are seeing in the country. I mean, there's still a lot more to do, but creating a health ID for every citizen, 1 out of every 4 citizens, is also not a small task. And then finally, I think one of the most important things we realized while implementing the scheme for the past 2 years is creating value and interest. I mean, to quote my former CEO, Dr. R.S. Sharma, he said when they were implementing the Aadhaar program, it was difficult to explain to people what Aadhaar is going to do for them. It was just a number. It would not say whether you are a citizen of the country. You could not use it for any other benefit. You could not get your ration or your public in the public distribution system. You could not get any health benefit. But then it was just a number. So at that point in time, nobody realized it. But fortunately, it was a push. It was completely government driven. It could be done. The difference here is you need people to ask for this. You need people to accept this thing called digital health, accept this thing called a health account, accept this thing called an electronic health record, and avail the benefit of it. For that, they would want to see light at the end of the tunnel. They would not want to wait for 2-3 years down the line when it becomes it goes to a tipping point where everybody wants to be part of it, and then there is something what you call a FOMO, the fear of missing out. Rather, trying to create those use cases. And one example is the scan and share, which is currently operational in 435 hospitals across 144 districts. Close to 1 million people have used this. And the simple thing that we do here is, instead of standing in a queue, you just go scan a QR code present at the hospital using your PHR application. You get a token number. You don't have to wait in the queue. You wait until your token number is called. But then it is saving close to 1 to 1.5 hours for every person. And that is how people are getting interested. And the stickiness it creates. The PHR applications themselves have reported back that once somebody uses this app, this feature, they have never deleted that app again. They have come back, and 40% of the users of scan and share are second-time users. So I would like to end with this last thing, saying that ultimately, unless we show value to the end user, who is the final beneficiary, adoption or implementing the digital health at population scale is not possible. Thank you very much.
Thank you very much. I'm not going to summarize. There's no point. And also, we're running out of time horribly. So if I don't mind, I'm going to ask Dr. Gareth Mail to come and talk to us. Gareth is the head of the Public Digital Health Technology Unit in WHO Geneva. And he leads the work related to digitalizing WHO normative health and data clinical and public health protocols. I think he led the development of the first WHO guideline on digital health and the WHO digital classification and a whole host of other areas of digital work within the WHO. And before that, he was covering different technical areas, again, focusing on digital health to some extent in the child adolescent health. Gareth, I'm going to let you start if you don't mind.
Great. Thank you so much. It's a pleasure and an honor to be here. Terrific. If you wouldn't mind putting the slides, great. So it's always hard to follow Dr. Kiran, in part because the work that India has been doing for the last several years is absolutely amazing and incredible, and it does serve as a model for how we can even think about digital transformation at a country level on a number of levels. So I'm going to focus on deconstructing digital transformation and looking at the key milestones in the roadmap for digital transformation, borrowing from guidance and tools that WHO has developed. But I think I've just encouraged people to reflect on the roadmap, the strategy, the policy, and the other elements that Dr. Kiran has presented, in part because I think they're illustrative of the kinds of things that I'll generically talk about as critical milestones, critical foundational elements for digital transformation. I think all of us will have heard the previous speakers talk about the global digital health strategy and the main objectives, which I think are really illustrative of the need for collaboration and joint learning, the need to ensure that we have policies at the national level, the value and role of governance, and the importance of person-centered systems so that value is derived at all levels of the system by all individuals. I want to focus in on one aspect of the strategy because I think it really speaks to a number of the strategic enablers that I was tasked to speak about. And it will, I think, highlight as well a number of the different components that my previous speaker has spoken about around the need for an architecture, a blueprint, a roadmap, so that common tools, services can benefit the diversity of health sector goals and the ability to enable applications to be developed, and knowing that there is a common enabling environment. The strategy also emphasizes the role and value of standards, and that really provides a level playing field for the diversity of applications that will be developed, but also the means by which the data can be transferred and reimbursement can also take place. I'll just remind everyone, I'm sure it isn't something that any of you have thought about too deeply, but or not thought about too deeply. But I think we need to remind ourselves that the application that we're using on a daily basis that we derive value from really fits within a broader ecosystem, and that ecosystem and the application may serve a particular goal and a purpose for the user, as well as for those throughout the ecosystem. And that application may be wonderful and valuable to use, but it really is within a larger ecosystem. That ecosystem includes policies, it includes a strategy, it includes things like an investment roadmap and the architecture of a country. And it also benefits from the ability of institutionalizing and operationalizing those aspects within training programs and curricula, as well as incentivization schemes to be able to use and make use of and benefit from that application. As someone at lunch said, there needs to not only be the policies and this interoperability standards, but there also needs to be carrots and sticks, and those kinds of things help to facilitate the use of that application and its effectiveness. Applications themselves in a project really form and are able to help us understand whether a particular functionality or capability will benefit or a particular use case. And if we continue to look at a project focus within digital health, and rather than thinking about a whole architectural view, the government oftentimes finds itself in a situation of having to integrate two applications, or worse still, integrating multiple applications in a way that is financially not feasible. And so being able to have a national vision with the kinds of common services and applications that are expected, as well as the kinds of registries and the sources of truth, like facility registries, master patient indexes, as well as other services like a shared health record, become the kind of commons that enable diversity of applications to be built. It also helps to mitigate technical debt. If we continue to just add to and build on a specific software solution in a vertical way that may be linked to a particular health application or a particular time-bound project, a country is going to be taking on technical debt. So we need to be able to architect and plan for, and ultimately a country will benefit from having that, not only the national strategy, but also the blueprint and the action plan or the implementation plan in place, rather than developing specific applications and adding on new capabilities, and it becomes a real mess to be able to untangle that. Rather, having policies around standards and an awareness of what the blueprint for the national or this subnational level is a helpful guiding post for those in the ecosystem. When we break down and look at the different aspects of digital transformation, we look at different milestones that a country might be progressing through. We also look at the maturity of a country and understanding that different countries are at different stages of investment, have different capabilities in place, have different workforce capacities, and different infrastructure. And being able to build to that and understand it and ensure that we're planning for that is a really critical application of guidance. I'm going to talk a little bit about, while I only have 15 minutes, I want to make sure that we highlight a few of these different milestones and the kinds of aspects that are critical for a country to think through. A digital health strategy, we'll talk a little bit about. We'll also talk about the importance of having a national inventory of the digital assets. So knowing what you have in your country to be able to plan for the future, being able to ensure that there's an investment roadmap and an architectural vision for the country is a critical aspect. Ensuring that applications are built to specifications and standards, and knowing how to do that is critical, and having the content available. And then being able to look at and understand the needs of the health workforce and the capabilities they need, and ensuring that there is a training program in place, and that there's both pre-service and in-service training for the health workforce to be able to ensure that digital health transformation can be part of everyone's business on a daily basis. And lastly, I'll just comment on the role of the digital maturity assessment as a planning approach to be able to guide a country forward. One of these milestones I mentioned was the Global Digital Health Strategy, and this really provides as a document, it's a guidance document, but it's also a methodology for developing and implementing a national digital health vision, an action plan, and monitoring framework. This WHO and ITU toolkit was released in 2012, and it provides a systematic approach to looking at these 7 pillars, these 7 building blocks of digital health. Another milestone is understanding the inventory of digital assets within the country, understanding their maturity, understanding their function, understanding the basis of the standards they're using. The Digital Health Atlas is one approach that WHO has developed to help provide countries with a way of doing an inventory and a way to ensure that there's a consistent documentation of digital assets in the country. And by using a common metadata approach, it allows for comparability of solutions within a country, but also across countries, so that countries have governance over those assets and can plan accordingly. The digital health maturity assessment is another milestone, and it reflects on the role that WHO is bringing back to life after a pause from 2016 in the form of the Digital Health Observatory. And the Digital Health Observatory will not only have the Digital Health Atlas and the Digital Health Policy Library, but it will also have a Digital Health Maturity Index, which provides the ability for a country to assess where they're at on the life cycle of digital transformation and help guide in areas along those 7 or pillars where they can invest to move forward their digital transformation. Another milestone is ensuring that there is a national digital health architecture in place. And there are 2 documents that the WHO has released recently, the Digital Implementation Investment Guide, as well as the Building a Digital Information Infrastructure, which is also the Digital Health Platform Handbook, which provides really a basis for looking at the kinds of platform aspects of services and applications that are needed at the enterprise level to ensure that systems are able to tap into those common needs and ensure that there's a source of truth, for example, in registries, as well as there are a set of services and data storage that will enable and really provide the basis for a multitude of different applications to be built, both within the health sector and using services from across other sectors. So having that vision of where you're at and where the country would like to go can help to structure that approach. Interoperability and standards are a critical enabler, a strategic enabler for data and digital harmonization. And it can fast track digital transformation by providing interoperability standards and specifications for services and applications to be built and ensure that the content is going to be able to be exchanged between systems. But moreover, our organization, WHO, has been realizing that we need to also make available our guidance and guideline documents that we have been releasing as narrative documents, also in the form of executable content in standards. We've started to release primary healthcare and surveillance documents that provide clinical recommendations and protocols for data and public health and clinical recommendations in these formats so that digital systems around the world can make use of that content and know that it's according to spec and that it's been validated. That really tries to overcome this challenge that I think we've seen for many years in countries where they may be investing oftentimes in a single solution that's tied to a particular disease vertical or a particular project. And within that, as a vertical, we have oftentimes a proprietary data model. Oftentimes that's linked to the logic, and there's a custom platform that it's all tied together. And that becomes challenging for a country when they're trying to integrate those systems. And there's oftentimes then a need to develop a custom adapter between those systems, which is costly. The approach that we've taken, I've mentioned, is the SMART guidelines approach, which really reflects on traditional approaches that we have taken for many years in the form of understanding that we do continue to release narrative guidelines as recommendations for the best practices. But we also need to, at the second layer, we need to provide the ability to have requirements, documentation, and specifications that enable those who are building systems to build to spec. We also provide the content in machine readable standards format so that systems can be built and executed and eventually can be brought into an optimized and dynamic way using machine learning. Here are some examples of that SMART guideline approach in practice. And you can see the same content is at these different layers, but it's for different audiences. So your traditional guideline is on the far left. The digital adaptation kit, which is the layer 2, is in the purple. And we're also releasing FHIR implementation guides at the L3 level. You have a reference application at the L4 level, and you have the optimized algorithm at the L5 level. That kind of approach where we're looking at the standards and using those to define the way the data is represented and the logic enables that standardized data model, which enables then systems to be built according to standards, and it enables a country to then ensure that they have a modular nature to their development, and they can bring this into life through the architecture of the country. I want to speak to two last milestones. One is that the capacity of the national health workforce is critical, and there is a need for countries to assess where there are needs and ensure that they have the ability to then bring course curriculum to that. We have been working on a curriculum to ensure that at a minimum, those who are leaders as well as those who are practitioners have the needed skills to be able to bring their daily routines into the digital era. The digital health investment roadmap is is one aspect of an output of the digital implementation investment guide, and it provides these 9 different areas, and the document provides a systematic way of developing a budget, as well as an implementation plan, as well as a monitoring and evaluation strategy and an architected plan. And it provides the basis for really accelerating digital transformation. We have a lot of tools at WHO, but I think maybe the most important thing is to say, as an organization, we're committed to helping countries, but also working with the diversity of stakeholders that are helping countries, and to make use of guidance like this, and the kind of tools that are in the ecosystem to help facilitate a country to go from their current state to a future state that is driven by the country, and really gives them the ability to leverage their own technology in their own way, and plan for that approach and ensure that it can be sustainable and effective. So we look forward to working with all of you, and thank you so much.
Thank you very much, Garrett. So these were the 2 key presentations given this afternoon when it comes to enablers for population scale digital health issues, and we've covered the more detailed Indian, if you like, enablers, and the more global, as you said, corpus of work which is being done for WHO at WHO HQ on different areas of the digital health transformation. I would like now to ask for interventions. I believe we have 3 ministerial interventions. I would like to ask for Dr. Nora Hayati Rusli, the DG of Health from Ministry of Health Malaysia, if she would like to give her intervention, and then we'll follow that with the other 2. Thank you.
Thank you, sir. Distinguished Excellencies, delegates, speakers, and ladies and gentlemen, I am very grateful to represent Malaysia at this esteemed World Health Organization event on Digital Health Conference. First and foremost, I would like to thank the World Health Organization and also the Ministry of Health and Family Welfare Government of India for organizing this very important conference to all of us. I will be sharing my thoughts on digital health at population scale, strategic enablers based on the Ministry of Malaysia's experience. Digital health has become a critical area of focus globally, especially in the context of healthcare. The COVID-19 pandemic has accelerated the adoption of digital health, and Malaysia is no exception. Malaysia took a major leap during the pandemic by launching a COVID-19 mobile application that we call it as MySejahtera. It grew at scale, having close to about 95% of the population using the application. Listening to the keynote address by His Excellency Dr. Mansukh Mandavia, Mr. Rajesh, and all other speakers this morning and this afternoon as well, I'm very happy to note that Malaysia had a very similar experience as India in rolling out MySejahtera, which digitally traced 47 million close contacts vaccinated more than 90% of the population of Malaysia with a total of 74 million doses and virtually connected with millions of people living in Malaysia via the virtual healthcare platform. The pandemic management was augmented by this digital tool covering all aspects. Malaysia have also embarked on the electronic medical record initiative to ensure seamless flow of information among healthcare facilities and will create a lifetime health record for more than a decade now. As we have transitioned MySejahtera to a public health application, we have now enabled 32 million people living in Malaysia to book an appointment with primary health clinics in Malaysia. Other than that, we are also using this application for NCD screening, the National Health Screening Initiative, other infectious disease program, as well as for the National Immunization Program. And Malaysia is on its way to table the healthcare white paper, which outlines the 4 important pillars: transforming healthcare service delivery, advancing health promotion and disease promotion, ensuring sustainable and equitable healthcare financing, and lastly, strengthening the healthcare system's foundation. Cutting across all these pillars, harnessing digital technology would be the backbone to accelerate the Health White Paper initiative. And Malaysia certainly recognizes the potential of digital health in achieving its health goals, which includes universal health coverage and sustainable development goals. To achieve these goals, Malaysia has taken several strategic enablers in digital health. Firstly, legislation and policies play a crucial role in shaping the digital health landscape. Malaysia has formulated a health data management policy, which sets out guidelines on data privacy, security, and confidentiality. In addition to that, public-private partnerships have been established to drive digital health innovation, with the private sector providing the necessary technical expertise. Secondly, capacity building is critical to the success of digital health. Malaysia has embarked on various initiatives to upskill its healthcare workforce, including digital health literacy programs, which aim to improve the understanding of digital health among healthcare professionals. Thirdly, institutional frameworks have been put in place to facilitate digital health adoption. Malaysia established the Malaysian Health Data Warehouse, which serves as a centralized repository for health data. This allows for better data governance, sharing, and analysis. And finally, the multi-stakeholder engagement is essential for the success of digital health. And Malaysia has engaged with various stakeholders, including patients, healthcare professionals, the private sectors, the NGOs, the universities, so many others, to ensure that digital health solutions are user-centric and aligned with their needs. Malaysia is also underway to ensure challenges and digital transformation are met, such as change management, rural connectivity, infrastructure upgrade, interoperability, training, education. To be rest assured, there would be many digital divide in Malaysia. In conclusion, Malaysia's strategic enabler in digital health demonstrates its commitment to improving healthcare outcomes through technology. With a strong regional and global digital mechanism, let's go digital for the greater universal health coverage and resilient healthcare system. With that, thank you very much.
Thank you very much. Thank you. May I ask next for Mr. Wissam Mohammed Abu Draz, Director of the eHealth at Sultan of Oman, if he wants to give his intervention. Thank you.
Good afternoon, everybody. Thank you for this opportunity. And I think if we need to talk about national digital strategy, some of the people, they are thinking it is to fill this strategy, you need to bring the best digital solution, which we have it. But we live in our countries, before we make any strategic, national strategic health, we need to care about the current system, which we have it. And also we need to be part of our stockholders should be a part, all of our stockholders should be a part from that strategy. After that, we should make a gap analysis between the current system and about what we are looking about it. And we should fill these gaps before make any national strategy for digital health. Depending on that, we are working in many systems in Oman to reach this. We are in the as a basement. We have a unique and universal HIS, Health Information Management System in all over the country. This has helped us to start the unique systems. And if you need the strategic things, national strategic digital health, we need to have what's called a system which they can talk with each others, and integrated system. And also you need to have what's called the system talk with each others. And during COVID-19 dynamics, we have launched many different systems, like a system which they have through mobile application for the people to know about the vaccines, about what they have it. And also we have a national health electronic records, which will help the people to have his files, or let us to say health files, which through all the country, even outside the country, he can use it. All of this thing, if you calculate it together, will help us to understand what's the current system which we have it, and what we hope to have it in the futures. And after the gap analysis, we can come with a national health strategic things, and which will help also to have a clear roadmap. We have different stages here. As you know, in healthcare, you need to take care about everything, not only technologies. If you have technology without clear visions, you cannot apply it. This is in your countries, you will not do anything. It's not only to bring a digital solutions. Also, you need to apply it in your environment, in your cultures, and also depending on your regions requirement to fill all what you need. And currently we are working in a high level strategic with all our stakeholders to have a unique national health records, which is apart from a national health strategy. And this will help us to reach about all our needs. And currently we're working in different technologies to reach that. As I told you before, we have a national, and currently we have a national electronic health record for all our patients, which including all our citizens in Oman. And this is already, we have it, plus other systems which help us to reach our strategic national, which we are looking about it, to come to give the citizen or the peoples all his information during X-rays, labs, all these things which they have it as a record in his mobile, which they can all over country or even outside country they can use it to help them to protect themselves. All these things apart from our national health records, which we are looking apart to have a very big what's called strategic to reach the latest technologies. And this is to help us to reach this strategic things. We are using some of the technologies like FHIR, plus the other technologies, HLM, and other things which we have it. And we can say, and we're cutting a lot of things which we needed in our roadmap, which we need to reach about it. But it's our opportunity here to learn from other countries, to know what's the gap between which we have it and what are people looking to help us to reach about the best in our countries. Thank you for that.
Thank you very much. I would like us now to go to the virtual intervention from Mr. Oleg Sonin, who is the Deputy Head, Department of International Affairs and Public Relations, Ministry of Health of the Federation of Russian Federation.
Dear colleagues, I'm glad to welcome all of you virtually. Thank you for inviting me to share the best practice of the Russian Federation on introducing digital health solutions. We do appreciate. Can you hear me?
Yes, we can.
Thank you very much. We do appreciate Indian colleagues' attention to digital healthcare solutions during its presidency in G20 and are ready to support their work. And we do also appreciate the contribution made by Indonesian colleagues to mutual COVID-19 certificate acknowledgement. Our new reality is still connected with the application of anti-epidemic measures, especially in digital healthcare. The use of digital technologies has become a key tool that has quickly gained speed in its potential. The Russian Federation has made several key changes in digital healthcare sphere to overcome the pandemic. I can say that the level of penetration of new information technologies into the healthcare organization we had achieved in Russia before the pandemic made it possible to create the necessary digital platform in the shortest possible time. Its name is COVID-19 Unified Register of Illness. The register provides personalized management of each patient at all stages. This register accumulates all data in a single digital loop and is available in real time to all participants. Today, this digital platform covers not only those with COVID-19, but also those who have been vaccinated. Thus, we have a single up-to-date database for all people with a confirmed diagnosis of COVID-19 and those who are immune to it. This work is carried out exhaustively in digital format without paper documentation, and the research results immediately fall into the electronic database. Currently, this register is the prototype of a vertically integrated information system for infection diseases, which already today allows you to track the medical path of each patient from a positive test to recovery. Self-observation diaries, which each patient can complete on their own after vaccination, are an important element of pharmacovigilance. This unique interaction experience provides sustainable feedback for each patient. The registry data provides analytic for any necessary context with decomposition to the level of the municipality and even a specific data area. This allows to move away from the classic tool of regulation reporting and move on to incident management. The digital transformation of medical education has made it possible to respond to this challenge as well. We have created the medical education portal. It made possible to develop and implement interactive educational courses on issues related to COVID-19 in a short time. More than 1 million medical specialists have been finished different courses using named educational portal. By the way, it is available for any specialist from all around the world and free of charge. So you are more than welcome to use it, but it is in Russian so far. We are working on it to translate. Also, the procedures for registration of medical products were revised, which significantly reduced the time for specific discovery to the introduction of the finished product into circulation. I'm talking about new drugs and medical devices. If the usual procedure takes from 50 to 180 days, while the accelerated procedure, in accordance with the new features, takes you from 5 to 11 days to do. The accumulation of big data has made it possible to quickly create a number of digital services using artificial intelligence technology, ranging from computer vision for describing images to medical decision support system. In 2020, the first product based on artificial intelligence in Russia were registered. And in August 2022, there were already 12 of them. So in the nearest future, it will be possible to use these technologies to improve on an ongoing basis the protocols for the provision of medical care, digital clinical recommendations based on the analysis and producing of big data. Taking into account the importance of best practice sharing, in the end of 2021, the Russian Federation organized the WHO European Conference on tackling NCDs through digital solutions. The conference served as a launchpad for future research and commitment by countries to invest in digital healthcare solutions at national level. As a result of the conference statement was taken. The statement served some kind of a roadmap for regional digital health action plan for WHO European region, which was adopted in 2022 in Tel Aviv. The introduction of innovative technologies in a pandemic has become an important and revolutionary process for all participants, the patient, the doctor, and the entire healthcare system. Thank you very much for your attention.
Thank you. My Fitbit goes went off just now saying I haven't moved for the last hour. And just as it happens, I think we're going to start doing a 3-minute dance routine for everyone now. And then we'll go into the interventions coming in from partners. So I believe that's the next stage is exercise. Healthier stretch, please. Yeah. And we're on stage.
Deadly virus, all of us in shadow knees, easy hips to protect, make a check for you and me. Keep distance, not too close, check out pose, not too back, check out left, check out right, not too tight, front and back. On mask, when go out, cover mouths and our nose, no touching, no scratching, keep it clean, not deep pose. For hell of billion, so can you see? Prepare for emergency, protect what ability, sustain our stance there, and let our gain. In a way that maintain, be the change, yes we can. Left, right, left, right, left, right, left. Bangladesh, Bangladesh, India, Thailand, Indonesia, Myanmar, India, Nepal, Sri Lanka, India, Southeast Asia region. Wash our hands, wipe the germ off our hands, soap our hands, rub our hands, water we can dry our hands. Veg, food safety, eat healthy, we make our day. Exercise for benefit, keep going at the base. Southeast Asia, one region, company and for COVID mission. Start with love, start with trust, start with us, we'll win as one. Sustain our success, accelerate our game. Innovate and innovate. Get the changes we can. Bangladesh, Bhutan, Nepal, India, Korea, Thailand, Indonesia, Myanmar, Maldives, India, Timor, Sri Lanka. We are as one. Southeast Asia is one. We leave no one behind.
Thank you, everyone. And after that, we are going to Thailand for a partner intervention. I would like to ask Dr. Surakamet Mahasiri Mongkol for Strategy and Planning Division of the Ministry of Public Health in Thailand on behalf of the Converge DH to bring during his intervention. I would be grateful if you could keep it to 5 minutes, please, because we are now horribly over time. Thank you.
Thank you, Mr. Chairman. I'm sorry that I cannot attend in person. So in Thailand, we had a special program working with World Health Organization. The program is called Convergent Digital Health, which is the 5-year plan that accelerating the implementation of digital health in Thailand. The plan is composed of 5 activities. The first activity is the development of the governance body on digital health in Thailand. This is following the convergence workshop model established by several international organizations, and we were successful in establishing the government body for the digital health first time in Thailand this year, and a committee, national committee established by Prime Minister, which subsequently adopted by the Ministry of Digital and Social System in Thailand. The second is the Personal Health Data Protection, which is following the Personal Data Protection Act in Thailand, enacted in 2019, and implementation of health system were delayed until last year after the 2 years of COVID. And we look at the implementation of the Personal Data Protection Act and comply with the Personal Data Protection Act for health data. The third is about development of data standard, and we try to develop standard on 3 topics: the road traffic injury data standard, the genomics data standard, and the last one is the migrant health data standard. And once we develop the data standard for these topics, we ask all the ministries to co-develop and co-create the standard so that everyone can adopt the same standard for collection of this data in Thailand. Eventually, it will be introduced to the National Committee to announce the data standard for health. The fourth topic is about the telemedicine development. Thailand has already adopted telemedicine during COVID-19, and we continue the implementation of telemedicine by introduction of the telemedicine policy under the Ministry of Public Health. Our current permanent secretary, Dr. Opat Kankawinpong, announced the policy that every hospital should establish one digital health section. This section will be responsible for our digital health activity in the hospital in the Ministry of Public Health, and that is the telemedicine topics. And that is all the information from the Convergent Digital Health. All of this is running by a committee established and supported by World Health Organization Thailand office. This is the second year of the 5 years plan, and we hope that this Convergent Digital Health activities will contribute to the successful implementation of digital health in Thailand and sustain the digital health implementation and impact on this activity to the better population health of people in Thailand. Thank you.
Thank you very much about that point of information regarding the working of Converge DH. I would like to ask now Mr. Jai Ganesh Udaya Sankaran, Executive Director of the Asia eHealth Information Network. If you want to No, fine. Thank you.
Good afternoon. I think we are running out of time or already out of time, but I would like to share something what a regional digital health network has been doing in the last 10 plus years. And I would like to thank the Ministry of Health and Family Welfare, Government of India, and WHO for giving us this opportunity in this very important event. I represent AHIN, Asia eHealth Information Network, which is a network of volunteers. I would like to reiterate, it's a network of volunteers, and that is right now has members from 72 countries. Our primary mandate was the 2 WHO regions, that is the Southeast Asian region and the Western Pacific, but then we do have members from across other regions as well. And then our primary mandate is to actually facilitate peer learning, peer sharing, and support. Just like we are all just like any one of you. We have sometimes similar issues. Of course, how we do it in our countries might vary, but we actually are volunteers working together for our countries to achieve the goals. And problems are actually similar. Sometimes like we do have a lot of interventions. Digital interventions are plenty, but what is lacking is there are still gaps in terms of governance, architecture, program management, and standards and interoperability. And then also we find there are lots of tools and frameworks, but countries still do have problems in actually taking it to practice. Same thing applies to digital health blueprints and strategies. More often they are in the form of paper and PDF, but to be used is something that takes a lot of effort. And when there is a political transition, again, and the leadership changes, and there are issues in terms of actually how the digital health programs in the countries can actually sustain or continue. This is exactly where AHIN actually addresses. So what we do, I think I also heard about convergence a lot throughout from the morning in different forms and probably in different scope. But what we do is to organize these convergence workshops. And then these convergence workshops are led by the Ministries of Health. And we try to bring together different stakeholders in the country. It could be usually, for example, I can tell you like one of the basic building blocks in digital transformation is the digital ID. And in India, we are fortunate to have Aadhaar, but then many other countries still do not have. And there are multitudes of IDs. None of them have reached critical mass to be considered or used as a national ID. And then without that, like people are actually struggling. In such cases, actually, like we identify whether the country already has a digital health strategy or a blueprint. If they do not, we actually help them through these convergence workshops. We bring together different stakeholders in the country, including other ministries. It's led by the Ministry of Health, but then there are other ministries like Ministry of IT, Telecom, sometimes the Interior Ministry, Home Ministry, or our recent trend has been to have a ministry on digital economy. In some countries, they do have. We bring them together along with the national professional societies in medicine, informatics, and then also the industry, and then build them to see a common big picture, because everybody is working in silos. What we do is to try to achieve, we give them the templates where like the first part of the day, like for example, if you have the convergence workshop spanning 2 days, the first part of the workshop is to actually identify for all the partners or stakeholders in the country to see where the country stands in terms of the national digital health landscape. And then we actually put them together to actually agree. So who is funding what? Because we also talked about the principles of donor alignment, but then like we are trying to actually achieve this in terms of actual practice. So we try to bring all the partners together and then see who is working on what, and then how they can actually align to the National Digital Health Blueprint. So that is what we try to achieve in terms of this convergence workshops. In the last 8 years, with all humility, I would like to say we have conducted 11 such workshops. Not every workshop actually leads to something like, sometimes it takes multiple iterations, but I would like to share in the recent 1.5 years, especially since COVID, like we have had very remarkable developments. For example, Lao PDR, we worked with the government together with the Ministry of Health and then the WHO country office, Asian Development Banks and other partners. Now the country, after having this convergence workshop, we now have a national digital health strategy, which is also costed. Not only that, we also had a national stakeholder consultation where people actually committed to what different strategic projects who can actually support. This is an ongoing exercise. This is something that I would like to share. And for those countries who have already developed or have a digital health blueprint, like Sri Lanka, we help them organize a workshop that focuses on governance and program management. Because without governance or taking the blueprint into action, things that is where is the tough part. To have a blueprint is sort of probably easier, but to take it to action is another challenge. So these are the things that we have been doing. And then we have a convergence toolkit already. This is something that I could also share for the lack of time, that I can share it tomorrow if anyone who's interested. And we are also updating the toolkit based on the recent experience. So we believe in people interoperability, because I think that's the most difficult part to achieve. Once there is people interoperability, I think achieving interoperability in terms of fragmented health information systems becomes easier. So that is in short, I would like to say, because I think this is also focuses on the one of the session objectives on multi-sectoral coordination and cooperation. Thank you very much for this opportunity. I'm available to have any in-depth discussions. Thank you very much.
Thank you very much, Jai. And finally, last but not by no means least, Ms. Katrina Chawla, the Acting Health Officer, Director, USAID, and apologies for the chair issue.
We should all be standing anyway. We saw it with the children and their exercise. In fact, I think if we had made this a video, you probably would have actually heard me clearer. Thank you. Thank you to the Ministry of Health for having us here. And thank you to the WHO Sierra office as well, and Dr. Jelani as well. And honorable dignitaries on the dais, off the dais, online, offline. It is our privilege that we are here today. I am going to speak to you about what USAID is doing in this space, specifically in our partnership with the government of India. And that's why we are here as a partner rather than a government representative. Later on tomorrow, my colleague, Dr. Pritha Ramarajan, will speak from the US government perspective. So we're all here because we believe that health fundamentally can transform people's lives. And we believe in the power that digital health services provides. And we recognize that now more than ever, digital health can help strengthen and expand an inclusive and ever resilient health system towards universal health coverage. So what has USAID's journey been in this? We saw, just like all of you, there was fragmentation, there was duplication, there was recurring, investments on the same things over and over again. And we heard it all this morning. 2 years ago, USAID launched its Vision for Action in Digital Health, which really offered us a framework. How do you take a country's needs, where they are, their capacity, how do you align it with what their desired goals are in this digital era? Many of the ways to which you do that, which is enhancing digital capacity, advancing a national health strategy, a national digital health strategy, strengthening digital health architectures, and leveraging global goods has been spoken about already by my colleagues, so I'm not going to go into immense depth there. But what I am going to say, and this is why I think we stand uniquely here as a partner, is that it's about when the rubber hits the road. What do we do? How do we support? And what are examples that we've done so with the government of India in partnership? So capacity. We heard today in the morning and now the importance of it, of healthcare worker capacity. What we've also learned with USAID through our partners, the Wadhwani Institute, is that it's more than just healthcare workers, it's decision makers. When do you use digital health? When do you not use it? And there are many use cases where you should not be using it. So we work at that level. We work with data entry operators. How do you enter in data? How do you work with integrating how do you work with bringing on epidemiologists that are working at the district level to use portals that have been developed by national systems? So these are all areas when we talk about capacity, there's the health workforce, but there's just so much plus, and we have to think about that. And we work in that space. Investments like our partners NISHTA work with community health officers in how do they create digitized forms that then integrate into what we were talking about, the IHIP, the Integrated Health Information Platform. We know that ABDM offers, and Karen Sir has spoken about it, an excellent example of a national strategy. It also offers excellent examples of digital architecture. But the question is then what? And we work in partnership with the government of India and at their guidance to really think about how do we migrate legacy systems, like a strong TB control program that has NICHE. How do we migrate that and be a partnership to the government of India to help that migration to become ADB compliant? Similarly, how do we build centers of excellence in future development like AI out of AIMS across the country? And we are doing that also in partnership with the government of India. The fourth facet that we spoke about was leveraging global goods. I don't need to tell you what global goods are. You know very well what they are. The question is how? And one of the things that we've done is we're working towards several path-breaking AI solutions. And for those of you who haven't actually gone outside and seen the AI booth, I would encourage you to do so and engage with those solutions and tell us what you think about them and give us your feedback on them, because we learn from you as much as you learn from all of us. The other thing we've done is built patient feedback systems. We worked with the government of India to build Mera Hospital, which I'm proud to say now has actually moved from being an India-wide thing to also another country adopting a version of it, Sri Lanka. When COVID came, we built on top of this partnership of really strong cooperation between the government of India and USAID. And some of the ideas we built to deliver on were predictive analytics, it was population screening, capacity building for health workforce, data for decision-making, and other targeted communications. An example is the Mumbai Municipal Corporation worked with us to build a predictive analytics platform that in the waves, they could determine where they should be putting their services and not, and how they should be intervening. A couple warnings for those of you who are in this space, and I think we heard them earlier today. One is the importance of not forgetting those who aren't traditionally a part of these systems. Everyone in this room has a mobile phone. I've seen everyone on them. So the question is, what happens when we move to others? How do we build those bridge systems to bring them into the folds of this? And we've been working very strongly with entities like Hakdarshak to do so and to demonstrate what that would look like. We took something like CoWIN, this phenomenal, incredible database and digital instrument, and built what the sort of offline version support for elderly people who would not have access and would not understand how to use a system like that should look like. Those bridges become incredibly important to continue progressing further in our agendas. Similarly, we've used drones in partnership with several state governments, both in Arunachal Pradesh as well as Orissa, to deliver services and really cut down the delivery time by about half in rural and remote areas. The other piece we've heard loud and clear, which is a little harder to tackle, but shouldn't be forgotten, is the responsible use agenda. What we've realized is in some different countries are at different stages. They have different positions in protection vis-a-vis legislation and more. But what we've realized at USAID is we can't just sit around and wait for legislation. We have to work with different people who are involved with developing these systems to build that awareness around how do we deal with consent and privacy and security, and prepare us for being able to deliver these systems in the future. In terms of where I feel there's a future to be really focused on also is this question of integrating the private sector into this debate. Because whether we like it or not, in this country and many others, healthcare is the agenda of both the private and public sector. And there's massive distrust of health systems, of data-based systems by the private sector in different environments. And really, one of the things we worked very hard to do is how do we bring them into the folds? Because once we bring them, then it holds value to that patient or to that individual seeking well-being. You know, to conclude, I'll say that with multiple interventions across a variety of geographies, it's imperative that we have a culture of learning, exchanging, but not just for adapting best practices, but also for learning from failures. And we've all failed. So how can we learn from them and learn from them fast? And how can we do this to protect ourselves in a future world with emerging pandemics or other threats? It is important that rather than reinventing the wheel over and over again, we share, we collaborate to further the agenda of one Earth, one family, one future. Thank you very much, ladies and gentlemen.
Thank you, Katrina. And the private sector question was something I was going to ask, but I'm going to park it for the session 5, and I'll be moderating. So fair warning to whoever is going to be here. I'm still not involved all of those. So in this session, what we've done is that we started local. We talked about the achievements of ABDM in India. We went global and see how WHO is supporting, trusting, encouraging various member states in developing the various digital health transformation, or managing the challenges and moving forward. And then we moved to intervention by countries, by Malaysia, by Oman, by Russia, and heard a number of different solutions, some based on reaction to COVID as a push factor, some built on what was there already and doing a more analytical approach of doing a gap analysis, identify what to do and how to move forward. We heard from Thailand and also heard from Asian about different ways that WHO, in case of Thailand, has been involved in supporting digital health via the Converge DH, as well as the support network and analysis which AHIM provides. And finally, we finish with Katrina with regards to the work that USAID is doing in collaboration with the government of India at national and obviously at sub-national level. I would love to open this to Q&As, but I'm seeing coffee more. So I'm going to ask one question if anybody has any questions. Otherwise, we can wrap the session. And we can wrap the session. Thank you very much, ladies and gentlemen.
Thank you very much. Thank you very much. Ladies and gentlemen, thank you very much, Dr. Nima. Thank you very much, distinguished participants and delegates, for your interventions. We are a little past the scheduled time, So let me take this opportunity to invite you for a very quick tea break. In a session on universal health coverage, you will all agree that tea and coffee is the universal health beverage. So we'll make the most of it, ladies and gentlemen, and aim to come back in exactly 20 minutes because we have lots of things lined up for the evening session, including a field visit, cultural program, followed by dinner. Thank you, ladies and gentlemen, and see you back in 20 minutes. Please be on time.
Health is our most precious asset. It's also a fundamental human right. As COVID-19 has shown, we can't take it for granted. But the pandemic also highlighted the power of innovation. Without it, COVID-19 vaccines would have taken years, not months, to develop. Innovation is key to improving health for all. Creative ways of working, new enabling technologies, and groundbreaking social and digital solutions can speed up progress in all countries. But there's a problem. Thousands of health innovations in development all ready to go will never reach the people who need them most. The World Health Organization wants to change this by leveraging our global network of partners and countries to ensure innovation responds to people's needs. Together, we can create a culture where new ideas can flourish and innovation can deliver better, faster, affordable health services for all. Let's make innovation work for health.
We must support all countries to invest in strengthening the foundations of their health systems, and especially primary health care.
This is a moment when one can think about transforming the entire health system through a transformed and reimagined primary healthcare system. This is essential if countries are to achieve the health SDGs and provide universal health coverage.
Primary healthcare has all to do with community health. It has all to do with really engaging with the communities in the provision at that first layer and the most important of healthcare delivery.
UNICEF is working with WHO to lead the PHC accelerator within the Global Action Plan. Our country teams are working shoulder to shoulder with countries to help bring the plan to life in communities around the world.
A joint GAP mission to Pakistan earlier this year has paved the way to strengthen the collaboration among stakeholders regarding PHC for UHC.
During the entire COVID battle, we have actually utilized our primary healthcare system to a very huge advantage.
It's a vision that the implementation of essential package of health services will lay the foundation for a resilient health system in Somalia that can prevent, detect, and respond to disease outbreaks and improve health security.
We can only succeed through a combination of national action and multilateral cooperation. Platforms, including the SDG 3 Global Action Plan, with its focus on every woman, every child, and primary health care, and UHC 2030, can help coordinate approaches and maximize impact.
WHO remains committed to working with our multilateral partners through the Global Action Plan for Healthy Lives and Well-being for All, to support countries to achieve an equitable and resilient recovery and to drive progress towards UHC and the other health-related goals by 2030.
The COVID-19 pandemic has increased how societies value health. We have never been so aware of government actions to protect our health and well-being. Yet, too often, People's insights and lived experiences remained unheard in government's decision-making. Governments must make a targeted effort to change this. Amplifying people's voices in health policy making by using participatory spaces as part of decision-making processes is the way forward. If these spaces are well designed and used regularly, they have a transformative potential to become a potent tool for more responsive and implementable policies. There are many ways governments can engage with the population to capture their needs. Mechanisms such as open forums, citizen juries, consultative meetings, and district health committees with fixed seats for civic and community groups are all methods of engagement. But government resources and capacities are too often lacking to manage these spaces effectively. The WHO Handbook on Social Participation, for UHC, provides practical guidance for policymakers to engage with the population by creating, strengthening, and sustaining participatory spaces. Policymakers must learn how to design spaces to empower people to express themselves frankly. Several examples drawn from countries' experiences are laid out in the handbook on how to do this. For example, define clear criteria to select participants. Be explicit about roles and the added value each participant brings to the policy question. Communicate roles and mandates transparently to all participants. Transparent communication lends legitimacy to each participant and values inputs equally. This is especially crucial for community and civil society groups. Influential stakeholders, such as academia, medical doctors, and government actors, derive legitimacy from their professional positions or standing in society. Therefore, a targeted effort is needed to lend legitimacy to those whose voices are generally less heard. It's time to invest in social participation. It's time to move towards regular and systematic public and civil society engagement for health decision-making. It's time to build a health system that belongs to the people and responds to people's needs, where no one is left behind. Tribal communities residing in the forests of Chhattisgarh have limited access to healthcare services due to the lack of social infrastructure and basic amenities like roads, health centers, and access to running water. The weekly Haat Bazaars of Chhattisgarh are a traditional form of barter system for the tribal communities living in far-flung rural areas. They walk long distances to sell their forest or agricultural produce and buy household supplies for the week ahead. The Chhattisgarh state government launched the Mukhyamantri Haat Bazaar Clinic scheme in 2019. The aim of the scheme is to utilize weekly Haat Bazaars as a platform to take primary healthcare services closer to people who need it the most.
गांव पे आए सयान सदनमन आया दीदी मन मुख्यमंत्री हाट बाजार क्लिनिक में मलेरिया जांच और उपचार, रक्तचाप की जांच और उपचार, मधुमेह की जांच और उपचार, शिशुओं का टीकाकरण, गर्भवती माताओं का टीकाकरण, समस्याओं का निदान भी मुख्यमंत्री हाट बाजार योजना में प्राप्त करें।
The health workers can identify illnesses in their early stages in the community with limited access to healthcare, thus empowering marginalized communities to take effective action to avoid disease severity.
महीने में हम लोग 4 हाट बाजार लगता है, जिसमें हम लोग हाट बाजार में आते हैं, जिसमें लोग दूर दूर से कई लोग हाट मतलब हॉस्पिटल नहीं आ पाते, जो मार्केटिंग आते हैं और वहीं पे अपना इलाज भी करवा लेते हैं। तो गर्भवती महिलाएं आती हैं, उनका हम रूटीन चेकअप करते हैं और जो उनका फंडस चेकअप करना रहता है उसके लिए हमारे पास उनके लिए प्राइवेसी भी है, अंदर रूम है, वहाँ हम उनका पेट की जांच करते हैं। जो इंटीरियर से गर्भवती महिला आती हैं, उनका जो ANC चेकअप नहीं हो पाता है किसी वजह से, तो यहाँ पर वो मिल जाती है और उनको यहाँ पर सुविधा मिल रही है।
Acceptance, convenience, effectiveness, and affordability of health services are the key deciders for accessing healthcare. The Haat Bazaar clinics offer all of these and much more.
जो मुख्यमंत्री हाट बाजार योजना के तहत ये 2 कार्ड है हमारे पास अवेलेबल। ये हम जिला अस्पताल या जिला चिकित्सालय मेडिकल कॉलेज ये रिफर करते हैं। और जो हमारा पीला वाला कार्ड है, ये कार्ड हम हमारे नियरेस्ट जहाँ हाट बाजार हम लगाते हैं, नियरेस्ट जो PSC CHC रही वहीं बेचते हैं।
जब से हाट बाजार क्लिनिक का शुभारंभ किया गया है, जहाँ तक हमको हमारी सेवाएं नहीं पहुंच पाती, हाट बाजार के क्लिनिक के लोगों को जानकारी में ये बात आ गई कि इस डेट के दिन, इस बाजार के दिन में हमारी वहाँ स्वास्थ्य प्रदान की जाती है।
Mitanins, also known as Ashas, or community-level frontline health workers, make home visits in the assigned areas.
हम लोग बोलते हैं अगर अस्पताल जाना नहीं चाहते हो तो बाजार में क्लिनिक खुला है, वहाँ जाके चेकअप कराइए।
हमारा जो दंतेवाड़ा जिला है उसमें हेल्थ एंड न्यूट्रिशन सेक्टर है, उसमें प्रगति करने में हमें बहुत सहयोग मिला है और मुख्यमंत्री हाट बाजार क्लिनिक योजना के माध्यम से ही यह संभव हो पाया। जहां पर स्वास्थ्य सुविधाएं पहले पहुंचने में दिक्कत हो रही थी, वहां पे स्वास्थ्य सुविधाएं आज पहुंच रही है। निःशुल्क जांच का लाभ मिल रहा है, निःशुल्क दवाई का लाभ मिल रहा है।
तो परेशान बहुत ये जितना मानसिक था, पैर महसूस था, ये पूरा शरीर सब मोटा मोटा था। मेरे को यहाँ पता चला शुगर BP बोल के, अभी तब से वो दवाई हम लेता अभी तो रखी था।
पहले ऐसी सुविधा नहीं था, अभी अच्छा सुविधा हो गया। हम लोग सब्जी भी बेचते हैं, टेस्ट वगैरह वही बाजार में करा लेते हैं। बाजार आते हैं, दवाई पानी लेते हैं।
Mukhyamantri Heart Bazaar Clinic is a step towards reducing extreme inequities in health by providing health for all.
Access to essential medical products in the Southeast Asia region and beyond.
I am 52 years old and married. We have 2 children who are both working. I have had diabetes for over 20 years. I need tablets to control it and should test my sugar levels regularly. My husband has high blood pressure. The government clinic where we live does not always have our medicines in stock. At times, we have had to borrow money to buy them. Sometimes we skip a dose to make our medicines last longer. My husband tried to buy cheaper drugs on the internet, but these medicines did not work. We have to ask for help. I hope my family can continue to support me.
Asha and her family are not alone. Although access to essential medicines is improved, many people still do not get the medicines they need when they need them. What can countries do? Universal health coverage means everyone everywhere can access the healthcare they need without facing financial hardship. How can we make universal access to essential medicines by 2030 a reality? How can we ensure Asha and others have access to safe, quality, and affordable medical products? National policies designed to increase availability and reduce out-of-pocket spending can help. Procurement can be made more efficient and prices more affordable. Better logistics to reach the most distant health centers. Stronger regulatory systems to ensure quality and safety. Apply intellectual property rules that promote access to affordable medicines. More research and innovation to meet changing population needs. Track trends on access to essential medical products to know if policies are working. Year 2030.
I'm 64 years old. We now have 3 grandchildren. I have had diabetes for over 32 years. I can now test my sugar levels when I need to. Every month, I collect our medicines free from the government clinic. Thankfully, both my husband's blood pressure and my diabetes are well controlled. We enjoy looking after our grandchildren and have a busy life.
Universal access to essential medical products is possible.
Ladies and gentlemen, may I request all of you to gather at your round tables for the start of the post-tea session, ladies and gentlemen.
Thank you so much for the nice
Slides. Oh, that is it. Oh, this one.
Ladies and gentlemen, allow me to invite you back to your round tables as we start the third and final session of the first day of this global conference on digital health. Please have a seat, ladies and gentlemen. Steve. Welcome back, Excellencies, distinguished delegates, and honorable participants. A very good afternoon once again, as we come to the final session of day one, a session on digital health at population scale, technology enablers to the same. Earlier in the day, the distinguished delegate from Bhutan greeted all of us on International Day of Happiness. Trust Bhutan to remember happiness. It is the edifice, the cornerstone of their domestic policy, gross national happiness. Today, we discuss the strategic and the digital enablers to digital health, the technological enablers. If universal health coverage paves the way to the road to happiness, digital health helps us to take the great leap of faith towards happiness faster and more accessibly, more affordably. On that note, ladies and gentlemen, and without much further ado, because we have a very extensive evening lined up for you, allow me to have the pleasure to invite Dr. Garrett Mell, Head of Digital Public Health Technologies at WHO headquarters. Dr. Garrett. Allow me to have the pleasure of inviting on stage our keynote speaker for the evening, Mr. Satyanarayan Gidigunta, Senior Digital Health Consultant from the Regional Office. Dr. Satyanarayan. And on the same note, Professor Vajira Disanayake, Chairman, Sri Lanka Medical Council, who is joining us virtually. Welcome, Professor Disanayake. And ladies and gentlemen, Our next speaker from the ministerial delegation from Australia, Mr. Steve Miller, Director, Health Systems Policy and Rights at the Department of Health, Ministry of Health, Australia, who is also joining us online. Furthermore, allow me to welcome our partner organizations represented by Mr. Mark Landry from the Global Fund, who is also participating virtually, and Mr. Graham Grave of the HL7 Partnership, who is also, as I understand, participating virtually. Am I right? Are all our virtual participants online and ready to go?
Yep. Hello, everyone.
Right. On that note, over to you, Dr. Mahel.
Thank you so much, and it's a real pleasure to be.
I'm sorry, my sincere apologies. I apologize. I also have the pleasure of welcoming Dr. Deependra Raman Singh, Director General, Department of Health Services of the Ministry of Health and Population of Nepal. Welcome, Dr. Deependra Singh.
Thank you so much. It's my pleasure to introduce the session, Digital Health and at Population Scale, Technology Enablers. In this session, we will talk about the key technology enablers, including the National Digital Health Architecture, standards and interoperability, the use of universal health IDs, and really also think through the how, the different kinds of technical support, the kinds of knowledge exchange and collaboration, the kinds of investments in infrastructure, and ensuring that these technology solutions can also be accessed at the last mile. We have a very a panel with a considerable amount of experience behind them, and I'm very pleased to be able to introduce the first of the two keynotes, Mr. G.D. Gunta Jatara Narayan. I'm butchering that, who will be talking about National Digital Health Architecture, but I've also been told to call him JS. And so with a career spanning 4 decades as a civil servant in India, he has served at the national level as Secretary Electronics and IT of the Government of India, and was also the chairman of Unique ID Authority of India, which was the largest biometric ID system in the world. He's also a thought leader in the areas of digital transformation and digital ecosystem architecture. He chaired the expert committee that designed the National Digital Health Blueprint for India, which is the foundation for the Ayushman Bharat Digital Mission. He currently serves as the chief advisor at the World Economic Forum and is associated in the deployment of emerging technologies in health, agriculture, and education sectors. Please, the floor is yours.
Thank you, Garrett. Good afternoon, friends. I think it's a very challenging task for me and the other panelists, to discuss seemingly complex thing like technology in the last session of day 1. Let me, just begin by saying that this morning we have been hearing a lot of very, insightful comments from various speakers, which included terms like integration, interoperability, convergence, partnership, collaboration, person-centric systems, and so on. So what is the common thread behind this? How to make these kind of seemingly nice words come alive into reality? So one possible way is to adopt an architectural view, meaning that look at these things from the lens of architecture. That's what in the next 10 to 15 minutes I'll try to do that in a apparently in non-technical terms or semi-technical terms. Having said that, let me just reiterate the need for an architecture. Why do we? Because very often, at least I have been in the IT sector for at least 2 decades out of my career. So people have no patience for architecture. Let me say, no time, no patience. Those who need to actually take those decisions. This used to be the scenario earlier, but now things are changing. And we are increasingly seeing the transition from, and the need for transition to ecosystems, from system thinking to ecosystem thinking. That is the change of, the environment that we have today, which is, fortuitous for us. Now, in terms of specifics, digital architecture is required for aligning the goals of the health domain with the IT goals, or the other way around, aligning the IT efforts to the goals of the health domain, whether there are SDGs or any other health outcomes that we are looking at. Then also, one key thing is that if you have the architectural approach, we are getting all the players onto the same page. They subscribe to the same architecture, and there is more resonance. There is a possibility of convergence, integration that I started, my intervention with. So with these advantages, if you just look at digital health architecture, I had the privilege, incidentally, to have been the chairman of the committee which created the National Digital Health Blueprint about 4 years ago, and which is the basis for Ayushman Bharat digital mission. So with that experience, some of my comments may be seen in that context, that it's based on the experience from India. Now, if you just see, a large and complex thing like that, you can't be prescriptive in designing the architecture. It can be only recommendatory, as you see. And I've put them in 2 buckets. In fact, this is the NDHB also puts it in these 2 buckets, which is, one is a set of what is called domain principles, which are arising out of the vision or the national health policy. And likewise, in any other countries, it applies the same way. So if you see here, we have, the principles, are kind of guiding in nature, but everybody follows that, those principles, like the rules of the road, so that you don't have any accidents. Number one, you have a streamlined, faster movement of the traffic. So here, a couple of principles I would like to mention here. One is obviously the theme of the conference, which is the UHC itself, can be one of the compelling factors or drivers for the design of the architecture. These are design considerations, you can say, from the perspective of health domain. And also things like, user-centric, need-based, which have been echoed so many times this morning. And one key thing I would like to mention here is the principle relating to think big, start small, and scale fast. For countries which are really beginning their journey, or somewhere in, in the early stages, this is a good principle, that while your vision is really big, your architecture is really all-encompassing, but you start small with the core, or the essential things, minimal things in the beginning, and then you scale, create to scale, design to scale, so that scaling is not a burden or a problematic thing later. So this is, the set of principles in the first bucket, which is related to health domain. And the next set of principles is the technology principles. In a way, indirectly, the speakers this morning have been, alluding to these ideas here. But let me again pick up a few of them and say a sentence on each. First one is, architecture is about building blocks. Identifying those building blocks and creating the core of those building blocks, are enabling to create those core building blocks. So that is the important thing. So it gives us the flexibility versus, compare, the situation where you're talking about, an ERP system, which used to be, very much in thing earlier. Enterprise resource planning, one huge monolithic, platform, which used to be procured, installed, trained, commissioned, and so on. But here we're talking of, Lego blocks, certain Lego blocks with which you can build any structure depending on your need. So that's a very important principle I would like to say. And then also the triple O, open, open, and open, is one of the key principles, which is the open standards, so that we are not getting hard-coded into or riveted to one particular technology or vendor. Then open source and open APIs and open data, wherever it is in consonance with the principles of privacy and so on. So the openness is another important aspect here. And also prioritizing creation of single sources of truth is architecturally very important. How do you design the architecture so that it creates an environment for, especially in a sector like health, healthcare, etc., where you have to be absolutely correct as to what are the facts on which you are basing your treatment or your advice. So single source of truth is really a very important aspect here, where different kinds of registries enable you to achieve the single source of truth. So in fact, Garrett in his presentation in the previous session depicted, what are the various kinds of registries that the WHO itself is, has incorporated in part of its documentation on this subject. So these are the set of principles we need to. It's not that you can just copy paste these principles. It'll satisfy. It'll be satisfying the requirements in all the countries. No, you need to little bit deliberate on these principles and customize or design some principles which are really unique to your country. So that's one point I would like to make. So I will not like to go into actual nitty-gritty of the actual architecture itself, because the context probably doesn't demand. And in fact, the keynote speaker from Sri Lanka is going to delve into some of the details of the architecture. So I'm straight going and talking about only for a couple of minutes on the key building blocks, that is the core building blocks. In the blueprint itself, there are different kinds of building blocks. One is the core, which is really at the heart of the whole ecosystem. And then there are a set of common building blocks which have this similar or same functionality. And there are some reference building blocks, which is a model for people to take and customize on their own. So, but let me not talk about everything, but except the core. It's like a kernel in an operating system, technically speaking. So at the heart of the whole ecosystem. So I'm just mentioning 5 of them, which in fact are the core. If you are able to really build or enable building of these 5 building blocks, you are almost there in achieving digital health for UHC. So one is the universal health ID is a very important aspect here. And you have seen that in India, post this blueprint, etc., now almost 330 million Abha IDs have been created. One common question or a dilemma that comes to our mind when we are architecting systems, which we also did encounter while we were designing the blueprint, is the following: that a country may already have a well-established personal identity for every citizen or resident of that country. Is it necessary in such a scenario to create one more ID only for healthcare? So the top building block is about creating that. And at the end of the day, in India at least, the decision was in favor of creating one more ID as far as health is concerned. Especially, this is coming from the perspective of, avoiding some kind of profiling of individuals, which is a privacy concern, all kinds of concerns about the personal data. So drive us to the conclusion that you need to have exclusive ID. So this could be one of the points which is country specific and needs to be debated publicly, and then a conscious view has to be taken. The second and third, as I mentioned already, Garrett has already mentioned, so I will not like to repeat that. But one key thing is the unified health interface. How do you achieve things like integration, interoperability, convergence, citizen centricity, etc.? One key thing here is artifact or building block is the fourth one on the screen, which is the unified health interface. Define a set of protocols and standards which people need to comply with, so that the whole thing falls in line. As I mentioned, architecture cannot be prescriptive, number one. Number two, it should be federated. It's not that you're going to stamp the same software everywhere or copy the software applications everywhere. And so uniformity versus unification, there is a world of difference between these two. We don't want, through this architecture, we're not advocating uniformity, that you cut and paste or use the same application everywhere. No. Unification, enabling them to integrate or interoperate. They're autonomous by themselves, but they're able to interoperate using this interface. That is the meaning, and it's the most profound of the building blocks is the fourth one, I would say. Last but not least is the personal health record. Even there, countries need to wrestle with a very fundamental concept, or which is the PHR versus EHR, which is preferable. Personal health record, which is controlled by the citizen, and privacy protecting, etc., versus EHR, which could be also in a way privacy protecting, but it is controlled by an institution like a health service provider or an insurance company, etc. So it's a conscious call again at the national level. One has to take a view on this. So these are the building blocks which I thought that in a technical session like this, one has to focus on. Last, the critical success factors. This is my really last slide, which I would say, in fact, has been echoed by several of the eminent speakers before me. So I would only like to mention, apart from this slide, which I'm not going to speak about, but one key thing is the standards. In fact, our representative from HL7, fortunately, or FIRE, is also going to speak. And my feeling is that when we're talking about PHC-centric systems or person-centric digital health ecosystem, when we're talking about, and we have also seen that about 80% of the requirements lie at the primary level, primary care level. This being the case, is there a need for these standards, a light version of these standards, right, to be developed at this point of time using the state-of-the-art latest concepts in this space? Is one point I'm just putting on the table for consideration, so that you need not have tertiary care, all the terminology and other things related to tertiary care in a standard which just applies to the primary care, and primary care in turn takes care of 80% of the needs. So the logical hypothesis is we need to have a light version of all these standards, major standards that we are following today. I just leave the thought for consideration going forward. So thank you very much, and all the best.
Thank you so much, JS. Very helpful overview of many of the factors that have led to the success of using an architectural approach in India that I think we can all learn from. I want to make sure that we have enough time and for people to ask questions at the end of the session. And I want to encourage people to perhaps even think about those questions now, so that we have a chance for maybe a little bit more time than we have in the past for questions. And so I will go on to the next presenter, if that's okay. Give more time for questions at the end. And so I'd like to introduce Professor Vajira Dissanayake, who's going to be presenting current status in Sri Lanka. Professor Vajira is the Dean of the Faculty and the Chair and Senior Professor in the Department of Anatomy, Genetics, and Biomedical Informatics of the Faculty of Medicine, University of Colombo in Sri Lanka. Professor Dissanayake has held many leadership positions in medicine and health system strengthening in Sri Lanka and globally. He is a past president of the Sri Lanka Medical Association and the Commonwealth Medical Association. The other leadership positions held by Dr. Dissanayake include president of the Health Informatics Society of Sri Lanka and president of the Asia Pacific Association for Medical Informatics. Vajira, over to you.
Thank you very much, Garrett. I hope everybody can see my screen and hear me.
Yes, we can.
Thank you. So thank you very much to the organizing committee for having invited me to talk at this meeting. It's a pleasure to be here. I'm sorry I cannot be there in person today. I'd be talking to you not only on my behalf, but on behalf of my colleagues in Sri Lanka, because I think most of them were not able to come to the meeting because of competing activities that are happening in the country. So I'm going to give you a brief current status of where we stand in Sri Lanka in terms of our health, digital health development. So to put things in context, we've like to, as you know, Sri Lanka is a little country of 20 million people, where our challenges are different to that of what we were they were before. We have a elderly population. We have eradicated most of the preventable disorders. We have an epidemic of non-communicable disorders, and so we have aging population with non-communicable disorders, and our kind of challenges are not much different to what is found in Western societies now, rather than the ones where we had a lot of infectious disorders. In terms of our ICT context, there is good literacy, there is heavy mobile penetration, good broadband infrastructure. But for the health sector, the most important thing is that we've got doctors who've specialized in health informatics who are spearheading the implementation of digital health in our country. So to put things in context, I'd like to take you through the different building blocks that we find in the WHO I2 digital health building blocks, as it were, so that we can see where we are. Starting with leadership and governance, we go back over a decade now when we established a National E-Health Steering Committee with the Secretary of Health taking the lead, and that is the highest level, central level committee, which oversees the implementation of digital health in the country. We have several working groups, one on standards, one on interoperability, and one on information security, taking the lead and driving some of the leadership at the highest level. When we look at service and applications, we can see that one of the unique things in our ecosystem, as it were, I will talk about this in a little while. We started in 2008 developing our own workforce on health informatics. There was a focus on innovation in that effort. There was frugal innovation, low cost, highly effective, scalable innovation built on open source platforms. And as a result of that, we've got systems that have been built on these platforms, which have received countrywide scale. And there is a lot of ownership of the Ministry of Health on all of these systems. And so some of these services and applications are listed on this slide, and how they sit at different levels are illustrated on this slide. Moving on, so in our state health sector, which is the predominant health sector in our country, we've got our own EMRs in the health sector, which are all, custom built within the our health system with the leadership of our health informaticians in good partnership with ICT professionals. And you can see the numbers of institutions where these systems have been deployed deployed. So the take home here is that these numbers that I'm showing you basically cover more than 90% of the institutions in our country. And if you look at a geographic distribution of these systems, you can see that they cover the entire country. So there is no, there is no lack of penetration, as it were. The places where there is, the places which appear to be bare are those parts of the country where there is sparse population. Now, the strategy and investment is all aligned. So the Ministry of Health has been working very closely with all the international development partners. And then they have, as a result of that, the investments are aligned with the country's strategy. And therefore, there is good alignment, I think good understanding. All development partners talk with each other and work towards a common goal. And that way, the investments are very well made use of. I mean, this was not the case maybe 10 years ago, but now we see that happening very smoothly. And that is, I think, a plus point that we all see. When we look at Sri Lanka's digital health activities, they align with our health sector master plan and the health information policy and strategic framework. And it is on top of that we have built the digital health blueprint, and then our infrastructure development plans, the human resources plans, standards, and the governance framework which took shape last year in 2022. So that's why I said there is good alignment all around. And then when we look at the infrastructure, while the Ministry of Health is developing its own infrastructure, we have government agency which is called the ICT Agency of Sri Lanka, which is working strongly with the Ministry of Health to ensure that the infrastructure is in place. And then the two dominant mobile providers in the country, Dialog Axiata and SLT Mobitel, are also very much, aligned with the work. And that way, then all that, there's seamless, discussions with the those who are developing the infrastructure, those who are providing the connectivity, those who are providing the funding agencies, and the Ministry of Health working towards a common plan. And then, of course, it goes without saying that we've developed the capacity within the country to, engage and deploy the international standards that enable interoperability. And so therefore, the systems that we develop both within the hospitals as well as in the public health sector are designed to talk to each other and share information. And we are in a process of, breaking down silos, as it were. And people are realizing that that silo mentality is a mentality of the past, and it's a shared future that we should all be looking at. To enable integration of these systems, we've agreed on a personal health number, which is being, deployed and in scaled fashion to all citizens of the country. And then going forward, again, the framework for communication between systems is agreed in the digital health blueprint and it's being implemented. If you look at the legislation, policy, and compliance, the legislation is now really in shape. I'd like to point to the last one here, the Personal Data Protection Act, which is a very strong regulation, built along the lines of the GDPR of Europe. And so we are really, a full implementation of that will come this year. Therefore, the legal background to implement for personal data protection is going to be in place. We've also got our medical ordinance, which regulates the doctors and other healthcare providers. And we are working towards our provider registers and so on. So all of them to be digitized, hopefully within this year, which will further enable us to bring things to stream, as it were. And of course, our National Medicine Regulatory Authority Act also provides for stringent regulation when it comes to medical drugs and devices. Workforce is something that we've been working on for many years, and that is our strength. Almost more than a decade ago now, in 2008, we embarked on a program where we started a master's course in biomedical informatics and an MD in health informatics at the Postgraduate Institute of Medicine at the University of Colombo. The idea of those programs was to develop the critical manpower who would take leadership in the healthcare domain for implementation of what was e-health at that time and what is digital health now, with a focus on bringing health to people rather than promoting the technology, but technology strategically to bring health for people. And as a result of that, there are more than 300 medical officers in health informatics with the masters, and some of them have gone on to do their MD and are now in the process, and some of them have already become consultants in health informatics, serving not only our country, but even WHO and other international organizations. And then, of course, our other programs are aimed at, creating ICT literacy among other healthcare workers. And of course, within our public health system, we also have the ICT professionals working on different levels. So we are very focused on capacity development, our own capacity development, so that they would be able to take things forward. And I know those of you at the WHO and other organizations who worked with those capacity that we have developed would vouch for their capabilities. Just to illustrate that a little bit, because I think this is this is the cornerstone of what we've done. We've got in the University of Colombo, in the Postgraduate Institute, a specialty board which is delivering these programs. We work strongly with the Health Informatics Society of Sri Lanka at the beginning, now with the College of Health Informaticians, the consultants. We had a strong partnership with University of Oslo at the beginning. And of course, the Ministry of Health. The ministry was sending us medical officers who did the masters, then went back and started developing this ecosystem that I've been talking about, because 10 years ago, we had nothing, but today we have all these systems that I alluded to earlier, developed through these medical officers in health informatics, working strongly with the ICT community, and that's being deployed across the country. Then they come back and do a MD with us, and after further training, they become board certified health informaticians. And I think we were the second country after US to have such a program where we were developing board certified health informaticians, doctors who were competent to lead ICT implementation in the health sector. A picture of a group of them a few years ago before the pandemic. Our numbers have, as I said, grown even further. I'm not going to discuss this. This is the entire ecosystem that is developing, and it is also captured in our blueprint document, which is on the website of the Ministry of Health that you could look at. And then, of course, that has now translated into a 10-year roadmap, which we are working very strongly with all those international development partners that I mentioned to you, or which I showed you on the slides earlier, working towards one common plan. And that's, that's been our strength. So I've taken you through all these building blocks and how we've slowly, over a period of about 10 to 14 years now, built on them and taken us to a different level, as it were. And I think, as I said earlier, the strength is the indigenous capacity that we have developed. So with those words, let me finish with a few acknowledgements. The Ministry of Health, the Digital Health Steering Committee, the eHealth Steering Committee headed by the Secretary, that is the cornerstone. Then we have the Directorate of Planning in the Ministry, which drives the national level plans. Then we have the Directorate of Information, which is the main implementation arm, working closely with the international development partners, the Specialty Board in Biomedical Informatics at the university, which is strongly providing the capacity development that is required. We are in the process of setting up a unique education environment in the Faculty of Medicine in the University of Colombo, where we are creating an interoperability environment for all these systems that I showed in a previous slide. And then, of course, the Health Informatics Society of Sri Lanka, which has been driving the soft, advocacy, as it were, for digital health and for over 2 decades now, and our consultants taking the lead now through the Sri Lanka College of Health Informatics, taking the lead both academically and professionally, advocating for digital health information implementation in the country. So with those words, ladies and gentlemen, let me thank once again the organizing committee for inviting me to make this presentation. I'll be happy to take a few questions at the appropriate time. Thank you very much.
Thank you so much, Professor Vajira. Thanks for providing an overview of where Sri Lanka has come and really used the WHO eHealth pillars to be able to provide a context for the progress that you've made over the years. Thank you so much. I think we will proceed to ensure that we have all of our virtual participants be able to also present. And so I'd like to introduce and give the floor to Steve Miller from the Australian Government Department of Health and Aged Care. Steve Miller, the floor is yours.
Thank you so much, and apologies for not able to be with you today. I look forward to coming in the next month to Goa to join the G20 conference, where there'll be a large focus on digital health and progressing this important initiative. As I said, my name is Stephen Miller. I'm the Director of Health System Policy and Human Rights within our International Strategies branch from the Australian Department of Health and Aged Care. Today, I'm here to speak to you about Australia's health system. I believe we have some slides. I'm not sure if they're available. Otherwise, I can share my screen if that's easier.
We have the slides. And
thank you so much.
Clicking them through.
Great. Thank you so much. Yeah, so I'm as we're waiting for the slides, here today to talk about the Australian health system, how we've utilised digital health solutions, and what we feel is needed to move forward as a means to share with colleagues at the conference today. We see this as a really valuable opportunity to share how we are working to strengthen our health system to enable universal health coverage through the strategic use of technology. Next slide, please. Before I get into the details of our digital health system, I just wanted to give you a brief overview. Similar to our Sri Lankan colleagues, we have a federated system, and Australia is proud through this system to have strong and equitable healthcare, which is a complex mix of different service providers and a range of healthcare professionals from many different organisations. The responsibility for both funding, managing and regulating the Australian health system is broadly split between the federal government and subnational governments. And all levels in government in Australia need to decide what is funded and how much funding is required to allocate to the different areas of our healthcare system. Next slide, please. Our previous Professor Neke talked about the leadership. Australia's National Digital Health Strategy is building on the achievements of our previous National Digital Health Strategy. This was released in 2017. We have the Australian Digital Health Agency, and they are currently drafting Australia's next National Digital Health Strategy. And this strategy sets an ambitious agenda to transform digital health in Australia, and it solidifies digital information as a bedrock of high quality healthcare. It underpins and coordinates work that is already happening between governments, healthcare providers, consumers, innovators, and the technology industry. Next slide, please. One example and central to Australia's shared success in driving digital reform has been the strength of our partnerships. The implementation of electronic prescribing exemplifies the importance of strong partnerships across our health system. The Australian Digital Health Agency and the Department of Health and Aged Care partnered with peak industry, clinical and consumer bodies in 2020-2021 to bring forward e-prescribing in Australia. And this was done as part of Australia's government's National Health Plan for COVID-19, and it was done through a co-design manner. A solid foundation for safe and scalable delivery of electronic prescriptions began by identifying key stakeholders. It was established early on that communication between local pharmacies and prescribers was critical to ensure both were ready to both issue and dispense electronic prescriptions. By the 30th of June 2021, almost 11.3 million original and repeat prescriptions had been issued. More than 98% of the nation's community pharmacies had adopted electronic prescribing, and more than 57% of the country's general practitioners were generating prescriptions. So as of February this year, more than 114 million electronic prescriptions were generated, accounting for over 17% of our pharmaceutical benefits scheme and repatriation PBS prescriptions dispensed across community pharmacies in Australia. Essentially, in a nutshell, without co-design, the collaboration across the entire healthcare industry, e-prescribing would not have been possible. Its rollout set a new benchmark in government, industry, consumer and professional collaboration in co-design. In short, the government regulated, the agency coordinated and facilitated, industry innovated, and the healthcare professionals advocated for safe, effective solutions and implemented them in clinical practice. Next slide, please. While digital technology brings many benefits to consumers and providers, potential risks, particularly during the implementation phase, need to be considered. We need to embed security systems to protect individual health information at the core of any initiatives. JS talked about that as one of the key tech and domain principles in his presentation. We certainly agree with that. Implementation of any initiatives without strong security considerations creates serious vulnerabilities to both individuals and health systems intended to support them. And additionally, failure to secure systems can compromise current and future initiatives and cause individuals, organisations and government to lose confidence in digital solutions. In February 2023, the Australian Digital Health Agency launched the My Health app, which provided consumers with access to their own My Health record, which is Australia's national electronic health record system. The process of continuous engagement with consumers meant the app can be adapted to address consumers' wants and needs. We only recently announced that we will be mandating clinicians to upload pathology and diagnostic imaging results to the My Health record over the coming year. One thing to factor, though, is digital inclusion and literacy are a key building block for digital health globally. In parallel to digital advancement, Australia recognises the need to ensure that those who use technology also have the skills and capacity to use it. This is particularly, but not exclusively, important for consumer-facing systems, and it's essential to narrow the digital divide within one's own country and increase equality. Next slide, please. Moving forward for us, Australia has increased the focus on digital health interoperability and has developed its first national plan to advance this area over the next 5 years. The plan includes 44 actions under 5 priority areas that were agreed following 2 years of extensive consultation with over 150 stakeholders. Healthcare interoperability supports safe, secure, efficient and quality care. It involves an ecosystem of connected providers that conveniently and seamlessly share high quality data with easily understood meaning throughout the health system. And final slide, please. Going forward, enabling and adopting digital health innovations to achieve universal health coverage requires robust digital health architecture, including legislative, policy, and clinical guidelines and agreements. In developing our own digital health architecture, 4 key change enablers were identified so that digital health can expand, operate effectively, and at scale. All 4 need to be present and working together to drive progress and achieve the whole of the strategy's ambition. 1, inform consumers and carers with strong digital health literacy. 2, digitally ready and enabled health and wellbeing workforce. 3, secure, fit for purpose and interoperable digital solutions. And finally, settings that cultivate digital health adoption, use and innovation. Globally, health system structures can differ significantly, and our experience may not be easily translated to other country settings. However, we believe that with these enablers are key for developing digital health capabilities across settings. In going forward, developing agreement on standards, implementation will play a large role in the adoption of emerging technologies, as will efforts to develop digital health literacy, creating collaborative digital health ecosystems at all levels and embedding security to establish trust in digital health solutions. We thank you, the organising committee and India, for hosting this event and the opportunity for Australia to share our thinking on digital health. Thank you.
Thank you so much, Steve Miller. Thank you for providing us an overview of the digital health strategy in Australia and some of the key lessons learned and change enablers that have been part of your successes. I'll want to transition now to Dr. Dipendra Raman Singh, Director General, Department of Health Services, Kathmandu, Nepal. Please, over to you. The floor is yours.
Thank you. Thank you very much, Mr. Chair. Excellencies, distinguished dignitaries, keynote speakers, delegates, ladies and gentlemen. My heartfelt gratitude to the organizing committee for having us here. Indeed, it's our privilege to be here, to have this opportunity to share something about digital health in Nepal. Digital health is acknowledged as an inevitable approach to achieve universal health coverage, quality improvement, improving efficiency and effectiveness of health system, changing people's life. And it is also important to achieve health SDGs and getting better in universal health coverage. And it is being the trust of the health system in Nepal. Distance, geography, cost, and time are major factors that limit the service access and utilization countries like Nepal. The out-of-pocket expenditure is around 57%, and only 49% of households have access public health facility within 30 minutes. Still, 11.3% travel more than an hour, with higher proportion of population being in lowest wealth quintile, rural residents and remote habitats. This shows the importance of digital health, which is required to strengthening health systems and public health programs, increasing equity in access to health services, strengthening health information system, and increasing the efficiency. So let's go back to the earlier days when the digital technology was formally introduced in Nepal in date back 1971 for the purpose of processing population census records. From that point of time, there has been a lot of developments. Wider IT penetration has been observed in health around 1997 when integrated health information system was developed. Currently, the availability of communication equipment in the health facilities, which is increasing in fast pace. Similarly, at the population level also, the households having computer, having internet access, and the internet penetration reached in certain percentage, which is really very outstanding in the current context in Nepal. The mobile SIM distribution was another fact which has made whole system think we can scale up in digital health. Similarly, the expansion of social media and people's overwhelming engagement in this. So digital health and population scale, these are the enablers in our context. So for the policy environment is also there as an enabling perspective. To cite some, National Health Policy, National ICT Policy, Digital Nepal Framework 2019, and similarly the e-health strategy and roadmap for ISMIS 2022, Nepal Health Sector Strategic Plan 2022-2023 are some of very important policy platforms. So Ministry of Health and Population is ready to embrace the initiatives in digital health, having all these periodic plans, health policies, digital Nepal framework, and in addition, the global digital health strategy, which are really enabling the initiative countries like ours if like to initiate. So Similarly, there is expansion of networks, the digital devices in the market, the increasing awareness and demand on digital health by the public. Similarly, increasing engagement of academic institutions, private sector developments, and similarly having the competitive markets and health sector reform exercises and demand for high efficiency from public perspective. And similarly, emerging solutions are there for digital health and increasing global and regional support and conducive environment. Similarly, the digital friendly population and academias who are warranted to produce IT equipped cadres and availability of open public goods are some of the enablers we have. So these all keep our ambitions high, having good governance, proper institutional setup, digital tools to improve the efficiency of health service delivery and program management. Similarly, reaching to all citizens under universal health coverage as mandated by constitutions, laws, and policies, making health information system smart and efficiency, and making it accessible as relevant. Similarly, the electronic health records for health data sharing among health facilities, data sharing beyond the health sectors, developing competitive market for digital innovations for health, and building capacity of service providers, recipients, and advancing the digital system in line with the regional and global standard, and similarly better response to health needs during emergencies, and increasing investment in the digital health and resources shared by multiple purposes were also our aim at this moment. Similarly, to fulfill these aims, there are certain actions we have already done, like the e-health strategy 2017 and roadmap 2019. Similarly, implementation of these interventions outlined in this roadmap, timely, and development of roadmap for integrated health information management system in line with digital health, and institutions set up in the ministry, along with provision of IT staffs at various levels of health facilities and online registries of CRBS. Similarly, use of digital devices in health services, and most importantly, the health facility registries developed for the interoperability and using digital solutions for community level services. Similarly, the digital health strategy interventions 2020 to 2030 is also some of the important actions we have already taken for the digital health governance, digital health infrastructure, digital health services, and standard interoperability regulation and change adoption. So with this, we are also thinking of having next generation health facility, digital health infrastructure, electronic health record, as I already told. So e-maternal care and emergency supplies by drone and telemedicine and virtual care are in the line. So the national digital health architecture, for it, the Ministry of Communication and Information Technology has already developed enterprise architecture 2.0 for all kinds of digital systems to follow. Similarly, the health facility registry, ICD-11 and HR registries are there as per some of the important standards and interoperability platforms. Regarding the universal health ID, the national ID is already in rollout phase, and there are some primary unique identifiers for individual patients which are in process of development. And the quality assured technical support, procedural mandatory requirements are there by Department of IT to fulfill by all the digital initiatives to ensure quality and technical support. Regarding knowledge exchange and collaboration, Nepal is building collaboration with local, regional, and global key players, organizations, private sectors, and special thanks goes to all the EDPs who are working in Nepal for digital health planning, training, and critical capacity buildings. Also for technical working groups which has been constituted, and the general support to enhancing their capacity. There is resource documents are provided by WHO and partners for knowledge building, and similarly collaborations with partners which has been enhanced in these past few years, and focal points are assigned in the Ministry of Health and Population supporting agencies. So We are also working for the investment case for improving digital infrastructure and developing a capacity structuring to proper investment. Similarly, certain initiatives to process health services and health insurance coverage to over 3 million population in foreign employment using digital health is going on. So in nutshell, Nepal is keenly observing and learning closely how to accelerate the implementation of connected digital health initiative and intervention as a cornerstone of building PSC-oriented and resilient health system, and how to unlock the potential and delivering and sharing digital health solutions in an ethical, safe, secure, reliable, equitable, and sustainable way. And similarly, how to invest, develop, and share digital technology following principles of transparency, accessibility, scalability, replicability, interoperability, privacy, security, and confidentiality. Similarly, to establish the strategic enablers and technology enablers required for implementing digital health at population scale. And these 2 days, we thought is the important days for learning more, institutionalizing digital health in our context. Thank you. Thank you very much.
Dr. Singh, it's a real pleasure to hear about the ambition of the vision of the Nepal government, and also the successes and different policies and activities that you already have underway. I think it's very exciting, and I think this is a very important 2 days as well. So I think we'll all have opportunities in the side meetings, hopefully, to get to know one another and be able to learn from the different experiences that we've all had. I think we have time for, I'm going to ask so I think we'll move over to our invited speakers, the partner organization invited speakers in this next session, and I'll ask them to be as brief as they can. The first of the partner organizations is Dr. Mark Landry from the Global Fund, and I will hand over to the floor. Hand over to you, Mark. The floor is yours.
Great. Thank you, Garrett. I hope everybody can hear me well. Could I have a sound check?
Yes, we can.
Excellent. Thank you. Thanks, Garrett. It's my pleasure, and what a wonderful opportunity. I'm grateful to the Ministry of Health and Family Welfare, Government of India, and WHO for not only convening this important event, but also for the privilege to participate on the program. And just to express, having been able to listen in much of the day, hearing just some tremendous experiences. And I think we learn best from learning from each other. Of course, as the host country has had the privilege to convene, we've heard a lot about the digital health journey of India, but I appreciate, of course, the many examples from the other countries that have been participating thus far as well. And I have to say that, as important as this session is on the technology enablers, I can't emphasize enough the previous session around the strategic enablers, particularly those areas that will help operationalize the digital health strategies and action plans that are being developed. With that, this is, I think, not a slide that would be unfamiliar to anybody in the room, but just to give you some Global Fund context as I delve into some of these technology enablers, that last year we had our 7th replenishment. We mobilized over $15 billion from our governments and other philanthropic entities and other private sector donors. And from past experience, this is for a 3-year grant making cycle. And in our last grant making cycle of 3 years, there were over or close to $300 million of digital health interventions and investments in digital data systems, primarily for programmatic support for HIV, TB, and malaria eradication, but also health systems, particularly health management information systems. So we've seen this trend, and in the 3 year previous to that, it was more than $200 million. We're starting a grant making cycle again this year. So requests are coming in from countries, and we're seeing a transformational shift, if you will, of moving from investments in the production of the data or the deployment of these systems and technologies towards more consumption of the intelligence, the data, the use of the indicators, etc. And this is very significant. And this comes back to many of the investments that are needed, particularly these technology enablers to address and mitigate these particular issues on screen. So we just finally completed endorsement through our management structure of our Global Fund Digital Framework. You can see on the left, that is a snapshot of our 6-year current Global Fund strategy from 2023 to 2028. And we have laid across that a number of digital objectives that I think resonate quite well with the intent and expected outcomes of this conference itself. And I think from some of the passion that was expressed, particularly in the opening session, welcoming remarks and others from Dr. Poonam Khetrapal Singh, from the Honorable Minister, address from the Government of India, Minister of Health from Government of India, Professor Alan Labreek from WHO, etc. That it's time to move from these strategies towards action to achieve towards the right, more equitable access to services and improve overall universal health coverage progress that is needed with these digital interventions. And so this has become an organizing framework for our digital health investments. And the work that I'm particularly focused on has been around operationalizing this at the country level. And this is just a little snippet insight into this particular initiative that we've launched, where I've just bolded in red just some of the aspects that we recognize that are important from a technology enabler perspective. And we've heard many examples now of the importance of this architecture blueprint or roadmap to really drive strategies and action plans into action. And I'll speak to some country examples of that in just a moment. But we're also in this session, one of the topics that were listed were, how do we recognize the importance of good quality technical assistance and the use of networking and how countries can learn from one another. And we've been very pleased to observe and see the success of many networks, including the Asia Health Information Network that was on the program already. But that kind of peer-to-peer learning and knowledge exchange platform is something we want to enable and strengthen in Africa as well, including the use of some of the experience from Asia around the use of these standards and interoperability labs as a way to provide regional support from the experience from countries through that platform to help other countries through that peer learning approach. So this is part of our work, but it's embedded in the importance of both, as I said, the strategic, but also these technology enablers. And one of the things that both Garrett, Mel, and Alan Labreek from WHO mentioned in their remarks is a renewed interest and focus on the use of maturity models, or the way to measure performance of digital health, both as a benchmarking tool, but also for a way to communicate gaps and challenges that countries might be facing. And we're embracing this at the Global Fund. both from a perspective of building on the Global Digital Health Index as a way to understand the current situation and status of digital health foundations, but also we have a number of global fund priorities that are digitally enabled that we are focusing attention on, particularly around the security, maintenance, sustainability, and scalability and functionality of our digital data systems and other digital health interventions. And importantly, another one of our priorities is more data agility and how we eke out faster, more meaningful intelligence from the information that's being captured so they can be utilized for better decision support. Now, these are a couple of graphics that I'm taking liberty to strategically reuse, if you will. On the left comes from the Digital Implementation Investment Guide of the WHO. And in red, I've highlighted again, just a couple of these building blocks or pieces of this progression that are important for this session. And to emphasize again that, any one of these aspects or components, we've heard discussion around the WHO ITU eHealth Strategy Toolkit, and Dr. Vijaya Daseniake, for example, used that as a way to frame the journey in Sri Lanka. These are all important. And then on the right, you can see from, going from strategy to scalable, sustainable, durable digital health assets being optimized in country. There are a number of important step-by-step capacity development aspects that are particularly important. And here's where I just want to take a moment just to share 3 country examples. First is just building on what Dr. Vajira mentioned from the Sri Lankan example. We have a very large grant with Sri Lanka through our debt to health swap agreement with the government of Germany, where the intent in Sri Lanka was to expand the hospital health information management system to another 100 facilities. But we took pause, and the recommendations were to step back, develop the architecture blueprint, develop interoperability plans, procurement plans, capacity development plans, to ensure that these investments are part of an ecosystem of digital health interventions and investments. And I think another key feature that I want to amplify from what Vajira said was, in fact, it has been a stellar example of the way that the Ministry of Health has worked with the ICT Authority in Sri Lanka to provide services and shared resources to enable that to accelerate and be developed rather quickly. The second example, in moving up this capacity development progression or journey around health information exchange. Later in May, Malawi will be hosting the Open Health Information Exchange global community meeting because they have committed to this open architectural enterprise architecture framework, which we find is an outstanding mechanism to create a way to visualize the need for systems to interoperate and use reusable assets such as client registries, unique IDs, health facility registries, etc., using an interoperability layer or a platform that can be able to exchange messages, both the content and the metadata. And they're using, for example, the Open Health Information Mediator to do that. And it's a good example of building on their current assets and creating an interoperability context to increase the data exchange and utilization. And then finally, just to share an example from Myanmar, which to highlight the importance of unique identifiers. And the Global Fund several years ago supported their investment to develop a master patient index, which was needed because of the redundant set of systems and applications that are used in HIV, TB, and malaria, where patients were being tracked with different identification schemes. And this master patient index has become a core digital intervention or asset that is helping them progress towards the use of electronic medical records. these are all important, but at the end of the day, it's about how this information is utilized and how these investments in the digital health infrastructure and info structure can really enable a better utilization to deliver better health outcomes. And so with that, I wanted to just highlight in just a couple more slides. We just launched in Kigali, Rwanda, back in December, a new digital health impact accelerator fund where we've been able to mobilize through a public-private partnership mechanism significant resources to help catalyze many countries to develop their digital architecture approach, thinking about how to invest more strategically in their digital infrastructure, promote interoperability, and ultimately to improve better strategic use of their digital health, particularly at the last mile. And community level digital interventions are a key focus of that. And this Digital Health Impact Accelerator Fund is particularly focused on exactly what this session is about, is recognizing that through investment in connectivity, cloud services being hosted with redundant on-prem services as well, utilization of reusable assets, as I mentioned, through different terminology services or the use of health facility IDs, master facility lists, community health worker registries, unique IDs, et cetera, to really deliver more integrated patient-centered care. But you can see at the bottom, again, I think I would be remiss without emphasizing the importance that we're emphasizing and want to fund and support countries to also invest heavily and more effectively in their digital and data governance mechanisms. And at the heart of the investments we want to see more of in this next funding cycle is in long-term capacity development approaches. And again, I just wanted to express appreciation for Dr. Vajira in a different context, because I think in the Southeast Asia region, the health informatics training program and the way to develop that perpetual capacity locally within country is an example for many to learn from as well. So thank you very much for allowing me to participate in this conference, but particularly in this session. And I look forward to any further discussions online or offline going forward. Thank you again.
Thank you very much, Mark. Now I'd like to hand over to Graham Grieve, who is the Fire Product Director at Health Level 7 International. Graham, over to you.
Well, hello, everyone. It's a pleasure to be here with you, although it would be a much greater pleasure to be there with you rather than to be here. And hello, Garrett. It's a long time. And I'm sure I saw a couple of other friends, at least in the audience, when we briefly saw them. I would really love to be there, but it's just not possible. So fire is a real change of pace compared to the other presentations, which have been more strategic. Suddenly we're down the weeds. It's lovely. So fire, FIRE doesn't matter what it stands for. We just picked a unique acronym to make us easy to find. Came out of my belief that healthcare has broken processes. It's not that people don't try. People everywhere, in every country I've been, try really hard and make their own bit the best they can. But it's really hard to have a system level view and not conclude that we have broken processes. I could see back when I started working on FIRE that other industries were being transformed, and often IT enabled the process transformation. But that same process wasn't happening in healthcare. It didn't matter whether I looked in the first world and the rich countries or the other countries. The business of healthcare is very sedentary. It doesn't change quickly at all. And IT standards that integrated business to business context and health to health, but also consumer to business, which I believe personally was critical to enabling the transformation of healthcare, they didn't exist. They allowed the standards to integrate those. And even the ones that did exist, not implemented very well. I've been my bread and butter for 20 years. I knew about that. Now, Because there's lots of other chain blockers that we've been talking about through this session in the last about what the actual problems are. And I'm not under any, illusions here. Digital health is not a solution to anything. It's just a tool that gets the IT and the information management out of the way so that people can solve the real problems. But at least that bit I could work on. I could actually take on the information management problem. So I did. And we created FHIR. So really key thing about FHIR is open. And it's two parts for me. It's first, and more importantly, it's open community. Our goal is to make it easier to exchange healthcare information in all of its forms, in all the contexts, in all the uses. And sometimes the question we get asked is actually, what's not healthcare? And that's a good question. What's not healthcare? And so it's a bit hard for us to keep our scope limited. We have open participation. Anyone can participate. You need to be no member of anything. You need to pay no money. You need to be in no particular country. You just need to participate on the open, web. And it's led by HL7. I work through HL7, and we're deeply connected to the worldwide health community. We are not sufficiently deeply connected to the lower middle income countries. It's partly because of history and workforce, and partly because of the way HL7 works. We are really keen to collaborate through WHO to see if we can transform the way we relate and help better those, more countries than we currently are. But for me, it was really key that it's open. And that was a real change for healthcare standards. And I really hammered that through, and because I wanted the equity that we could create to be created. And then the community gets together and we argue about how to solve the problems we have identified, and anyone can bring problems to us, new problems, and we figure out how they're going to be best handled or least worst handled, and we describe that in a formal standard, publish that as the actual standard at hl7.org/FHIR. It's a web API, and we very much focus on continuity with existing standards for healthcare systems around the world, and we publish that. There's two parts of what FHIR is. And I'm not going to bore you with some of these other slides since Garrett asked me to move things along. But I do want to focus again on the freely available. What the FHIR community does through HL7 is take everybody's IP that they give us, ideas for how to do things, and collate that and curate that and publish that and a public, open, Creative Commons public domain, which is no rights reserved. So you do whatever you want. And it's important to me that anybody, anywhere in the world, can do whatever they want. They can translate it, they can compile it, they can use it. There's no restrictions. And we did that to enable anybody, no matter how much money they do or don't have, to make use of the work. And it creates this really interesting dynamic where people will give us their best people, their best IP, their best ideas that relate to working with other people so that everybody can have it. And so in effect, we're all richer because we all have it. And that sort of open it creates a virtuous circle. And for me, that's a key part of our collaborations. Now, HL7 is where I work. Health standards. And we collaborate with many organizations. The WHO is one of our primary collaborations. We're still working on building that and making it bigger. Terminology and health guidelines and institutional frameworks, and here we are. We would love to work with your national standards organization, health authorities, and we do all around the world. And the way we do it as a standards organization is a collaborative process. How do we build your capacity? Now, we've heard quite a bit about workforce capacity, single biggest issue in every single country I work in. Amazing to hear Sri Lanka say it's not an issue. Wow. And so we want to help you build local capacity in your workforce, your development, your business analysis, your policy arm. It's our job, and we have a bunch of ways to help you develop local community, which become part of our community, but serving the national bodies for the countries that they're in. And we're keen to turn most into almost all, actually, that's my goal. We also work with vendors and care providers, and it doesn't matter whether they're rich, big, huge companies, or very small 2 or 3 people companies. We don't care. We just want to help everybody make better use of the standards and for the standards to better serve their purposes. And we work with other standards organizations and professional organizations. I used to list the actual collaborations we had, but there's hundreds of them now. And we want more because standards don't solve anything. We're here to help you solve your problems. And so here's a bit of a sense of hits on the tests at the public test service from around the world. You can see we've nailed Europe, we've nailed America, but we've got a lot of work to do in the rest of the world. And I'm here hoping that this serves that. We would really like a big dot in your country from your local community, developing out solutions for your national public health or, health services. Let's cares of business in America. Who cares? It's America. Now, what I really wanted to do when I set out to do FHIR was to reduce the cost of interoperability. Fundamentally, this is an economic problem and about scalability of workforce and solutions and reuse and reliability. And it worked. In the USA, it worked at least. And we can reproduce this, I believe, in other countries. But basically, if you wanted as a hospital to provide data directly to the patient, when I first started in 2010, I priced it was $150,000 US for a typical total cost of ownership for that kind of service through a representative of a patient. $150,000 US. That's a pretty big amount of money, especially given there are hundreds of companies spruiking their wares for personal health records. USA couldn't afford that, forget the rest of the world. And so we worked with the government and the EHR vendors in the United States, and we're doing the same project in other countries now to define a public API for patients to get their own clinical data. And the secondary goal for applications is to use the same API for their internal use. And we built an industry specification. The government then turned around and said, okay, everyone, you're going to implement this. And then Apple picked it up and used the standard as published, which is pretty unusual for Apple. And basically, hospitals register with Apple for free. They get the software, the capability for free. All they have to do is pass the testing process, which is pretty much pro forma. And so they have a 90% reduction in cost. That's what the standards process is about, and it worked. And we can reproduce that in other countries, leveraging the same work. And we would love to do that. Now, and so we reduce costs, so that's fair enough. But FHIR is not a silver bullet. It's a good technology. I love it. It's my baby. But it's only in the base specification, only captures what everybody agrees to. Everybody in the whole world. In any particular country, in any particular language, in any particular institution, you will agree about more things than everybody in the world does. And so you need to build further agreements on top of it. I got this fantasy. Some fantasy that somewhere in the world, we'll get every single health IT person together and we'll stick them in the Maracana or the Mexico City Stadium where it's big enough for us all. And we'll surround it with military and say, you can come out when you agree. That's not going to happen. So we'll continue to have to build layers of agreement because, that's the reality of the healthcare industry around the world. But our focus has always been, and that's a strong focus for FHIR, is about building community. And so I could talk about the technical guts of FHIR, the stuff developers love. But really, from the beginning, for me, it's been social engineering, not a technical problem at all, around building a community. And we need to build a community in a country, clear strategy and architecture so that everyone knows where they fit and they know how to get going. Lots of countries coming to me saying, we really want to use FHIR, but we don't know where to start. And no one will start because everyone's dependent on everyone else. Building education, formal education. In most countries I know of, the real problem is not offering the education, but getting students to choose to take it. So That's what I see around the world, but and also professional education for postgraduate, post-work education. Learning and testing opportunities, we run those in public, and then we help people develop their own local specifications to build those extra agreements. That's the community focus for us. And I wanted to, JS asked about a simpler cut of the standards for consumer access. It's a pertinent, very pertinent question. In the 5 specifications for all health, really complicated stuff, decision support and medication administration with full MAR, it's a nightmare. That stuff's really hard. There is cut down takes on patient access to data that are suitable for international and LMICs adoption, and there's a pair of them. The International Patient Summary, which is an agreed set of content building blocks for the core common summary, clinical summary of a patient, and it's portable, but it focuses on the content. And we also have a partner specification, International Patient Access, that focuses on getting access to data. And they're actually separated because some countries will not easily be able to sign on to patient summary, but can easily sign on to patient access, and some countries vice versa. But we recommend, particularly if you don't have a well-established health ecosystem, that you adopt both as the basic method for interacting with patients. International Patient Summary, International Patient Access. And we're starting to see countries really work on that pair. And we're happy, very happy to help. And the big consumer companies like Apple and Samsung are on board with that pair. And we will start seeing a health ecosystem built around those. I believe we will anyway. But that's the answer to JS's very reasonable question. Now, this is a personal thing for me. Really getting data to patients, wacky-doo, doesn't really help them. What we need to do is get them services, but they need the data first to get the services. I just wanted to point out there's a problem with this. And I'm going to see how quick I can do this. If you take a system, this on the left, a clinical system that's got a rate of adverse events, and then you change the clinical process to try and reduce the adverse events, hopefully you'll do that, a net reduction in adverse events. But the new process, which is always more systematic than the old, has a bunch of things that it causes. Now, in my experience, the things that it causes are new adverse events. They happen less often, but they're more systematic and they're more dangerous. And there's one particular feature of systems in the real world. Every information system I've ever dealt with has degeneracy in it, and the users know how to deal with the degeneracy. But when you connect 2 clinical silos, you're about to find out about the mismatches between the degeneracy assumptions, and existing understood and tolerated problems become safety issues, and you need a process for dealing with that. But the hardest problem here is that when you bring the patient into the system, you just brought someone who has no idea about the understood and tolerated degeneracy problems and put them in the middle of it. You need a good management process for dealing with the consequences of that for the patient. And I've seen this happen in country after country where we got the patients their data and they discovered that actually healthcare has lots of problems. So that's a really important part of bringing the patient into the system, is having a process for dealing with all of the information problems that will surface. I just want to, I'm nearly done, Garrett. For me, the real thing that where this delivers is when you can start dealing with integrated care. And that means the system as a whole is running consistently for the patient, not doing different things in different places. But every single system I've seen anywhere in the world that's doing anything for the patient, that's what's happening. We've got services built into FHIR, technical services for distributed care plans, virtual clinical reviews, communication between consultants over and doctors and nurses over the care plan. What I'm looking for is countries to actually take advantage of those and start working towards those. But it needs systemic cultural change, which is, as I said at the start, the real problem. I'm going to stop here. Our goal is to disrupt healthcare by providing better standards and then building a community that makes it easier to, to significantly reduces the cost of data exchange and building open knowledge. And this is happening more widely. And for me, that's a key part of what it means to build civil society. And so I encourage all of you, no, you're already doing this. I encourage all of us to encourage everybody around us to spend some time in their life contributing to open communities and being part of civil society. And thank you for listening. Back to you, Garrett.
Thank you so much, Graham. Thanks for providing us an overview of the FHIR ecosystem, the standard, and also sort of the focus on ensuring there's a reduced cost for interoperability and how you've built a community around the standard, and that has led to a number of different positive outcomes, including reduced costs for personal health records, as well as the empowerment of patients and the broader ecosystem in general around data exchange. Thank you so much. I know we're running over time, so I want to, at this point, I'd like to thank all of the panelists who have shared with us their enablers for technology transformation, including JS, Professor Disanayake, Stephen Miller from Australia, Dr. Dipendra Raman Singh from Nepal, Mark Landry from the Global Fund, as well as Graham Grieve from HL7 International. With that, I'd just like to give everyone a hand and thank you so much.
Thank you very much. Thank you very much, distinguished panelists, ladies and gentlemen. We come to the conclusion of the operative part of the first day. Allow me to request all of you to assemble just outside this hall in about 5 minutes' time. For those who have volunteered to make the field visit to the Ministry of Health and Family Welfare's office, at 7:15, we assemble here again for the cultural event and dinner. Ladies and gentlemen, on that note, thank you so much for your participation in this path-breaking conference on digital health. Ladies and gentlemen, thank you.